don't see anything, it's a little bit crenated edges, then you are dealing with a herpes. You have to deal with the herpes, systemic and topical antiviral treatment. Then coming to the bee sting injury, this is very common in our place. Farmers, they come, it doesn't respond to anything unless you remove the bee sting. That will be very, very small. It's very difficult to remove. Sometimes it will fall into the anterior chamber and it will disappear. It's a light grayish in color. But somehow you have to get it from the cornea out. Then only it will heal. Otherwise, it's gone. The cornea is gone and the patient will become bullous keratopathy and blind. So somehow you have to remove it. Once you remove, Dr. Siddharth has done a lot of cases before bee sting he presented. He nicely removes from the posterior. He makes a paracensis and removes from the posterior with the vitreoretinal forceps. And they heal very well. The first few days we put on antibiotics, then we put on steroids. So combination, they heal very well. So if you don't remove 100%, it's such a small tiny thing in this, the poison, it can damage entire corneal endothelium and they become bullous keratopathy patients. So then comes the marginal keratitis. If it is exaggerated, many cases they referred, almost 360 degrees. They referred as a PUK. PUK, another thing is PUK is not diagnosis. PUK is a finding. So somehow these Americans, they pavement, they call sidewalk, and tennis racket ball. So they can't understand the words. They use only the spoken words. So they started calling it PUK. All our great surgeons, they go America and come back, they call Murens also PUK. So PUK is a finding, peripheral ulcerative keratitis. It's not diagnosis. So as ophthalmologist, MS qualified, we have to write diagnosis. So PUK is never write PUK as your diagnosis in case sheet. What you write, PUK is only just finding. So this case is just a marginal, exaggerated marginal keratitis. You have to put on steroids, otherwise they don't respond along with antibiotic. Then come to this one. This is the conjunctivitis post in the second day or third day they come to us. This is very typical of microsporidiasis. You don't need any scraping or anything like that. The microsporidia, this is intermediate organism. It is neither bacteria nor fungus, nothing. It's a different fellow. So they found now it's responding to antifungals better than antibiotics. So you can try itraconazole or fluconazole drops, but not too many times. It becomes too toxic. 2 or 3 times a day is good enough. They respond very well. If you put 6, 8 times, then they produce toxicity and they come with the toxicity. You will get confused and patient will get confused. He will run away and it becomes a mess. Just 2 or 3 times a day, they do very well. So here the hallmark is you don't see any inflammation on they just live on epithelium. So they don't touch the cornea, they don't touch bombers, they eat the epithelium and grow there. So it doesn't produce, just stuck, it is stuck as though you put a drawing. Surrounding cornea is very clear. So this is very typical of microsporidiasis, which we recently came to know maybe 10 years back, not before us. Then comes to the dendritic ulcer. Once you put a stain, then if somebody, junior puts the stain, then you see it, then becomes a problem. It will spread like that, then you don't know it's a fungal or dendritic ulcer. So once you put a stain like this, immediately you have to see. If you wait for 15 minutes, 20 minutes and you see second opinion, then you cannot diagnose it's a dendrite or a fungal ulcer. So you have to treat it appropriately and see and treat it appropriately. For example, you see here now, even I don't know which one, when it comes off 10 minutes of C fellows and put the drops and fluorescent stain, I don't know if it's a fungus or a dendrite. So that becomes a big issue. That's a very important one. So come here, this is a very common thing. A linear, if you see carefully, you can see in the just people, below the pupil area, a linear one, something like a dendrite in interpalpebral area. So this is diagnosed as antiviral and given it's not antiviral, this is only nutritional keratopathy, keratinized epithelium. You fluorescent, you stain it, this is called stippled staining. It's not strong stain, it doesn't go with the time. You can see the staining line here, a little bit pupil area. This is not dendrite. Any patient needs a systemic or oral systemic vitamins, a lot of vitamins and topical lubricants, and stop whatever is there he is using the eye drops. So if you treat his antiviral, it becomes exaggerated and becomes more worse. For example, you see this and see this, there is a gross difference. But still, You see this pattern you don't see there, and that's the difference. This one is very typical of the nutritional keratopathy. So they need a lot of vitamins. When compared with even this here also dendritic is a horizontal only, but it's totally picture is different, clinical picture. Then come this referred as a stromal keratitis, infective keratitis, lot of so you look at the cornea itself, it looks like a severe cellularity and problem. But you just look at the sclera, then the adjacent sclera is also inflamed. This is sclerokeratitis. Typical picture of sclerokeratitis. When you have a sclera and keratitis, there will be a lucent area. Then there is a lot of stromal inflammation, pupil area. So these patients need steroids, topical steroids, and systemic immunosuppression for cure. So this comes the early stage of vesicular ulcer. This is very difficult to treat. We think that something is happening and we put on a lot of antibiotics, it doesn't respond. We have to put on steroids, maybe 1 or 2 days antibiotic and start on steroids for this patient. And they recur, they go for a long time, 5 to 10 years. So you have to tell the patients, whenever comes, please come. Otherwise you will end up with problems. We have to, this vascular vessels growing at the tip of it, it's early stage. Later stages, it's okay, it's very typical, very easy to diagnose. So this patient, then comes the small circular ulcer, non-healing, non-responding to anything. So if you look at the periphery, you will have a pinhead-like lesions. And it runs for months, nothing happens. For weeks, months, even a month, it will be like that only. This is a typical of nocardial ulcer. But if you look at close, if you zoom and see it, you will have a centrally no infiltrate, peripheral infiltrate, and you will have a small pinhead-like lesions. So this is very typical of nocardia. You just put the mamic acid 50 milligrams per ml, it will start healing, then they change 25 milligram per ml, they 100% they will heal nocardia, and they become very nice. So if you leave them, keep on treating with quinolones, this is what happens. It spreads slowly over a period of 2 months, 3 months. Now it looks like a acanthamoeba keratitis. So we will diagnose a ring ulcer, either fungal or acanthamoeba, very ring. It's a ring. Typical textbook description is that. But you have to look at the periphery. You can nicely see as the small pinheads. This is a very characteristic of nocardia ulcer. It doesn't go put them mamic acid, you see the cornea reasonably, they 1 or 2 lines drops, otherwise they will be reading 612, 69. The mamic acid drops works very well. The problem comes, a ulcer like this. In our clinical practice comes like this, elevated, little bit, we can see even single dimension photo, it's a bit elevated, and it's not typical round like a cornea ulcer. It's neither, so these are very typical features of a fungal ulcer. Subepithelial, the epithelium will be intact. So this is the problem. We don't want to scrape because it's some pupil area, we are worried about the vision. So when you are in dilemma, you have to use antibiotic, which is many antibiotics got antifungal activity also. Like chloramphenicol got antifungal activity, polymyxin got little antibacterial antifungal activity, and moxi got antifungal activity. But GATI is not having, ofloxacin is not having, so you have to give a combination of which is having antifungal activity, antibacterial, along with antifungal agents. Here is everybody is just a blind shot. We have to put antifungal, you have to put an antibiotic which is got antifungal activity. You can mix with moxi or you can mix with chloramphenicol with the polymyxin combination. And here also same. You see the ulcer here, it is right in the pupil area. There is no much material to scrape and take for culture and textbook. You have to ulcer, and you scrape that, the vision, we are also worried it will so in the pupil area. So these cases also needs that type of rational treatment than textbook description. This is anybody, any first even staff will tell this is a fungal one. But only thing here is we cannot treat like that. We have to remove the plaque. It doesn't go deep into the stroma. It takes nutrition from tears and it likes tears. It keep on growing. Just it comes when take a 15 blade, not 11 blade, take a 15 blade and scrape it off comes. It doesn't respond to this is demacious or pigmented fungi we call it. They don't respond to netamycin. They respond only to ozoles. So you have to use a ketoconazole or iatraconazole, something. They don't respond to netamycin. This is demacious fungi or pigmented fungi. This is also small, same like thing pigmented. Whenever you see pigmented, take that off and put them on ozoles. They do very well. And here comes, this is a typical Staphylococcus ulcer. Round one, you can nicely put a drawing, you can differentiate everything. This is a typical Staphylococcus ulcer, and you can give whatever you like for Staphylococcus. Then you can't see, you can't put the borders, anything. Then you are dealing with a gram-negative organism, mostly Pseudomonas. Here also gelatinous, it's like a jelly. The cornea is like a jelly and elevated. This is a typical of gram-negative bacteria. They do very well. You don't need to worry. You have to put them on an appropriate antibiotic. And what is the antibiotic? These are choices. This is a very busy slide. This is there anywhere in the net. You can just put it now. It's not anything for me to be very specific about that. Only thing is here is the bacitracin. This is for vancomycin resistant staphylococci, bacitracin topical. That's the only thing is very new for ophthalmologists, remaining all regular drugs only. Then comes here, you have a crystal clear cornea and you have a posteriorly fungus. Why they grow? They like the stroma, they cannot grow the bloody fungus. It likes the aqueous. So it goes across the cornea. It cannot survive, but it takes on the eats on the aqueous and it will grow only on the endothelium. The stroma it cannot grow. So this typical, you cannot ask why you can't grow in the stroma. That's what he likes the food. He will eat that aqueous and it grows. So the OCT has come to us for this type of ulcers where the infiltrate is posterior, and there are many cases we get like that now and then. So OCT it came very friendly for us. It's a very documentary. You can see that nicely in the OCT picture growing an endothelium into the. So here we need amphotericin intracameral dose. You give that, they respond very well. For this is a post amphotericin injection. One injection is not enough. You have to repeat it 2 or 3 times a day. This is another ulcer like that. This is another case. So these cases they do very well. You have to give amphotericin. The full dose produces a lot of uveitis and reaction in antechamber. First dose we give the full dose. Third day and again on the 6th day 2 or 3 times we repeat. So second, third, fourth dose we give half the dose of textbook description what you get in the Google. That's working very well. Full dose producing a lot of inflammation. Then comes the ulcer. This is the new one. Maybe 5-6 years we get to that. You see this is again PUK. PUK and infiltrate. This is the deadly combination. They say PUK with fungal infection. This is not PUK with PUK you can call. PUK is only clinical finding. This is the typical of pythium. So you have a epithelium intact, you have a gutter, and under the epithelium the filaments will grow. That is a very typical. You remember these 3 words, you can diagnose that pythium. So here also you can see it. Under the epithelium they grow. So we think the moment you see it, we think it's fungus. But when you see the epithelial defect will be very small and it will start the tentacles like thing it will be going. This is a very typical pythium, and here also you see PUK with infiltrate. If you say the right diagnosis PUK with infiltrate, 90% of the times it will be pythium. It is not a Murren's ulcer second infection. The treatment is entirely different. Here azithromycin and linezolid, they are work wonders. You can give topically, you can give orally, nothing wrong. Both are very friendly drugs. You have to apply every hourly. Azithromycin and linezolid. Linezolid, unfortunately, we have only 0.2%. That is IV solution. We put in a bottle and give to the patient. Actually, we need higher concentration, 0.5, but it's not available. That's a wonderful molecule in this case. They 100% they heal. So this is a small kit came to us. We admitted. You can see you cannot expect 9-year-old person a PUK with a infiltrate. So we diagnosed as a pythium. Even cultures came negative. Microbiologist said I didn't see any pythium. We put on azithromycin and linezolid. He did very well. This is just a 9-year-old kid. It took a time, 1 week, 2 weeks. And that's very important, otherwise this typical acanthamoeba keratitis, which is quite common here. They used to respond very well to PHMB, but the new drug that's getting added is the linozid from acanthamoeba meningitis. So the doctors have come, who are treating, they said linozid is working very well and they are able to save a lot of people with acanthamoeba meningitis. That has opened up another avenue, another treatment modality for us. So acanthamoeba, don't worry, just put them on linozid drops, oral linozid and topical PHMB. PHMB is not available, that's a big problem. So people are using chlorhexidine and something. So characterless ulcer. If you see a characterless ulcer, you cannot define any character for that, then it is 100% neurotropic. So nothing worse, you have to do tarsorrhaphy in this. No antibiotic, whatever you do it, nothing works. This is no character, there is nothing. There's why it is no ulcer, it's melting on its own. This is very, very diagnostic of neurotropic ulcer. They have either trigeminal or there's cerebral injury, something, you have to do tarsorrhaphy. Total tarsorrhaphy, not lateral. Medial tarsorrhaphy, you have to do a temporal permanent, then it works. Then atheromatous ulcer, existing leukoma, breaking down, recurrent is coming. Nothing works. Ultimately, you have to go for a ketoplasty. Lamellar ketoplasty works very well. So you treat them with BCL, everything, it's okay. Again, it will come. You do lamellar ketoplasty, that is a permanent answer for them. So these type of ulcers, melting, you just don't hesitate, send them for a lamellar ketoplasty if you are not doing. Then comes the ill-defined ulcers like that. What you do, you get confused. They run for years. When you ask the patient, they give a big list from. So these ulcers, they are not responding to all, so many, some 20, 30 papers. You have to go for ketoplasty straight away. There is no point in trying to do something and thinking you are a genius. There is nothing here, geniusness for us to prove. And a unresponding ulcer, now we are trying RBP, Rose Bengal PDT. It's working reasonably well in superficial. If the infiltrate is more than 250 microns, it works very well. Deeper than 250, it doesn't work. So that's only clinically you have to evaluate. You can try before you go for a treatment. This is a Rose Bengal and put on 532 light for 10 millijoules we are using right now. Instead of 5, they work. Then comes very bad ulcer, what to do in this. So TKP is the only answer for them. And they do very well. Even such a bad looking ulcer, this boy, 16 years we are following. He's from Kerala only, he's doing, it's not something, it looks not very good, but he's having around 660 vision, that's good enough. So when it comes full ulcer, what to do? This is the biggest problem. We have to do, it's an ulcer, perforated, one-eyed fellow, so there is nothing here, corneal. So another procedure was there. No. 1 minute. One slide up, please. So this is a corneoscleral graft. I used to do it. The last time I did it is 10-15 years back. They do very well. Even with the total ulcer, total cephaloma, you have to take it. This is a 1.5 millimeters corneal sclera. I took it. Even up, you can go up to 2 millimeters sclera. You have to take partial thickness. But the only thing they suggest is you have to take with the trabecular meshwork. You have to take the cornea with the trabecular meshwork because that trabecular meshwork will work without producing glaucoma. That's what the Italian doctors promoted. And you remove this and put the cornea. Now we got oral systemic tacrolimus, topical tacrolimus, azathioprine, cyclophosphamide, MMF. So very safe drugs. You can put them on immunosuppression. They do reasonably well. I have many patients till their lifetime. These are 2 cases like that only. Total corneoscleral graft. You get a glaucoma, you have to put a tube. Nothing works. So the topical drops. If they get a glaucoma, you have to put a tube for them. And they do reasonably well, especially one-eyed or instead of doing. I done lots of this is a PUK typical. This is the cases where we do that grafting, and this is a cornea ulcer treatment is very unrewarding. So nobody can run forever. It's not a 100-meter dash. Somebody has to take over. It's like a relay. Somebody says I do something. Somebody should take over from me. I cannot run forever with cornea ulcers. I'm sitting in the OP seeing everybody every day. So unfortunately, nobody wants to take it. So I found now most of the time, all of them girls are coming. I don't know why they are coming and try to teach me. I am a 60 years old person, I cannot change now. They are not coming to learn, they are coming to teach me. I said, you do a graft? They said, no sir, I do all the scans, A scan, B scan, OCT, something else. They say, it's a vitreous endophthalmitis, you have to eviscerate. They take decision, they don't you listen what you tell, you do that. So Arjuna, Krishna was lucky in Mahabharata, he got Arjuna as disciple, not a Draupadi or somebody else. So then he could have spent entire day teaching her for instead of 45 minutes finishing his Bhagavad Gita. So that's become a very big trouble for us to treat Carnival, sir. Thank you very much.
Thank you, sir, for your enlightening talk. I'd request Dr. Thomas Cherian, sir, to kindly present a memento to Dr. J.K. Reddy, sir, as a token of our gratitude. Thank you, sir. Our next talk for today is by Dr. K.S. Siddharthan, sir. He is the Director of IMED Hospital and Cornea Research Foundation, Coimbatore. He is a pioneer in lamellar kerastoplasties and he has performed several surgeries, and he is also a certified trainer in DMEK. Sir will be enlightening us about recurrent corneal erosions. We welcome you, sir, for the talk.
So, good morning, and I would like to thank Dr. Sreekanth for inviting me for this wonderful CME. And also, I started my hospital about 1.5 years back, and I could spend a lot of time with Dr. JK, sir. So, I'm very happy that again I'm able to hear Dr. JK, sir's talk, and two of my mentors, Dr. Satyan sir and Dr. JK sir, are here. So really a very good morning. And my topic here, recurrent corneal erosions, it's like a masquerading. There are so many conditions which present as recurrent corneal ulcers. Even as Dr. JK was telling, even the microsporidial keratitis, it appears like a erosion, or it appears like an SPK. But there are so much of variations in the diagnosis. So first, for the postgraduates, I think now a few postgraduates come. So my talk in the 10 minutes, 3 to 4 minutes, I'll just talk the basic anatomy, and then I'll present some few interesting cases where we can have a view of it. So the cornea for the postgraduates, 5 layers. Now the 6th layer DUA is added, but that's not our prime concern now. So now the basic problem in a recurrent corneal erosion lies in the basement epithelial layer. So we can see that. So we can see that this is the layer which we are going to talk about in recurrent corneal erosions. So the epithelium is made up of the superficial cells, wing cells, basal cells, and basal cells along with the Bowman's layer. This layer is the most important layer where we'll be concentrating now. So going into that layer, very important is the basal cells, because these secrete the epithelial basement membrane, and the hemidesmosomes. For the postgraduates, remember, hemidesmosomes are the most important anchoring fibril here. So when there is a problem, in the hemidesmosome, the anchoring fibers into the lamina lucida and densa gets weak, and this area is the most important part where the epithelial basement membrane gets disrupted. So from the Bowman's, again, there are a lot of fibrils going into the stroma, and just remember the hemidesmosome layer anchoring fibrils into the stroma. So in a recurrent corneal erosion, this is a normal epithelium which has a very sticky Bowman's. Remember, as I told you, the anchoring fibrils are all very sticky and it remains okay. If there is a problem in the epithelial basement membrane, there is a problem in the gumming. So what happens? The epithelium becomes loose and it breaks. So typically a recurrent corneal erosion, a patient says that when I get up in the morning or in the midnight, they get pain. So that is a typical pathophysiology. Because there is a dysfunctional hemidesmosome, there is a poor anchoring fibrils. So when there is poor adherence of the, because there is no gumming effect, the epithelium is loose, and this nocturnal drying is very, very important in a recurrent corneal erosion, because when there is a nocturnal drying and the patient sleeps for some time, when he opens his eyes, there is a resultant shearing force of the tarsal conjunctiva. You can see the tarsal conjunctiva, there is a drying, and the tarsal conjunctiva sticks onto the epithelium and rips it off. That's why when they get up in the morning at 3 o'clock, 4 o'clock, along with nocturnal drying, there is a shearing of the epithelium and they have severe pain, redness during that. This is the typical pathophysiology of a recurrent corneal erosion. So there are so many predisposing factors. This is just for the theory for the postgraduates. First thing is corneal epithelial basement membrane disruption. So when there is basically any disruption, the patient may have an underlying problem for so many years, but they say suddenly a history of injury or any infection, or they would have undergone any refractive cataract or corneal, any other surgeries, chemical burns, thermal burns, or floppy eyelid, anything can precipitate a recurrent corneal erosion. Also a poor epithelial or a basement membrane stromal healing. For example, a patient has a diabetes, patient has blepharitis, dry eye syndromes, all these things, ocular rosacea, where the matric metalloproteinase are more, MGD, even a simple MGD can cause a poor epithelial healing. And also degenerations like band-shaped keratopathy, nodular degenerations, epithelial dystrophies, epithelial basement membrane dystrophy, particularly map-dot finger dystrophy, rice buckler, tail becken, and Meesmann, all these are a part of the superficial dystrophies. And all of us know stromal dystrophies, macular, granular, all these things can present as recurrent corneal, with recurrent corneal erosions. So basic whatever we talk about, just remember this diagram in your exams, and it's just a basic junction. When there is a breach, of the epithelial basement membrane dystrophy membrane, there is a pooling in of the transforming growth factor and the platelet derived growth factor. When there is an injury, these two are the important chemicals which come in to regenerate your the epithelium. But when there is a problem, what happens is they stay for a longer time, damaging the keratocytes and producing myofibroblast or fibroblast. So when these stay here in the stroma, they are very weak. You can see a weak collagen forms. So when there is an underlying epithelial basement membrane secretion defect, when there is a hemidesmosomal problem, the next happens here is the poor collagen formation, because there is more time for healing, more time these chemicals stay in, and they cause all these problems. So extensive, the same thing which I showed you in a diagram, there are many. For example, injury, a trauma can cause, because of the hemidesmomal weakening, it can enter the stroma. Same thing what I said. Important point is keratocyte apoptosis happens. When there is so much of keratocytes loss, the epithelial basement membrane secretion is poor and the cycle follows. So for example, again the same mechanism in a dry eye or an ocular rosacea or MGD, these two matric metalloproteinases is there more in these ocular rosacea cases, causing the poor epithelial healing and the myofibroblast formation. So all these things cause again recurrent erosions. Again, in a limbal stem cell deficiency or a viral keratitis, the yellow parts are where these conditions work, because the limbal stem viral, they prevent the closure. A regular way of healing is when there is epithelial heals, closure of the defect, there is a regeneration of the basal cells, inhibition of these growth factors, the EBM gets regenerated, the keratocytes mature, myofibrils which are formed is gone, keratocytes repopulate, and there is no scarring, very minimal scarring. But in case of all these conditions, epithelial defect healing is delayed, initiation of EBM is delayed, maturation of EBM is delayed, and myofibril apoptosis is delayed. All these are delayed, causing recurrent erosions. Even in person deficit, any abnormality of neurotrophic diabetics, again the same thing. There is more prolonged release of TGF growth factors, myofibrils development, increased amount of disorder of ECM, and then scarring and fibrosis. So this is the basic information which we should know in a cases of developed ones. Whereas in case of dystrophies, it's an entirely different pathology, meaning that the cells, because there's a desquamating corneal cells get entrapped, they are not expelled out For example, that's why you see in map dot fingerprint dystrophies, you find maps, dots, because epithelial cells are not able to go out anywhere. The desquamed epithelial cells get entrapped in the redundant EBDM and these make them loose, the epithelium loose, and they are prone for the corneal erosions. So basically now I'll show you some slides of different cases where we can see. So basically for the postgrad, just have a differential diagnosis of herpes. It can be an exposure, it can be neurotropic, conjunctival foreign body, dry eyes, infective keratitis or ocular graft. All these are just theory. Just remember this, that these conditions can cause erosions. So the first thing is this we miss a lot. This patient actually came for me about a month back, telling that a patient using anti-glaucoma medication for so many years, and the doctor said that there is something in the epithelium. He's been using anti-glaucoma for so many years. So, but when I could see it, you can see here I put a red spot. There are a lot of whorls. There are a lot of whorls, and these are a lot of micro scarrings. This is a typical map dot fingerprint dystrophy. There's nothing to do with any anti-glaucoma medications here. It is just, you can see this vesicles and goes, and these are, as I told you in the anatomy, these epithelial cells cannot go anywhere. As I told you, redundant epithelium, where the desquamating epithelium can go, they get occluded, they get caught in the below the basement membrane. So this is what you see, and over a period of year, it becomes very prominent. And even when you stain, you can see here that loose irregular epithelium can occur here, and you can see the staining here in the corneal aberrations. And you can see that typical lesions of this. And here, if there is no problem in the vision, we can just manage with lubricants and any night ointments. But if there is, we can do with a diamond burr, or we can do a small shaving. Again, macular corneal dystrophy, very commonly we know that they also produce recurrent corneal erosions. Granular dystrophies, again you can see that more common in macular, erosions are more common in macular. Granular less, but still they are very common. And corneal degenerations. So this patient, I'll show a video of this. So this is a very bad case, one-eyed, typical psoriasis all over the body. This is the only one, the other eye is removed. So he actually referred for corneal transplant actually. But when I could see it, actually the one half of the cornea was doing really well. So he had recurrent breaking down of epithelium and had severe pain. So just with a diamond burr polishing, you could see that this was immediate post-op. I did the patient, brought him down, and I did it under topical only because one night. Then this is immediate after surgery, and this is after 3 weeks, and then after a month I did a cataract for him. He had plus 31 lens. He is now having 5/60, 660, but still he is happy, and we avoided a transplant for him. And again, chemical injury. So chemical injuries also can present with persistent epithelial defects or stippling. You can see here, there is a very acute epithelial defect. What we have to understand here is, these patients, once they heal, they can present in later also with epithelial erosions and stippling, because what I wanted you to notice this point here. There is a definite acute, very, very faint, we can see the limbal stem loss. Very well you can see it. This is after healing. This is a very active stage. After healing, you can see that how amount of pigments are there, but here the limbal stem cells are gone. Even in a white-blue filter, you can see that the cells are gone. So this patient, sometimes you have to ask a history of any acid fall or alkali fall, because once it heals, this we will miss. Over a period of time, nobody is going to look at it when you get a new patient, but you can see a little bit of stippling here over a period of time, but keep it in mind that half a history of acid burns. And again, a viral keratitis, a peripheral viral keratitis, you can see here a typical staining here of the viral, and this patient actually was on immunosuppressives. Actually, we see these dendrites mostly in the center, very rare to see in the periphery, and these patients also in the early, actually this patient was treated 1 month elsewhere, and with just irregular stippling, and when I came and I could see it, because I think he had not used any antivirals, and you could see that actually it was proliferating and with a lot of stippling over the area. This was treated with antiviral, oral as well as topical. And sometimes geographic, when you leave it, it becomes a geographic ulcer. needing a regular treatment with antivirals. So dry eye disease, again, it's a very big discussion here. Just wanted to show you, usually it presents like a complete diffuse epithelial stippling. You have to take care of the lid margins, dry eye conditions, do a systemic workup, then only this condition will improve. Just with topical lubricants it will not work. So dry eye disease is a very big spectrum, but when you get a stippling like this, you have to do the complete tear workup, the general workup, to when you can manage a SPK. And this one, as Dr. J.K. sir said, this is a new entity. We can see stuck up appearance, stuck up on SPKs. And this we think it's only SPKs or some erosions, but you can see very beautifully on the surface, sticks very rarely goes to the stroma. But this is a new entity which we keep seeing. Most important, this is unilateral. Please remember, patient might come with a little bit of discharge, and this is 90 to 99% unilateral. I've never seen a bilateral microsporidial, very rare, but I've seen a single one patient presence. They initially treat as conjunctivitis, but the patient will say 10 days I was using mild discharge. But this tuck-on appearance you should never miss. You will always confuse with our viral SCKs or SPKs, but it's unilateral. And this nowadays I think what our mind does not know or eyes does not see. I see a lot of these type of patterns nowadays. I had almost 10-15 slides like this, but I put only one or two. This is a typical corneal oasis, and you can see here that there is a proliferation of the conjunctival cells and growing, and you see that how it grows. Actually, this again was referred just with stippling. When you stain, some stippling is there, but you can very beautifully see the pattern here. That this is actually seen in the slit lamp very well, but otherwise if you don't see it, you'll just think it's a scar. But you can see the edges, how fibrinated the edges are. And in the staining, you can see how it is going like a tongue. Just one cycle of 5FU, just one cycle of FU. You can see that here, you could see that the conjunctival growth from ingrowth from where it was growing, you can see here, just with one cycle, it started growing down, it started coming down. So you have to just keep in mind, just look, don't just think it's a scar or anything. Have a mind, think about corneal oasis and also. So this patient, again corneal patients just presents like this with stippling and erosions. Immediately we think it's a nutritional keratitis or something else or viral, and we start putting on medications. But what I wanted you to know is we can think of exposure, because when you have erosion, you can think of exposure or neurotrophic, anything we can think, but just look at the red point. When you stain, actually without staining you are not able to see, but as you stain, you see from here again there is a conjunctival growth, and from here it is growing. You see that it's growing. Here also there is a small growth, but you can see, just will be very totally convinced whether it's viral or what it is. But typical a conjunctival epithelium growing into the conjunctiva. So these are very, very common nowadays. When you feel that it's not, there is stippling, you are not able to find any diagnosis, please look at the limbus. Stain it and take some time and look at the limbus from where these are coming. Because it's very, very simple. The moment you give one cycle, gone. Just one cycle, you see, this is just only one cycle. This patient on third or fourth cycle completely goes. You see, just when there is a SP case, you just look at the limbus from where it is going, take some time, stain and have a look at the pattern, very, very important. Again, this case, again, we have seen quite a few cases like this where we again see a little bit of stippling and a keratinized epithelial ridge. Nowadays I see, last 2 months I have seen 1 or 2 patients like this. Typically from the conjunctiva, you see typically from the conjunctiva. So sometimes this can present as a whirl of here. This is very typically connected. You can see that how the conjunctiva, the epithelial cells have grown. Again here the same. It's a corneal oasis, and you can start a cycle of 5FU, and you see that from a pattern of tongue shape slowly coming down and slowly it disappears. This patient is still under treatment. It takes quite some time, but it's still under treatment. So basically, when the treatment, just 2 or 3 slides more, just medical and only surgical treatment. Medical, when the patient presents with recurrent erosions, when it's acute, daytime antibiotics, a broad spectrum of antibiotic like moxifloxacin, once or twice, don't use too many times. The fluoroquinolones are very toxic, so just once or twice just to prevent infection of the epithelial defect. preservative-free lubricants. There are so much in the market, whether you can use sodium hyalurate or CMCs, whatever you can use. Nighttime lubricating ointment and hypertonic saline. Even you can give hypersol, you can give a sodium chloride drops or ointment, whatever. And BCL generally not needed, but if the patient is not able to tolerate pain, then you can put bandage corticosteroids. You can give, suppose you feel associated MGD or any ocular rosacea, anything, add doxycycline, and topical steroids also once or twice. That is chloramphenicol with dexamethasone, definitely once or twice, because there is a added part of inflammation in EBDMs. So you can definitely add topical steroids once or twice. Clear solutions, not suspensions. Clear solutions of dexamethasone. So to prevent, once they heal, generally I maintain them on sodium hypochlorite drops once or twice, or on the ointment. I generally continue them for about 6 months, 1 year or 2 years. Just ask them to use so that we feel that the recurrences are very much reduced when they use these hypertonic drops. So when the conservative treatment fails, then comes surgical. Surgery, there is not much any surgical interventions here. When it's central, just do an epithelial, sometimes just an epithelial debridement works. Diamond ball is very simple, because an access to PTK is very expensive. Not everybody is having an excimer laser. A diamond burr polishing does wonders, because it does a very good smoothing, and it causes micro cicatrization here and there, and it causes more additions. Just like if you want to stick on a smooth surface, anything doesn't stick. But if you make it irregular, it sticks well. So that's the concept. And alcohol delineation also is a technique. But when it's in the periphery, you can try anterostromal. You can, in the periphery also, you can do all these things. But if it is, you can anterostromal puncture or NDAG is for theoretical purpose. Finally, a last video of the burr. So it's very simple. Just you have to just do a normal, like how you scrape, just do a normal superficial touch of the corneal epithelium, and you can see that how irregular, it creates an irregularity. So this is what we want. We want it to become irregular so that the epithelium grows beautifully over it. So we should not do too much also, because then it becomes, you will be taking too much of stroma. So this is that patient whom I told you that one-eyed with psoriasis. So I didn't block him, but actually I was very skeptical to very simple. And so our main aim is to make the surface irregular so that it sits very well. So in that patient I was a little bit skeptical to do. I did a topical only. You can see that it's a CDK with a lot of scarring. So recurrent erosions and recurrent pain. So you can see that actually he was not able to fix the light at all when I started doing. But when I could really remove the epithelium and little bit stromal polishing, you can see that he is not able to focus. But as I could clear, he could slowly start looking into the light. There was cataract, but still he was able to look into the light and he was able to see. You can see now he is able to fix a little bit. So these cases, a simple diamond burr polishing will do, and no need of any keratoplasty or anything, because the problem is basically in the epithelial, causing a little bit of stromal scarring. And then these are the post-op photos you saw last time. And the other one is regular, this for post, there is anterior stromal puncture, just with our regular capsulotomy needle, just make small punctures in the periphery, where in the not in the visual axis, when you see when there are localized areas. And this is an amniotic membrane. The simple amniotic membrane graft you can do in cases of recurrent corneal erosions which are not responding to treatment. Thank you.
Thank you, sir, for your enlightening talk. I'd request Dr. K.V. Raju, sir, to please present a memento to Dr. Siddharthan, sir, as a token of gratitude.
Dr. Siddharth, can you stay back for some discussion? Thank you for your wonderful presentation and a good collection of photos. It's open for discussion. One thing I wanted to ask you is, between medical and surgical, what's your threshold? Like, when do you actually switch to surgical? What is...
Surgery is very rare, Sujit. Surgery is very rare until the patient is really disablated with the vision. If the vision is not coming, vision is becoming scarring. For example, repeated epithelial defects with scarring, then it becomes a issue. So that is the delineation point. But most of the times, 90 to 95% of times, they respond with topical medications.
Yeah, they respond with medications, but it's often a long-standing treatment, and you need to motivate the patient for using the medicines continuously for months.
Yeah, the thing is that if they are not able to tolerate, if there is pain and there is breakage in 2 months or 3 months, regular, frequent intervals, when there is frequent, suppose they come with a recurrent erosion, we treat, 3 months they are okay, they again come back. Then we treat them, then again after 2-3 months they come back. That time we tell them that again one more time, second or third time it comes, better to go with a superficial keratotomy or a PTK. That's the area where we try to go with the surgical when it recurs very frequently and the patient is not able to tolerate pain.
Okay. And your point about the dry eye is also very important, because most often we see that both coexist. And
yes.
In spite of doing a dry eye, in spite of doing surgical or medical management, sometimes it keeps coming back unless you address the dry eye issue. And sometimes when they come during in between the episodes, it's difficult for us to actually make out, other than from the symptoms, from the early morning symptoms or whatever it is. It's difficult for us to make out whether it's actual recurrent erosion, unless if there is a clear-cut trauma history. Because the history may be very vague sometimes. Trauma might have happened many years back and they might have actually forgotten that. So we have to address the dry eye issue. Even if we do a surgical thing, we have to keep putting the lubricants for a longer period. Any other questions?
Even after stromal puncture, you get the recurrence, right?
Yes, stromal punctures sometimes, ma'am. But most of the times when you do a burr or a PTK, they don't recur.
Burr is good. So what I do is, in case of doing puncture, I make small linear streaks, avoiding the pupillary area.
Yeah.
And first time when they come, I ask them to patch their eyes at night and not open their eyes immediately in the morning, in the first 2 episodes. And after instilling the drops only to open their eyes, so that they'll be relieved of their symptoms.
Yes, ma'am. Yes.
Yeah. And PTK, what is the setting you keep for? What's the mind?
Just maybe 10 to 20 microns or maximum 30 microns we go. We cannot go beyond that, then it causes a hyperopic shift.
So you remove the epithelium with mechanical or?
I have a Schwind machine where it removes the epithelium by itself. So I don't do any mechanical debridement.
Yeah.
So 50-55 microns epithelium and another 10-20 microns you add, it does it. So 60 microns.
Yeah. And one more thing is, whenever you get a recurrent corneal erosion, I always check the other eyes. If you don't get a history of injury, even if you get a history of injury, the other eye should be really taken. Thank you.
Any further questions from the audience?
How do you sterilize the burn?
Tip is autoclavable or ETO, you do the tip, but the motor you should not sterilize. So when what the sister does is, she will clean it with sterilium, and one portion she gives you in the sterile, then you take it, and then you clean the entire motor. So there you cannot autoclave or sterilize the burr because it has battery and all these things. So she just, the one edge she cleans with sterilium and she gives you, and you can hold it, and then you have to clean it, and then that burr part is autoclavable or ETO.
Any idea why it is happening more with the organic matter injury?
More with organic.
Yeah. JK sir, your any thoughts on that?
Sir,
Treatment for the microsporidial.
Same.
Because I have one little girl who keeps coming with this microsporidium.
Recurrent microsporidium, no.
Yeah.
Recurrent. Then no,
I was
it's
thinking
not,
that it is a.
No, microsporidium looking like there is a different diagnosis. We have to look at something else.
But it is a bilateral.
Recurrent means that you have to look at something else. It cannot be, microsporidium cannot be recurrent. So it goes stromal. They are difficult. Once it goes stromal, we have few cases. As long as you put on the steroids, prednisolone, they will be okay. Once you stop the steroids, it becomes abscess and perforates, and you have to go for TKP. Microsporidial stromal keratitis beyond the epithelium under the Bowman's going more than 200 microns depth. There is no known treatment for it. Ultimately, they'll land up maybe 4 years, 5 years, 6 years after also. They'll land up with TKP.
There's a little
But
girl around 10
recurrent
years.
superficial means there is something else. We have to look into that.
Yeah, this is a bilateral. Moment she is on lotiprenol low strength.
That's
it just disappears in
mostly Tyson. Mostly Tyson. The best treatment for Tyson is still FML or lotiprenol alternate day, something like that. That just looks like a microsporidium with a little bit less number. Maybe you can count. If you count number of spots on the cornea, that is Tyson. If you can't count, then it's microsporidium. There are too many you cannot count. That's microsporidium. You can count, yes, I can count 20, 15 or 30. If you are able to count number of spots, that is Tyson.
So in case of microsporidium, what is your regular management?
No, microsporidium cannot be. That's the Tyson only. What you
No, I'm asking.
Mine is just itraconazole or fluconazole drops 2 or 3 times a day for the topical. So you get a subepithelial, sometimes inflammation, you have to use mild steroids, lotiprednol or FML once or twice. Or if it is a tooth dense, then use tacrolimus.
So voriconazole, do you use
I am not a fan of voriconazole. He is a big fan.
Sir, but no, but Sujit, for microsporidials, fluconazole is the best, and as JK said, 3 times, 4 times, not more than that, and along with ciprofloxacin and all, epithelial defect will happen. Just 3 times, lot of lubrication.
You don't go for epithelial removal or
No. You beautifully it responds with just 4 times fluconazole, 3 times lubrication. It will improve. Sometimes it takes 2-3 weeks also. It takes 2-3 weeks, but it resolves.
Any other questions for Dr. Siddharth?
Typical RC has my threshold is, you're asking threshold.
Yes, sir.
My threshold is 3 attacks. If the 3rd attack comes. I tell them, because many cornea also.
How frequently, sir?
Where?
How frequently?
No, whatever may be. He had 3 attacks, in his history, in his lifetime. So I go for diamond burr. Diamond burr is the best. So PTK problem is you cannot reach up to the periphery. Sometimes you can maximum 7-8 microns. PTK, you cannot reach beyond that. Cornea is 11 mm.
8 millimeters.
So, yeah, maximum 8 millimeter. Beyond that, you can't reach. So, diamond burr is very good, almost 100% result. Small puncture we used to do. BCL for 15 days.
What is the role of pilocarpine in a long-standing like neurotropic ulcers?
So, pilocarpine for increasing the tears. Neurotropic is completely different phenomena. Neurotropic ulcers, nothing works, only 2 things works neurotropic. One is dorsography, second is the Boston catoprosthesis. Boston, not catoprosthesis, actually this BSLD, they call this is scleral contact lens. So Boston BSLD they call it as. But BSLD also you get infections. These are only 2 things that works neurotropic. Boston scleral device, they call it. Otherwise, they don't get insurance coverage there, so they call it as. So for typical neurotropic, 100% neurotropic, either torsorrhaphy is a cosmetic disfiguring, means you have to go for a scleral contact.
Okay, atypical.
What is atypical? Then comes it.
No, I'm seeing that the pilocarpine really has corneal epithelial
It's a
healing
borderline
property.
case. Maybe that
Yeah,
is
that-
dry eye associated with one.
Yeah, because-
So balanced cases, you have no sensations. These two things, and you have ulcer, torsorrhaphy, or scleral contact lens.
Sir, actually, for a neurotropic ulcer, now they are using more of insulin drops also, probably. So you have used it.
Yeah, yeah. We'll
So
be
that is
happy
giving-
to hear that insulin
Yes,
drops.
so that's giving very good results. Sir. I have tried in around 10-12 cases. Very good results.
Who is the manufacturer for the insulin?
No, actually, I am using the insulin injection and reconstituting it. I think Entod is coming up with
Entod, yeah.
Entod is coming
I
up
received
with
the
the
message from
drops.
them,
Yes,
yeah.
but I don't. It's not yet available here. But you can mix up with the, reconstitute with human mixed diet injection, and
How
so
much is that?
it's like 4 ml you have to take and put it into the refreshed ears or whatever lubricants. Replace 4 ml from that, and you have to refrigerate it. And 4 times a day, 7 to 10 days, you are actually seeing the epithelium is healing. Frequent breakups are happening, but every episode when you put this, it's healing very well. And apart from that, of course, other things like dry eye management, BCL, torsorrhaphy. This which I am saying is specifically for those with this trigeminal injuries, severe trauma, and all those happening with multiple cranial nerve injuries and all those things. Post-surgical also. CP angle tumors.
I
So
also
what
use
is the role-
insulin drops, sir, actually.
Okay.
Yeah, it works well for the neurotropic
Okay.
ulcers.
What is the role of cyclosporins, like Sequa, in the dry eye syndrome like picture? The Sequa drops, the cyclosporins.
So any specifically you want Sequa or cyclosporin?
You can say, because though we have all the 3 dosings of cyclosporins, I could, as a glaucoma people, I'm saying that the Sequa seems to have a better outcomes than those
It's
other
better.
two.
It is said to have a better penetrance. Sir. My personal experience is less with that product, mainly because of the cost. But cyclosporin as such is having very good. It has got its own place in dry eye management, especially in the inflammatory cases where you have the autoimmune diseases like rheumatoid arthritis and other things. Sir, any specific regarding that Sequa product? Any?
For them, it's very good for glaucoma people because most of them they induce the dry eye. It's not a dry eye. So they have to somehow you have to cure. The cyclosporins are wonderful molecule in along with the anti-glaucoma medication, especially brinzolamide, brimonidine, or dorzolamide. I think cyclosporin is essential to prevent long-term tolerance or all at least once a day.
Probably it is taking care of the inflammation also, sir. The medicine
No, but
induced
there is a
inflammation.
distinct difference between 0.05, 0.01 and
Condition.
0.05.
Say severe, if you are having a symptoms or you clinically you start with 0.09 or 0.1%. Then once they are stabilized, maintenance you can just come to 0.05 once a day. Its compliance is better and you are preventing. They are two different. One is curing, the second one is the prophylactic, preventing. So you have to accordingly you have to titrate your dosage.
Stinging is less with Sequa, as you said. Patient compliance is better with Sequa, telling you frankly, and I'm also happy using Sequa.
Just one more question to JK, sir. Regarding that rose Bengal treatment, what is your current selection criteria?
It's a non-healing, superficial. I don't wait for very deep. Only thing is it produces mild scarring of the surface. So if it is very much on the pupillary area, first we'll give 2 weeks, 3 weeks drug trial before, because it's producing some amount of mild scarring on the superficial stroma. So otherwise it's better to use it while it's working. There's no point if it penetrates deeper, 300, 400 microns, it penetrates, it doesn't work. So 150 microns, 200 microns, so it's very good results. Beyond, once it goes deeper, it doesn't work. Then non-responding corneal ulcers, we did no treatment, no, it's not working. It doesn't work. We know that cannot protect.
Timing protocol?
Protocol, see, Rose Bengal you can apply, okay? And the OP day, you keep the patient half an hour, 1 hour, whatever time, you keep on applying. It will get coated and penetrate up to 150 microns. The 5.4 millijoules is that joules per square millimeters, but we are using a little bit. It's just a light, green light, it doesn't produce any toxicity. So we are using 10, double.
10 minutes, how many minutes?
It's a 3 minutes, 3 minutes, 6 minutes.
And this diamond bar can be utilized for other corneal ulcers?
Sir, for ulcer we don't use, sir. Only RCE. RCE, pteresium. It's a very good instrument, diamond bar, underutilized in ophthalmology. Very, very versatile. Pteresium, like he has shown scars, Salzman nodular degeneration, CDK, spheroidal degeneration. It works wonders, spheroidal degeneration. Elderly people, post IOL, all. It's a beautiful one, very inexpensive, and it lasts for a long time.
Okay,
It's very cheap.
Thank you, sir. Next we go on to a case presentation by Dr. Fatima Aslaha, postgraduate student, Malabar Medical College. Welcome, Fatima.
Thank you. A 56-year-old female presented to the OPD with complaints of defective vision left eye for 6 months with occasional pain and photophobia left eye for 6 months. Patient experienced defective vision and occasional pain left eye for past 6 months, which was insidious in onset and gradually progressive, not associated with aggravating or relieving factors. She also gives history of mild redness, photophobia and watering during the episodes of pain. Symptoms are more pronounced during the morning hours. Patient consulted elsewhere and was given topical medication. Although her symptoms improved temporarily, she experienced progressive deterioration of vision in left eye, even with topical medications. No history of nausea or vomiting, seeing colored halos, flashes of lotus. No history of ocular or head trauma or joint pain. Past ocular history was a history of cataract surgery right eye 6 years back, and the postoperative period was uneventful. History of cataract surgery left eye 5 years back with uneventful immediate postoperative period, and gives history of good improvement in vision. There is no relevant past history, no history of similar complaints in her family, personal history, normal bowel or bladder habits, and no history of smoking. General physical examination and systemic examination were within normal limits. Coming to the ocular examination, head posture, facial symmetry, ocular alignment were normal. Extraocular movements were full in all directions, both eyes. Uncorrected vision in right eye was 6/9, improving to 6/6, and in left eye 6/60 with no further improvement with pinhole. Anterior segment examination of the right eye was within normal limits with PCIOL in situ. And coming to the left eye, lid and adnexa conjunctiva were normal. Examination of cornea showed microcystic epithelial edema with grayish opacity of 4 into 3 mm, seen paracentrally and infratemporally, extending from 4 o'clock to 5 o'clock position. On slit beam view, there is increase in thickness of stroma, suggestive of stromal edema. Multiple linear folds, suggestive of DM folds, were present in the area. No Gette or KPs on endothelium. No corneal vascularization, and corneal sensation was present in all quadrants. Anterior chamber was of normal depth with Van Herrick's grade 3, subluxated IOL with inferior haptic of IOL, seen displaced into AC, rubbing against cornea at around 5 o'clock position. No cells or flare. Pupil was of irregular shape, 5 mm dilated, with sluggish reaction to both direct and consensual light reflex. Iris, normal color and pattern, no peripheral anterior synechiae or atrophic patches or ectropion UVM. PCIOL in situ. Intraocular pressure by applanation tonometry in right eye was 14 millimeters of mercury, and in left eye 16 millimeters of mercury. Fundus examination was within normal limits, both eye. To summarize, 56-year-old female with past ocular history of cataract surgery left eye 5 years back, presented with gradually progressive defective vision left eye for 6 months. also associated with pain, redness and photophobia. Vision in left eye was 6/60 with no further improvement. Anterior segment examination showed microcystic edema, stromal edema, DM folds, and inferior haptic of eye oil was seen in AC. Provisional diagnosis: pseudophakic bullous keratopathy left eye, post anteriorly subluxated PCIOL, pseudophakia right eye. Thank you.
What you will do? What's your choice?
It looks to me like it's a single piece IOL. So single piece, I don't think there is no point in redialing it into a sulcus.
No, we have to redial. We cannot keep in antechamber.
So it has
what-
to be explanted.
Yeah, you can.
And you can think of.
But what is the PC? Why they get into the antechamber? Probably. But what happens is what we saw. It's a lot of cases we had long time back, not now. Case like this, when there's a PCR, the surgeon puts one haptic there. The second haptic he doesn't PCR. He doesn't know how far it extended. Then do it. So then after some time, maybe 3-4 months or 6 months down the line, the PC fibrosis very well. So a little bit vitreous is there. You do vitrectomy. You have a nice fibrous PC. Then you can dial the lens. It's very unusual to PC to extend up to the journals. There will be PCR vitreous, so they keep it. So you can redial it. So if there is it's unstable, then you have to explant to either iris claw or a scleral fixation. So that will take care of this condition, and long-term patient should be, once you go, the trauma is gone, the cornea will recover slowly for my case.
For this patient, actually, just radial this IO into the back.
We had to do
It will not go into the
vitrectomy.
back.
We had to do vitrectomy. First thing is vitrectomy, either pars plana or anterior. We had to, even if you don't see vitreous also, you have to do vitrectomy. If you, without vitrectomy, you redial it also, it won't redial, and you have so many problems. Fast vitrectomy has to be done.
Since it is already 6 years now, it's unlikely that the haptic will go inside the back. It will be in the sulcus.
Sulcus only.
So either it will cause pigment dispersion, or it may again come back after some time.
Lenses in the sulcus, they don't cut pigment expression. Only hydrophobic IOLs, they completely pathology. The mechanism is different. They are highly tacky material. Metal is different. Edges are different. They cannot be polished. They're completely different. PMMA, if you see the haptic and if you are sure it's a PMMA lens, which is quite easy when differentiate from hydrophobic acrylic, then if it is a hydrophobic, explant and do a iris claw or put a 3-piece
No, basically, probably one second part of the question would be like, will you do anything for the cornea, or just leave it for it to heal? Just take care of the cause, not the effect.
Yeah, it will recover. Only thing is when you are doing dialing all manipulation, if you want to do it, use viscoat or RO coat as with this, cohesive one which will protect endothelium than methyl cellulose.
Yeah, it's outside the pupillary area, so you can actually leave it, observe it, and since the cause is taken away, probably that edema may resolve over time. Siddharth, anything to add?
Thank you.
Thank you, Dr.
Nicely
Fatima.
presented, Dr. What's the name? Fatima. Nice presentation.
I request Dr. Sudha K to kindly present a memento to Dr. Fatima as a token of our appreciation. Dr. Sudha K, madam. Dr. Sudha, madam, please. Sorry, madam. Dr. Sudha Ji, madam, presenting the memento to Dr. Fatima. Thank you. Next, I'd like to request Dr. Vijayan K to present mementos to our panelists. Dr. Sujit Nayanar. Sir.
ഇത് ഡ്യൂപ്ലിക്കേറ്റ് ഉണ്ടെങ്കിൽ ഡ്യൂപ്ലിക്കേറ്റ് ഓക്കെ ഇത് ഡ്യൂപ്ലിക്കേറ്റ് എങ്കിൽ അത് ഡ്യൂപ്ലിക്കേറ്റ്
Dr. Vijay Lakshmi, madam. Dr. Irshad, and Dr. Aisha.
So start our second session on glaucoma after this power-packed cornea session. I would like to invite the panelists for the session. First, I would like to invite the moderator for the session, my respected teacher with more than 30 years of experience, Dr. Jyoti PT, who is presently the professor in HOD, Department of Ophthalmology, KMCT Medical College, and former professor in HOD of Ophthalmology, Government Medical College, Calicut. I would also like to invite Dr. K.S. Chandrakanth, Chief Consultant Eye Surgeon and Medical Director of Chandrakanth Malabar Netralia. He is a former Senior Consultant, Arvind Eye Hospital, Madurai. He is a reputed surgeon with a vast clinical experience and an excellent surgical expertise. I would also like to invite Dr. Shanti Sunil, Senior Consultant Glaucoma and Cataract at Trinity Eye Hospital, Calicut. She is specialized in glaucoma and cataract with more than 35 years of experience. I would like to welcome Dr. Manjusha Rajesh, glaucoma's consultant at Dr. Sreekanth Eye Care and Research Center. It is my proud privilege to invite the first speaker for this session, Dr. Satyan Parthasarthi. He is the director of Satyan Eye Care Hospital at Coimbatore and Coimbatore Glaucoma Foundation. He is the former Chief Glaucoma Services at Arvind Eye Hospital, Coimbatore. He has performed more than 75,000 cataract, glaucoma, and other eye surgeries and laser procedures. He is a teacher and a trainer and a new product innovator. He is a guest faculty for various national and international meetings and has published many articles in peer-reviewed journals. Dr. Satyan will enlighten us on when to refer known glaucoma patients for surgical management. Over to you, sir.
Madam, I have one more here. Thank you. Sorry about that. Very good morning and welcome you all for this wonderful meeting. First of all, my sincere thanks to Sreekanth and the entire team from Dr. Sreekanth's Eye Care Hospital. It's wonderful being in Calicut. I keep coming almost alternate months. So I started coming to Calicut ever since 1993 for the camps. So it still keep on going on. Such a nice, wonderful place and the audience. I have an importance in this particular slide because the topic is like that. It is a surgical management of glaucoma, when to refer. So both there is a surgery reference. So there is a financials in this. So I don't have any financial disclosures for this particular talk. So basically we need to understand when we are treating the glaucoma, we are not trying to completely eradicate the disease from the eye. It is going to be there. Throughout the patient's lifetime, the disease is going to be there. Our goal is to see how much we can really maintain for the patient so that he can maintain his daily works, the quality of life. He is reasonably maintained till his lifetime. So that we can really eliminate the sight to threat or threat to vision. That is the concept is called as a threat to vision, TTV we call it as. So how many of you feel that the glaucoma is a surgical disease? Can you just raise your hand? Is glaucoma a surgical disease or glaucoma a medical management? Surgical, how many of you? One half hand. The remaining everybody seems to be, you are a referral doctor, so you want to raise both hands. All right. As far as I am concerned, after practicing glaucoma for almost 30 years, I still feel glaucoma is a kind of a surgical disease. What we need to do is we need to maintain the IOP between 8 to 12 millimeters of mercury so that the patient is kind of more or less stable, so he can kind of maintain his quality of life throughout his lifetime. So this is the concept I was trying to tell you, that the threat to vision. Always there is a role of the intraocular pressure. Though we know that glaucoma is not the disease of intraocular pressure is just a risk factor. We have the other risk factors as well. But when you really take the advanced glaucomas, we have mild, moderate, severe and advanced. So severe and advanced glaucomas, there is no point in you maintaining the pressures at somewhere around 18 or 19 or 17, though we call it as a normal range of pressures. We need to bring it down to somewhere around 10 to 12 or 8 to 12. That is the range that you need to maintain. Otherwise, the patient is definitely going to progress. We are always happy. At this time, from a background of Aravind Eye Care System, we used to write CST for if the pressures are say around 17 or 18. CST is continue the same treatment. 18, 19, you continue the same treatment. But that doesn't hold any good, because the moment you start understanding the disease better, then you will know that the patient is definitely progressing. If you are not going to do your OCT or the visual fields, you are not going to understand whether the patient is progressing or the patient is having a stable disease. At the same time, you might think that you are just treating only an ocular hypertension with IOP of 30 or sometimes it goes even up to 40. You may see the disc is completely normal. But what you see on that particular day is not the patient is having. The damage has happened. Now we have to wait and see only after 12 weeks. That is the time where it will be shown in your OCT or in your visual field. So it is completely different perspectives that you have to understand. So what do you really mean by TTV is threat to vision? So when you have no other options, that is unavailable, inappropriate or ineffective, then you got to go for your surgical indications. So before you decide to go for the surgery, you have to make sure that whatever the measurement that you are doing in with your applanation, make sure that you measure it in the morning, afternoon and in the evening hours. Whenever you see your patients in the evening hours, the IOP is always on the lower side. You might think the patient is stable with the IOP of say 17 or 16 or whatever, but that is not the true IOP which you are really seeing. Always the IOP spikes happens in the morning hours or in the afternoon hours. You have to remember this, the diurnal fluctuations. Some people morning it happens, some people in the afternoon it happens, some people both morning and afternoon it happens. Evening there is a dip. The moment when you are seeing the IOP in the dip period, you might think the disease is under control, which is completely not true. So keep it very practical. Measure the IOPs at different time periods so that you can understand the disease pattern much better. You might not appreciate the micro level changes which is happening in the optic nerve head. By looking at the optic nerve head in your fundus photograph or with your 90D, today it doesn't hold good. So we have to understand that OCT and the visual fields plays a very, very critical role. And understanding the OCT also very critical. Many times now my job is to see whether the patient really has the glaucoma or is it that something else like a toxic optic neuropathy or nutritional optic neuropathy, or there are so many other neuropathies which probably we are missing and thinking that as a glaucoma. So just make sure that IOP measurements are multiple times, and you have to really make sure that it is a definite glaucoma and there is a definite occurrence of progression which is happening. Without any progression, if you are just going to do, then of course there is an indication for that as well. So looking at this particular concept of threat to vision, there are multiple factors you can consider, but you don't have to have all these factors. You can have your own factors and say, okay, for this reason I'm going to do the surgery. So age, then you have the amount of damage the patient has, other treatment options are unavailable, you have intraocular pressure as a risk factor, then progression, the poor compliance, all these kind of indication for surgery. So picking up one by one, not going to be in the depth, but at least some practical points for you to take home is that anyway we all going to treat only the intraocular pressure. The other things are we have a very less idea is that it is first of all it is there, and what is the best management we really don't have a full understanding about that. We have only the supportive role to play. So IOP is the one which we are going to treat. So as of now there is a misconception about the central corneal thickness and its role in glaucoma management. The central corneal thickness is very useful only when you have borderline cases like glaucoma suspects or the ocular hypertensives, whether you want to treat or you don't want to treat. But in an established case of glaucoma, don't keep that central corneal thickness and then try to manage the patient based on the central corneal thickness. It will never work out. The patient has already having the disease. Now it is for you to treat it properly. The central corneal thickness gives you an idea whether this patient is going to be a fast progressor or is it going to be a slow progressor. Having said that, it is just a very minimal role in an established glaucoma because the patient definitely has the disease. It is a matter of whether he has a higher risk of progression or has a less risk of a slow progression. That is the only thing which we need to understand. And also whatever the nomograms which we have is still not sufficient enough for us to take the CCT as a very strong indicator that based on that you can do the management. So in an established glaucoma, CCT has almost no role to play, which you need to understand. The next thing is, as I told you, the intraocular pressure level has to be taken for that particular patient and to see how much is the progression. In an advanced glaucoma, 15 is high, 16 is also high. Probably you have to maintain somewhere around 8 to 10 or 11, something around that. It has to be throughout the day, not only at morning hours or the evening hours. Same way, when the ocular hypertension goes beyond 30 or 35, then again there is a role for you to think about the surgical options. So the degree of damage, most of our patients they do come in the late stage of the disease. If you are going to play around with your one single medication, 2 medications, 3 medications, 4 medications, it is your discomfort in doing the surgery, it is not the patient's problem. Please understand, I have a problem in doing the surgery in all these patients because the patients are on polypharmacy. The moment you put the patient on polypharmacy, my results goes down dramatically down. So please don't do that. If you can advise the surgical option much earlier, the results are much better. Those patients whom I have done in the 96, 97, 98, those period of time, they have a much better success rate than those who are on polypharmacy with 4 drugs, 5 drugs or 6 drugs. We are happy in giving the medication, but we don't understand how much the patient has to go through that suffering. So more the damage, take up the patients much earlier than doing all your drug trials on those patients. More than 2 drugs if you are going to give, I feel in my own personal opinion you are a criminal. If you are going to give multiple drugs, it is just your inability to do the surgery than just thinking that the patient is doing well. That's not a good idea to go with. But this is all I am talking about, much more practical. This is not for the PGs to tell your teacher when the examiner is there. So just be aware of that. Then you have the progression. Of course, you have to do your proper visual fields and you have to understand the OCT if you are going to say there is a progression in the OCT. OCT is little bit difficult to understand because each OCT behaves in a very different way. And if you have not identified your the Brooks membrane opening, and if you have not taken a proper OCT and you think that the patient is progressing, then probably you are not in the right track. So you have to understand the OCT and the age. Again, we have the misconceptions on the age. Those who are around say 75, you might think, okay, the astrologer has told he is going to live only for another couple of years, which is not true. He might live for another 10 years, but the guy who is 35, he may pop off in the next year. But in general, what you can think is 35 years, he has always calculated for at least 90 years. So 30 is 60 years remaining period. Can I manage him with the medications alone? 2 medications, 3 medications, 5 medications. It's not possible. You have to think about the surgical options much earlier for him than those with the elderly people like 75 or 80 or 85 years. So think about the age is one of the major indicators for you to understand. And of course the compliance to medical therapy, even for the people who are on treatment for the AIDS or the carcinomas, they really may not be very compliant. So just understand the compliance is one of the major issues that you have to think so that the surgery can be done much earlier to protect his side. But those with the secondary glaucomas are much more faster in progression, and also their IOP controls are not very good many times. Of course, we have to think in the other way also. Like we have our retina colleagues, they are our best friends because they do give us a lot of patients. And cardiac people also post keratoplasty, invariably they will refer it to us. So they are the best friends, so keep them happy all the time. See, these patients might reverse very quickly also. So silicon oil induced or just a post, band surgeries, they come down in intraocular pressure levels also. Also, those who are receiving the intraocular injections, especially the Ozurdex or any Tricot, all this, they do settle down properly. So you have to be a bit careful on whom you want to advise the surgery much earlier. So then of course the reasons for economy is another area. This is one of the major factors for us. We might think the patient is okay to buy another 100 rupees, 200 rupees drops, but he may think that other options are better for him. So just think about all these reasons and then you can indicate the surgery. And what is the optimum medical therapy? Where you feel the patient can tolerate 2 drugs, 3 drugs, 4 drugs is the optimum medications. It is not that you have 6 combinations, 7 combinations. It may be only a single drug, which is an optimal therapy. So once he crosses his optimal medical management, then of course he is going to lose his compliance and then you have to go for the surgery. As the want of time, we'll have the discussion time. That time we can discuss. So I'll just stop with this because glaucoma people, cornea people like Reddy and we are all little old people. You just give us the podium, we keep talking. So I'll just stop with this and then during our discussion time, we'll have more discussions. Thank you so much.
Thank you, sir, for that informative talk. I would like to call Dr. Shabib to give a token of appreciation to Satyan, sir. Thank you, sir. It is my great honor to invite our next speaker for this session, Dr. S.J. Sai Kumar, who is the Medical Superintendent and Head of Cataract and Glaucoma Services, Giridhar Eye Institute, Cochin. Armed with the experience of more than 20 years, he has done more than 55,000 cataract surgeries. He is a DNB teacher and a cataract surgery trainer. He has presented posters, papers, and instruction courses at state, national, and international conferences. He is our past president KSOS and was organizing secretary of the hugely successful AIOC 2023. A warm welcome, sir.
Thank you.
Dr. Sai Kumar will give us an overview of secondary glaucoma. Over to you, sir.
Thank you. It's a great pleasure to be involved in a CME done by a very, very close, sincere friend, which is Sreekanth. And thank you for inviting me once again to your CME in the presence of a lot of senior luminaries in various fields. And it was a pleasure to meet Bhatt sir today morning and receive his blessings before I start this talk. Although I started my post-graduation in Calicut, I was here only for 3 months and then I shifted to Trivandrum. And when I shifted, the late Venkadachalam sir told me, "Njangadathu odi rashappedukaanalle." So I still remember, but the very short 3-month stint I had in Calicut, Raju sir also was there, was very fruitful. And with these few words of introduction, I will just move on to the topic, which is secondary glaucoma. Now, secondary glaucomas by itself is a very vast topic. So I have been given 12 minutes to speak on all secondary glaucomas. Each individual thing is a 15 or 20-minute talk. So I'll just very briefly go through the secondary glaucomas, and like Satyan said, probably we can take up some questions in the interactive discussion. What I will try and do is, after each of the topic or each of the subset of secondary glaucomas that I mentioned, I will just give 1 or 2 take-home points. Thank you. So before we go on to the topic, probably at each one of these points, I'll just give 1 or 2 take-home points which may be useful to all of you. So we'll be basically going through these headings. As I told before, it is a very, very vast topic, and so we'll rush through the individual glaucoma subsets. Pseudoexfoliation glaucomas is one glaucoma where I feel that probably it should not be even called a secondary glaucoma. It is definitely a severe form of primary glaucoma, where the people with pseudoexfoliation are at a higher risk for developing disc damage. So the general prevalence among the open-angle glaucomas is about 1/4. The prevalence increases with age, and about 25% of all pseudoexfoliation patients develop ocular hypertension, and within them about 30% develop glaucoma. Which means that whenever you see a pseudoexfoliation, does not mean that this patient is going to develop glaucoma. There are many patients with pseudoexfoliation, well-dilated pupils, who don't have any problem either with glaucoma or during cataract surgery. But some of them definitely go into glaucoma, and we have to follow them up very closely. There is a very strong genetic association with a specific mutation, and there are some other theories about how pseudoexfoliation develops. The white material of pseudoexfoliation, we all know, they form a particular pattern. This pattern is supposed to be due to rubbing of the iris on the anterior lens surface, and you also see these deposits on the edge of the iris, in the angle structures, and even on the lens zonules you can find this material. The clinical features which are of importance, especially for a cataract surgeon, is phacodonosis, poor mydriasis, pigments and pseudoexfoliation material on the corneal endothelium, and they definitely have what is called a pseudoexfoliation endotheliopathy. And many of these patients, when you have a slightly difficult cataract surgery, they do have persistent DM folds for quite some time after the procedure. These are the gonioscopy findings, where you see these patchy irregular lines, which is called a Sampolosi line. So the presentation in chronic open-angle glaucoma is basically due to trabecular cell dysfunction and obstruction due to the iris pigments. Once in a while, pseudoexfoliation can present with acute glaucoma. It can either be an open angle where you have a very severe IOP spike. It can also happen in a narrow angle setup, where due to the zonual weakness, the entire lens iris diaphragm move forward, and produces a narrow angle glaucoma as well. So within glaucoma, you can have various presentations with pseudoexfoliation. The primary line of treatment is with prostaglandins. Then you think of laser trabeculoplasty if it is an open angle, iridotomy if there is a concurrent angle closure. And like Dr. Satyan said, I think these are all patients where we would like to go for an early trabeculectomy, because pseudoexfoliations usually cause significant disc damage. I am not very familiar with the non-penetrating surgeries, and I don't know whether mix is very popular. Probably we'll take up that point during discussion. So the key points about pseudoexfoliation that I want to mention is that it's generally bilateral, but it can be asymmetrical. We have also patients who have strictly unilateral pseudoexfoliation. Greater glaucoma damage at the time of diagnosis, faster progression of visual fields, greater IOP fluctuations, poor response to medical treatment, and an increased need for surgical intervention. The clinical course compared to a routine primary open glaucoma may be different, and the course can be worse with a poorer prognosis. We come to the second NDT, which is pigmentary glaucoma, common in myopic males about 30 to 50 years with glaucomatous disc damage, and you find this pigment granule depositions in the anterior segment. This is supposed to be released from the iris, and because of that you see these very typical transillumination defects. So you can have this active pigment dispersion phase initially, then they go on into glaucoma, and theoretically at least there is supposed to be a regression or a burnout phase, although clinically we do not see it because significant glaucoma damage would have occurred by the time you see the phase 3. There is this mechanical theory that the pigments rub on there is a posterior bowing of the iris and the area of the zonules where the iris rubs on the anterior lens capsule and these pigments are released. This is the most common theory that is being used or propagated as far as the etiopathogenesis of pigmentary glaucoma is concerned, and they cause denudation and collapse of the trabecular meshwork, aqueous outflow obstruction. There are certain other things, and there are reports of what you call a pigment shower or a pigment storm after acute physical activity in these patients. So you have this typical triad of Krukenberg spindle, peripheral iris transillumination defects, and pigments in the anterior trabecular meshwork, a deep anterior chamber, and sometimes pigments deposited at the posterior capsule near the zonules, heterochromia and anisocoria. The gonioscopy shows a very dark brown pigmented trabecular meshwork, and the degree of pigment dispersion is supposed to correspond to the degree of severity of the glaucoma. So the more pigments in the angle, the more severe the glaucoma. Laser trabeculoplasty is supposed to be one of the methodologies because the pigment, the laser energy is taken up well by the pigment. One of the evidences of the mechanical theory is that laser PI definitely reduces so this is one of the conditions where you do a laser PI in a deep anterior chamber. And of course, if doesn't get controlled, trabeculectomy. So we come to the third entity, which is steroid-induced glaucoma. Again, elevated IOP causing optic nerve damage in predisposed patients, triggered by use of local and systemic steroids, but definitely local more than systemic. The risk of IOP elevation is more with, as I mentioned, with topical, and more with the potent steroids. And as again Dr. Satyan mentioned in his initial talk, that these intravitreal injections now cause significant problems. So more and more of our retina colleagues now don't prefer Ozurdex or triamcinolone, and because the same indications you can manage with anti-VEGF agents, and so the indications have sort of changed. There is upregulation of a myocilin gene in the trabecular meshwork, which causes alteration of the trabecular membrane morphology and causes deposition of glycosaminoglycans in the trabecular meshwork. So when you have a prior history of glaucoma, be careful. Those patients who already have primary open glaucoma or have a family history, you have to be careful. Previous steroid response, you have to be careful. And type 1 diabetes, clinically I have not observed that, but at least literature mentioned that type 1 diabetics are slightly more prone for steroid-induced glaucoma. So the management would be to stop the steroids, switching may be very, very essential to a milder steroid, and the drops and the filtering surgeries. So one point that I would like to highlight about steroid-induced glaucoma is that when you see a patient with a glaucoma which is non-progressive, with a normal intraocular pressure, please ask for history of steroid use. Because we do quite often see patients, some patient may be in his 40s, they come with glaucomatous damage, but you observe them over a period of time, the glaucomatous damage remains absolutely the same. They have, intraocular pressures which are absolutely normal. So if you just look back and ask them, probably they would have used steroids for 3 years or 5 years during their childhood for a spring catarrh or something like that. So these are non-progressive glaucomas probably which you don't need to treat. But this history of steroid use in their childhood gives us a clue that this damage probably occurred due to a high IOP during the steroid use period. The next entity that I would like to discuss is uveitic glaucoma. Again, you can have both the open angle and the narrow angle varieties. In the open angle, you have the mechanical obstruction of the trabecular meshwork, inflammatory mediators, trabeculitis, and sometimes in uveitic glaucoma also you can have a steroid response. So, a uveitic patient with a steroid response can cause a raised IOP, although generally in uveitis the initial IOP is actually lower than normal. And you can also have the closed angle mechanism due to posterior synechiae, peripheral anterior synechiae, and rarely forward rotation of the ciliary body. Treatment is basically treatment of the uveitis, treat the systemic inflammation, and probably this is one of the conditions where steroids reduce intraocular pressure. So when you have a large amount of inflammatory material going and blocking the trabecular meshwork, causing an increased intraocular pressure, and when you use steroid, the intraocular pressure along with the inflammation comes down. So this is a condition where steroids actually treat the intraocular pressure instead of causing an increase. Neovascular glaucoma is one area in which we have done a lot of work. It is an aggressive form of glaucoma, and at least in my experience, the CRVO NVGs perform much more worse than the diabetic NVGs. The advantage being this, that CRVO NVGs generally are unilateral, unlike the PDR NVGs, which are generally bilateral. Some can be asymmetrical as well. So we know various causes, but practically in day-to-day practice, two entities you have to be look at very carefully. One is CRVO, other one is PDR. Of course, with BRVOs and hemi-CRVOs also we can get, but there are a lot of other entities which can cause neovascular glaucoma, which includes inflammation, tumors, and a lot of other entities. So we know this classic, progression of open angle, stage of rubeosis, then open angle, and then finally closed angle glaucoma. Anti-VEGF injections have changed the management of neovascular glaucoma in the last decade. This is one gentle change that has occurred. But just one point that I want to tell you is that anti-VEGFs do not treat the basic cause for neovascularization. The basic cause for neovascularization is retinal ischemia. You have to tackle the retinal ischemia in the long term if you have to control the neovascular glaucoma, which means that the anti-VEGFs give you a window period. If you have, a lot of aggressive new vessels, you give anti-VEGF, the new vessels all regress, but that is a window period for you to either operate or go in and ablate the retina and make sure that the retinal ischemia is taken care of. So the retinal ischemia basically produces VEGF. The anti-VEGF just tackles the VEGF, but it does not treat the basic cause for the neovascularization. Post-traumatic glaucomas, you can have various varieties. Acute pressure rise due to hyphemas, angle recession, which can cause a long-term glaucoma. Iridodialysis by itself will not cause glaucoma, but iridodialysis is usually associated with trabecular damage and significant damage to the trabecular meshwork, causing secondary glaucoma. These are the various entities. Again, you can have, vitreous in the anterior chamber, uveal effusion, various types of mechanisms for post-traumatic glaucomas. Management initially again would be medical, management of the hyphema, control of the inflammation, and in cases like angle recession where the intraocular pressure is persistently high, you can go in for a filtering surgery or a glaucoma drainage device. I don't know why my fellow who did these slides for me made a very laughing emoji for lens-induced glaucoma. I tried to remove it, it is not going. So lens-induced glaucoma are not laughing matter. You can again have an angle closure mechanism as well as an open angle mechanism. The open angle would be the phacolytic and the lens particle glaucomas, while the phacomorphic would be the angle closure mechanism. And the terminology which is used of late is the phacotopic glaucomas, which are the ones associated with ectopia lentis. All your Marfans and things like that. Generally not very high incidence of glaucoma, but they do occasionally cause. So I'm not again going into the details. The phacolytic is basically due to the lens proteins. we have the chamber will be deep. You have lot of flare and lens material in the anterior chamber, causing secondary glaucoma. And lens particle glaucoma, again due to either a trauma with the breakage of the anterior capsule or a post-surgery where you have left behind lot of cortical material, and rarely an immune mechanism which is called a phacoanaphylactic glaucoma. On the other hand, the phacomorphic glaucomas would be the ones which have a mature or a hypermature intumescent cataract causing an angle closure. And the ectopia lentis ones are the Marfan's, the homocystinuria, and the other varieties. So one of the important questions that is always asked in a lens-induced glaucoma is, should I just remove the cataract or should I do a combined surgery? This is a common, actually I get referrals for lens-induced glaucoma referred for combined surgery. So my general feeling is that, again, this is a point which we can take up in discussion, is that generally a cataract surgery should be enough for most of the lens-induced glaucomas. Unless you have a very severe inflammation, a lot of peripheral anterior synechiae and things like that, cataract surgery by itself should treat the entire mechanism of glaucoma, unless there is a significant damage. So generally, and we don't know, we can't see the optic disc. These are all white mature cataracts or hypermature cataracts. You don't know what is the condition of the optic nerve. So without knowing that, generally I wouldn't, but I always go in for a temporal phaco, or if possible, or for a temporal SICS, so that will leave the upper portion behind in case the patient needs a filtering surgery later on. Aqueous misdirection, again, post-PI or post-surgical malignant glaucomas where you have a uniformly shallow anterior chamber. These are some of the OCT and photographs of malignant glaucoma. Again, dehydrate the vitreous, laser hyaloidotomy, easier said than done. Quite often difficult to get a hyaloid breakage with a YAG laser. Surgically, you can go in and disrupt the anterior hyaloid face, remove a bit of vitreous. I usually ask my retina colleagues to help me in these situations. A few other not very common entities before I wind up. The essential iris atrophy, Chandler and Cogan is together called the eye syndromes. Generally unilateral, usually have significant corneal problems also along with the raised intraocular pressure, so both have to be handled together. And the post-ocular surgery glaucomas, again along with pars plana vitrectomy and scleral buckling, intravitreal gas injections, and the ones after penetrating keratoplasty. And one final point before I wind up is regarding the post-vitrectomy glaucomas. So we have seen that in PDRs, especially the diabetic vitrectomies, where either you use gas or you use oil, the immediate post-op looks pretty much good. In about 2 to 3 weeks' time, all these patients develop an angle closure sort of mechanism. There is an anterior bowing. The inflammatory material comes and blocks the pupillary area. The iris bows forward, almost touching the periphery, forming peripheral anterior synechiae, and significant increase in intraocular pressure, 40, 50, very difficult to manage. You have to give intensive steroids, try a few YAG PIs, release out whatever fluid is there. But of late, I have been operating on these patients with a filtering surgery, and they do pretty well. So you go in, release all the adhesions, do a good trabeculectomy, and again start on intensive steroids. Many of them do require. Earlier we used to manage them with YAG, PI and medicines, but some of them did really badly and we lost a few eyes. So I am doing a few more early trabeculectomies in these sort of patients, the post-PPV patients. So thank you for your kind attention, and we can take up whatever questions we have in discussion.
Thank you, sir, for the informative talk. I would like to call upon Bhatt sir to give our token of appreciation to Sai Kumar sir. Thank you, sir. Next, we have a case presentation by Dr. Hiba Abdul Rauf, a PG student from KMCT Medical College.
Good morning. Good morning. Hereby presenting a case of a 62-year-old male. He is a known case of diabetes mellitus and he is on insulin since 7 years. He is also a known case of diabetic nephropathy since 8 months. He is having a history of a defective vision in both eyes since 1 year, and he was already diagnosed as diabetic retinopathy in both eyes. So by August 2023, he already had a history of 3 sittings of panretinal photocoagulation in the right eye and 2 doses of intravitreal injections in the left eye. Now 4 months later, by December 2023, he developed a history of pain in the right eye as well as a right-sided headache. On examination in the right eye, there was a mild congestion in the conjunctiva with clear cornea and quiet anterior chamber with a shallow grade of Van Herrick's grade 2. And the iris showed new vessels, 360 degrees with an ectropin UVA. The pupil was 5 mm dilated with both direct and consensual light reflexes sluggish and immature senile cataract. The left eye anterior segment was found to be normal with no new vessels in the iris. The visual acuity in the right eye was 636, in the left eye was 6/24, and it did not improve with pinhole in the right eye, and it became 6/6 in the left eye on pinhole examination. Near vision in both eyes was N18. When we checked the intraocular pressure with applanation tonometry, right eye showed 48 millimeters of mercury and left eye showed 20 millimeters of mercury. Gonioscopy revealed close angles in the right eye with new vessels in the angle in both nasal and temporal quadrants. On fundus examination, we could see that there was a advanced diabetic eye disease picture in the right eye with some old laser marks, and the left eye showed a moderate NPDR picture with diabetic maculopathy. Now he was started on 5 anti-glaucoma medications, namely brimonidine, timolol, dorzolamide, bimetoprost and riparsudil. But the intraocular pressure and the pain was not decreased even after usage of these 5 anti-glaucoma medications. So thus we did a trabeculectomy with mitomycin C in the right eye in April 2024. Now on follow-up, the sclera showed a functioning filtering bleb. The conjunctiva became normal, cornea is clear and with a VH2 grade anterior chamber. Iris showed regressed new vessels in the iris with a peripheral iridectomy. Pupil has become 3 to 4 millimeter size with both direct and consensual light reflex sluggish and an immature senile cataract. The vision improvement we can see, preoperatively in the right eye it was 636, postoperatively right eye has improved to 612 and the left eye 618. Right eye preoperatively was N18, postoperatively near vision has improved to N12. and in the left eye it is N18. Now the intraocular pressure, when we measured, we have found a decrease in the right eye from 48 millimeters mercury preoperatively to 22 millimeters mercury postoperatively. Left eye showed 20 millimeters of mercury. Gonioscopy revealed closed angles. A provisional diagnosis in the right eye, neovascular glaucoma due to advanced diabetic eye disease, status post trabeclectomy with mitomycin C, and in left eye, moderate NPDR with a diabetic maculopathy. Thank you.
First of all, I thank Sreekanth Eye Care for giving us this opportunity to chair this session. And I thank Dr. Sai and Dr. Satyan for that excellent presentation, which I'm sure will be useful to the comprehensive ophthalmologist and postgraduate students alike. This case presentation actually, this is a case of neovascular glaucoma secondary to proliferative diabetic retinopathy in the right eye, which was extensively treated. The retinal ischemia was treated with PRP and anti-VEGF was given prior to trabeculectomy with MMC. And this was refractory to maximum medical treatment. He was on 5 medications. Still the IOP was 48. And after doing this trabeculectomy with mitomycin C, there was a very good response. So I would like to hear from the panelist what would be the line of management in such cases.
No, once a proper retinal ablation has been done and judicious use of anti-VEGFs are done, then this is the right method of management. So you have got to, rather than waiting for 5 medicines and then waiting for it to work. But then we all tend to, especially in NVGs, diabetics, otherwise would be sick. We wouldn't advise surgery straight away. So we'll try maximum medication before going in for surgery. And again, use of mitomycin is something that's very, very important. Generally, the traditional teaching was that NVG traps have a high failure rate. Failure rates are now definitely better with mitomycin, but in case it doesn't work, again, probably a tube would be a better option for these patients. But at the same time, you have to keep a look at the retina, look for any additional, neovascularization or subhyaloid bleed and some things like that. Then probably you may have to go in, do a pars plana vitrectomy, do an endolaser and things like that. This would be my comments on this particular case.
Thank you, Doctor, for your wonderful presentation. The only concern for me is the fundus picture was little different.
Yes.
I'm not sure whether for the presentation you have just taken these fundus photographs.
I didn't get the previous fundus photograph actually.
So then it is fine. Yeah. As long as it is not belonging to this particular patient, it is okay, but otherwise it doesn't match your presentation. So that is the first thing. The second thing is we got to remember, unless you see a regression pattern post anti-VEGF, you should not touch these eyes for the trabeculectomy, especially with IOPs of 40 plus. The moment you touch trabeculectomy with the NVI on, that is the active NVI, that means you can forget that these patients are going to bleed like mad on the table. So you have to make sure that the NVI disappears completely. The moment you give the anti-VEGF, within a couple of days itself, you can see a complete regression of the NVI. So just give it a week's time, but you have to give the steroids either plus homemade or atropine to make sure that the eye is really quiet, and then you can take up for either as a trabeculectomy, or one of the primary indications for the tube surgery is the NVG patients. It doesn't mean that you should not be doing a trabeculectomy. It does give a good results, and you have to do a preoperative gonioscopy to understand whether there is an NVA in the angle so that you don't do the punching in that area. though you give anti-VEGF, it does disappear. But what you see is sometimes in the angle, the superior part of the angle, we might come across a little larger ghost vessels. The moment you have the larger ghost vessels, we may think it is a ghost vessel, but the moment you punch, it will bleed heavily. So once you see the bleeding heavily, this is for the people, whoever is doing the trabeculectomy, we have to go with the ethamslate tablets, or as an injection also is available. Ethamslate tablet 3 times a day. You may have to continue for 2 weeks or even 1 month. It is very harmless. So these patients, it is sometimes called as a reactionary hyphemus, though we don't say immediate bleeding or is not reactionary. But these patients will start bleeding even after a week's time. The interesting point about is, even if it is not bleeding on the table, some of the patients will bleed after a week or 2 weeks' time. That is again because of the mitomycin. So mitomycin has a property of reducing the platelet counts. By day 2, day 3, platelets will come down, and also at the end of 14th day cycle of mitomycin. So we need to understand the hyphemas in TRAB really may not be corresponding to the NVG as such. It may be because of the mitomycin also. Some patients do have their hyphemas even after a couple of months later also. So that is all induced by the mitomycin. If you really do the heme count, then you will really understand that. So it is not that end of the story for this. We might have to go for a repeat injections of mitomycin, subconjunctival repeat injections, or we might have to go for tube surgeries. So these patients need a proper diabetic counseling with a complete control so that the progression of the diabetic retinopathy is arrested. The second concept of NVG I just wanted to add is, we may think that the development of NVI is from the posterior to anterior. It doesn't happen like that. Because of the anterior segment ischemia, it is not the anterior segment ischemia. Because the posterior segment ischemia, from the anterior segment, everything goes towards the posterior segment. There is a hypoxia which is developed in the anterior segment after that. So that is how the NVI develops. So we have to really aggressively treat the NVI before the patient goes in for the stage of angle closure disease. So my few points on these NVG cases.
I would actually do a TRAB even before a week, because in about 72 hours time you can see that the vessels are nicely regressed. About 4 to 5 days would be my ideal window period before I go in for a TRAB. Dr. Thomas had to make some comments about the post-vitrectomy glaucomas.
Yes, that was an excellent overview of the secondary glaucomas, and you did a decent job in 12 minutes. 1 or 2 comments about post-vitrectomy glaucomas. One is the gas-filled eyes. You said in 2 to 3 weeks it comes, most of the time it has developed a peripheral anterior synechia and you end up doing a filtration surgery. But there is another group which comes in the first week itself. You send the patient, of course, with an advice that in case you find something amiss like vomiting or headache, severe headache, you report back. And in 1 week, sometimes you find that the IOP is this 40-50. And most of this happens because of the wrong concentration of the gas which has been filled, and it absorbs more air, absorbs more nitrogen, and the intraocular pressure goes up. In such situations, immediately put in a needle, take out some gas, make it a bit hypotonous, and give maximum treatment, and usually this gets resolved in a week's time. And you have to maintain the patient on glaucoma medication till the entire gas is over, and even for some more time. Second is about the silicone oil filled eyes. There also you have a lot of intraocular pressure going up. Mainly there are 3 reasons for this silicone oil filled eyes going for intraocular pressure rise. One is of course the pupillary block and a shift in the iris lens diaphragm anteriorly. Second is emulsified oil blocking the trabecular meshwork, and the third is trabeculitis as such. So these also you have to maintain the patient on maximum medical therapy till the oil is out and again for a long time, and then taper the drops one by one, and at some point of time you might have to go for a filtration surgery. So that's about oil-filled eyes. Thank you.
He had diabetic maculopathy also with.
But 6/6 with the
Yes.
N18, how it is possible, I really don't
There
know.
was
The left
also-
eye.
Okay.
The left eye.
Left eye.
Right eye, is there something else other than diabetic retinopathy? Is there a CRVO or ischemic syndrome superadded on that? Because the patient is diabetic. Left eye, there only PRP was done. No
Yes.
anti-VEGF was injected in the right eye. Why is
Left
that?
eye intravitreal injections were given,
Left
ma'am,
eye.
because
in the right
diabetic
eye it was
macular-
not given.
In the right eye only PRP was given.
Why is that?
Because it was already diagnosed as an early PDR in the beginning.
Even still, you have to reduce the VEGF, so you have to give anti-VEGF for PDR.
What was it, IOP on the day of surgery morning? Was it the same 40 or what is it?
On the day of
On the
surgery.
day of surgery. Pre-operative you don't have you measure the IOP, right? What was it? Was it 40?
It was always in a range between 40 to 50, sir.
Yeah. And with such a florid new vessels on the iris, it's highly risky to do opening of on the trap, because at least we could have, has mannitol been given on the table or before the surgery that day? IV mannitol. Mannitol.
IV mannitol,
IV
whether it was
mannitol.
given.
Yeah,
No.
intravenous was given, sir.
It was given, it was not mentioned there. So such a florid new vessels and 40 to 45 millimeter of mercury is very risky to do, because the chance of expulse is very much because of all the vessels in the problematic mode. So that has to be taken care.
How do you decide whether tube, the trabeculectomy or tube shunt procedure is better for a particular case of neovascular glaucoma?
Primarily, it is not easy. Generally, all of us do a trab with an MMC first. But if the pressure is very high, say 40, 50, you can't find a nice area on the conjunctiva where you can do a safe trabeculectomy. Patient has been on 4 or 5 medications for a long time with a lot of surface inflammation. Some of them, go into something like a pseudopemphigoid. That is why I thought the use of Sequa, I think, was very interesting today. Many of them, although we say that we have to do early trab and all, we see many patients who are on long-term medications. Conjunctiva is very bad. The moment you see the conjunctiva, you know this trab is going to fail 100%. So these are the patients where we would directly probably go into a tube. And tube also is not without complications in NVG. You can have even the iris tissue coming and blocking the tube. We have even seen bleeds in the posterior area of the conjunctiva where the plate is there. So it's not that it's without complications, but they do apparently have a better long-term result compared to the traps.
What about prostaglandin analogs you advise in neovascular glaucoma?
Generally no, because inflammation is a very, very important factor, and actually in NVG, as much as you put any of these anti-glaucoma medications, steroids are very important. You don't hesitate to put prednisolone or whatever high steroid that you want to control the inflammation. The patient will also get a lot of relief in pain. The severe pain, although the pressure may come down only from 40 to 30, but the patient's symptoms are significantly relieved when you give steroids and cycloplegic along with the treatment.
Can I ask a question to Dr. Satyan? Dr. Satyan, during these 30 years of practice, how often could you manage medically with 1 or 2 drugs in a primary open angle glaucoma for long term?
I wouldn't even give that, madam. Because continuing the medication for a longer period of time with a good compliance, say for example the patient is 40 years, next 50 years we are asking them to put the medications, and we don't know how much of a damage that we are causing for his systemic condition. We think timolol is one of the most safest drugs. For me, timolol is the worst drug, because 1 drop of timolol can cause death. See, one tablet of propranolol, I developed severe dry eyes, severe dry mouth. We never ask what the patient is going through, and we don't even elicit because we don't even understand what is happening. So putting the patients on medication thinking that we don't really see anything, obviously, we think patients are safe, which is not the truth. So PGs definitely has a role to play as a safety part of it, but continuing the medications forever, because all these programs are being supported by the companies, we should not be going against them as well. But at the same time, we have to think about the patient as well. Is it really possible for him to continue the medications for the next 40 to 50 years? Old patients, okay, reasonable, they have their own problems. But one or two medications beyond that, I feel, as I told you earlier, we are all kind of, to a reasonable extent, criminals.
I think as a corollary to what Satyan said, I think a winding up comment is that doing a trab also is, don't have the feeling that once you've done a trab, everything is fine. So trab has to be done at the appropriate time. 100% agree with Dr. Satyan. But at the same time, these patients also, just like any other primary open, you have to follow them up. You have to follow them up. Sometimes the trabs fail long term. The patient still may have to be on 1 or 2 medications. So the target intraocular pressure is the final thing that you look at. So definitely, we have all come to realize that doing earlier trabs are much better than doing trabs in advance. What is the deterrent when you want to plan a trab in advanced glaucoma? You think this is going to wipe out. That is something which is overemphasized. There is a phenomenon called wipeout, but quite many a time we are scared that, oh, this is an advanced glaucoma. The moment I touch him, he's got 6/9 vision. Pressures are about 18/20, 6/9 vision, one-eyed patient. So you are afraid to touch these eyes. All of us, I think, all of us, including people who have been practicing glaucoma many years, we also do that. But then do your treatment before the patient reaches that stage. I think that would be something that is a take-home message.
Just one point. For neovascular glaucoma, when IOP is 40s, instead of giving 5 topical medication, better to control with the oral acetazolamide in the form of Diamox or sustained release to preserve optic nerve function.
Ranjani madam, you are absolutely right, but only concern for me is, again, the oral acetazolamide, how long will you be able to continue? It's for a short period of time prior to surgery, yes, or when the patient is having very high IOP, you can just bring it down. But then we cannot really use it for a long time, because we never ask for other problems what the patient has with the acetazolamide also. So having said that, just a word of caution is that once you do the trabeculectomy, as Dr. Sai was mentioning, it is not that it is always successful. But what we need to understand is, even if it is a failure in the trabeculectomy, the fluctuations in the IOPs are much, much lower than those who are on medications and the progression of the disease. The progression of the disease in a medicated eye is much more faster than those who had undergone the trabeculectomy surgeries, even if it is the target pressure is different in the sense. We can keep on discussing that. I think that we have to go with the next session. So thank you so much. We can discuss during our tea time. Thank you all.
Thank you, esteemed speakers and panelists, for that very informative session with lots of tips to take. I would like to call Dr. Beena Gopalakrishnan to present our token of appreciation to Jyoti ma'am. Chandrakant sir. Shanti ma'am. Dr. Manjusha. Our PG student, Dr. Hiba Abdul Rauf. Thank you, ma'am. So we are skipping the tea break and moving on to our third session in pediatric ophthalmology. I would like to invite the panelists for this session. First of all, I would like to invite Dr. Leila Mohan, HOD Pediatric Ophthalmology at Comptrust Eye Hospital, Kozhikode. She has presented in various international and national and international conferences. I would also like to invite Dr. Suma Unnikrishnan, Associate Professor at Government Medical College, Manjeri, and our present KOS President. I would like to invite Dr. Lakshmi C., Professor in Ophthalmology, Malabar Medical College, Kozhikode, and Visiting Consultant at Abate Eye Hospital. I would like to invite Dr. Arun Kumar, Professor in HOD of Ophthalmology and Vice Principal, Government Medical College, Kozhikode. I would like to invite Dr. Almas Abdul Aziz, Consultant Pediatric Ophthalmologist at Dr. Sreekanth Eye Care. It is with great pleasure I invite our next speaker, Dr. Sandra Z. Ganesh, Senior Consultant of Pediatric Ophthalmology and Strabismus at Arvind Eye Hospital, Coimbatore, with more than 18 years of experience. She has around 30 publications as first author and has presented at various national and international conferences. Her area of special interest includes complex strabismus, myopia, CVI, and amblyopia. Dr. Sandra is going to talk on the approach to refractive errors in children. Over to you, ma'am.
Thank you so much for the kind introduction. I should thank the organizing and one of my favorite fellows and students, Dr. Almas, for her kind invitation, Dr. Sreekanth. So I am going to talk about an approach to refractive errors in children. So before we talk about the refractive errors per se, I think we should know something about the dimensions of the eyeball in adults and children. As you can see, in the newborn, eyeball is really small. It's only around 17 millimeters, and the keratometry is very steep in small children. The corneal diameter is approximately the same. Even at birth, it's near about the same as adults. So the thing to understand is the majority of the ocular growth occurs in the first 18 to 24 months of life. So what's normal refractive error at birth? Most of the children are born hypermetropic at birth, and as they grow, they slowly become emmetropic. So this process is called emmetropization. And as the eyeball grows further, sometimes this emmetropization will overshoot and it will become myopia. So this is what is happening. So as you can see to the left, that is the hyperopic, the graph is skewed towards the left. So most of the kids are born hyperopic. And this is how the eyeball will slowly grow towards normal. And so in the preterm infants, myopia is more common and astigmatism is also more common. So I'm saying this because whenever you see these kids in the OPD, you have to keep this in mind. So compared to normal, the incidence of myopia and astigmatism is higher in preterm infants. Full-term infants are usually a little bit on the hyperopic side. Some very few of them are myopic. And in the preschool years, that is from the age of like 3 to 10, there is a rapid growth of the eyeball, probably around like 2 millimeters per year or so. And in the school age group, later on, in the teenage, the growth slows down and it kind of stops, the eyeball stops growing around 15 to 16 years of age. So then coming to the refractive errors, it's one of the most common cause of visual impairment worldwide. And also it is it's a significant proportion of treatable blindness whenever it comes to the higher refractive errors. So around 19 million children less than 15 years are visually impaired, and majority of this are due to uncorrected refractive errors, which is very easy to treat. So there is a huge economic burden, and myopia brings with it blinding complications, especially the higher the myopia, the more the incidence of complications, and there is an impaired quality of life. So there is a lot of social, economic and educational problems there. So what is the etiology of these refractive errors? Mainly the etiology comes with regard to studies for myopia. Astigmatism also kind of runs in families. So the etiology comes when we look at twins, whether they are like monozygotic or dizygotic twins, parental refraction, ethnicity. Parental refraction, like if one parent has a refractive error, there is around 10% the children can get myopia, whereas both the parents are having myopia, means around 20 to 30% risk is there for the children. And ethnicity, Asians and South Asians are very prone for myopia. If you go to Hong Kong or Singapore and all, it's around 70 to 80% incidence of myopia. India, it is around 20 to 30% as of now on an average when you take urban, rural, everything into consideration. Hereditary conditions, they can also cause pathological myopia. Birth weight, low birth weight again is prone for myopia. So what is the reason? And again, these are all the genetic things. The environmental can be because of the lesser daylight hours, more stress on education, socioeconomic factors, all these are also contributing. And visual input, what happens when you go outside, there is sunlight exposure. Sunlight exposure kind of linked to dopamine. The more the dopamine, the retina, the lesser the ocular growth. So that is why the environmental influence also plays a major role in the progression of myopia. There are a lot of diseases which can be associated with refractive errors, as in the syndromic myopia where Marfan, Sticklers, and even severe treated ROPs, where all you can get higher incidence. There are few conditions which can be associated with hypermetropia as well, like Leber's, where you get very poor refraction with high hypermetropia. And whenever you get ptosis, like congenital ptosis can cause cylinder, because chronically it is pressing on that lid. The amblyopia may be because of cylinder, uncorrected, and dermoid cysts and all. So the challenges in kids when it comes to correcting refractive error, because of the inability to obtain a good visual acuity, is not easy, especially in the preverbal age group. Subjective refraction, very difficult to do, especially in the preverbal age group again. Shorter working distance in kids, you tend to go closer to the eye. There is a very wide range of accommodation which you should arrest to come to the correct refractive error. Cooperation may not be there all the time, so they may be playful or sleepy. And risk of amblyopia is always there when you don't get the correct refraction, association with strabismus. So all these are difficulties when it comes to the children. So examination again, so give attention to family history, birth, behavior. Then comes to the visual acuity, motility exam. Whenever you do the refraction in the children, it is always along with the binocular vision assessment as well. So it is not in isolation, because many of the refractive errors do have strabismus or minor problems in binocular vision problem as well. So both has to come hand in hand and together. Dynamic retinoscopy, cyclorefraction is mandatory in children. Without that we cannot prescribe. And then, so what's required in pediatric is retinoscopy. So we cannot rely on the autorefractometers because of the high accommodation. You can have instrument myopia. So retinoscopy is the most generally satisfactory and accurate method for objective determination of refraction. But it's an art, and definitely it takes a lot of practice to do the refraction in children. So there are certain indications where you cannot do a cycloretinoscopy. So you do something called Mohindra's technique, where you go monocularly with a working distance of 50 centimeters in a dark room, and without cycloplegia. You may be just subtracting -2 for the distance correction, and you add +0.75 for the tonus factor. And then approximately you can get the refraction. That is, you are doing in a dark room. This is in conditions like low birth weight, neurologically impaired, allergy to drops. So you can use this Mohindra's technique, which is described. What is being shown here is the Lea gratings. So with the Lea gratings, you can see that the kid is looking at the pattern stimulus. So Lea grating is a form of forced preferential looking, where the child will look at the pattern stimulus more than the blank. So depending upon the thickness of the grating, you will get an approximate value of the the power, the vision in grating, like cycles per degree. So that is how you can get a rough estimate of the vision. Then dynamic retinoscopy, that is called monocular estimation method. So here you have to do on a near target. Like after doing the distance, they also focus on a near target. So this near target is fixed to your streak retinoscope, and the patient is made to read the letters if they are older, or there are pictures in the younger age group. So you can see between the distance, like for example, if distance retinoscopy is +2, and when they are looking at near, it is +0.75. That means the child is accommodating. Accommodating is normal. There are certain conditions where accommodation can be impaired, like a kid with Down syndrome or cerebral palsy, where they may be having issues because their inability to accommodate. So once you put them on a plus glass, then they will be able to read better. So this is the importance of doing dynamic retinoscopy, especially also when you are treating myopia, because if there is an accommodation lag, that can result in the progression of myopia. So that is an indication for giving bifocal glasses in myopia. So again, there is a other way of estimating visual acuity is just using like, you try resistance to occlusion. So if the kid is having poor vision, they will not accept it. You can use a patch, and this child is trying to pick up the cake decorations. So if the visual acuity is pretty good, they will be able to see the small, which is approximately 6/24 or so. So you can do that as a rough estimate. And in the below picture, you can see the Cardiff's cards. So Cardiff is vanishing optotypes. So slowly the thickness of the pictures reduces the line. And at one point, based on the visual acuity, the kid will not be able to see the picture anymore. So they will not point to the picture. So that is the principle of vanishing optotypes. All these are tests for pre-verbal children. So coming to the static or distance fixation retinoscopy, you can do in older children when they fix at a distance. And again, then here subjective is being done. So the retinoscopy will be the gold standard for prescription. So here you are using the matching optotypes. So it is a matching HOTV where you can see the kid they may not know how to read the letters, but they can look and they can match it. So this is again useful in pre-verbal children. So it is very easy, but you need to not to make the kid afraid when you are doing the test. So that is very important, otherwise they are not going to give any estimate of any visual in there. So the role of auto ref is very limited. I would say it will be helpful to choose the axis of cylinder. That is the only indication where you can confirm. But the instrument myopia very high, very difficult to get a correct reading for myopia. You can do after cycloplegia. You can put the cycloplegic and then you can do the auto ref, not in the dynamic age group. So what is this photo screeners? These photo screeners are being used especially for rapid screening in the school screening setup, where they can detect refractive errors, strabismus, media opacities. They use the infrared light at a 1 meter distance. There are various options, like plus optics is one of the commonly used ones. This is a Welsh-Allen one. So you know whether there is a refractive error or not. So you will get, you can also pick up strabismus, and you will get a report like whether the kid needs to be referred or not. So that can be used in camps like school screening and all, whether you have to, whether the kid has to be referred for a detailed exam. Usually, cycloplegia is very important, especially for first-time glass prescriptions. Atropine refraction we generally do in age less than 3 if there is a very high myopia or variable refraction, strong accommodation, esotropes. In all these kids, we need atropine refraction. Cyclopentolate can be used in older kids. And then tropicamide is the fastest onset, and also it lasts for only 6 hours. So in older kids, like repeat second time and all, we can do the tropicamide refraction. But we have to be careful in certain situations, like again Down cerebral palsy, some kids who have seizure disorders and all, and low birth weight infants, you need to be careful. Too much of cycloplegic, I have seen even cases where they get psychosis. Even after 2 drops of cycloplegic, they get a mild psychosis at times. Nothing, you just have to reassure the parents and it will disappear. So when to prescribe, it depends upon in the absence of strabismus or strabismus is there or not. So if strabismus is not there, hyperopia, then only if they are symptomatic, for the minimal addition you need to give if they are having asynopic symptom. Otherwise, hypermetropia, there is no need to treat. But if there is an esotropia, then you need to give the full correction for strabismus. Then ability to accommodate, again I said before, visual needs, risk of amblyopia. Whenever amblyopia is there, you need to give the full correction again. So in the presence of strabismus, definitely full cycloplegic correction for esotropes, and bifocals if there is a higher AC/ORA ratio. And so prescribing glasses, it is based on experience rather than evidence. So each person will do based upon their own experience and their what is their treating policies. So the issues are whether the spectacle is really necessary. Like in the preschool, sometimes in the camp setting, we look at a 0.5 without doing cycloplegic. There is no need to give because we don't know whether that's accurate or not, first of all. So you need to decide whether you have to give and what is the refractive error which can produce amblyopia in that age group, you need to know. And also whether it will interfere with the normal emmetropization. So all these you have to consider before prescription. There are general guidelines given by the AAO and also by our Indian Academy, where we have general guidelines for isometropia and anisometropia, myopia, hyperopia and astigmatism based on and also age wise. So you can use this as a rough guide and also define it accordingly. Like for example, less than 1 year, if hyperopia is more than 6, definitely you need to give because otherwise risk of amblyopia is there. Then again, when it comes along with strabismus, as I said, ET, you have to correct fully. Exotropia with myopia, again, it's a good combination. So because it will help to control the exotropia as well. Nystagmus, you have to prescribe for the null zone, whatever error you are getting there, and over minus can stimulate the accommodation and help to control the nystagmus also. In aphakia, again, after you do surgery, in the initial 1 year, you don't have to give the near addition. 1 to 2 year, you can just, so you add the +3 to the distance. That's how you correct. You don't have to give a bifocal because most of the kids look only at the near and intermediate distance. So above 3 years, you can give the bifocals. That is in aphakia. Then you should pay very attention to the frames because unless the frames are well fitting, it is not going to work. They used to be especially for small kids who don't have a poor nose bridge, poorly developed ear and all, some syndromic kids and all. You have to be very careful when you are giving the glass prescription and see whether it's fitting properly. So coming to, do I have time? I am not keeping track of it. Another 2 minutes, yeah. So coming to myopia, like it's worldwide and it's more in our part of the world. So the trends are, this is one study that we did in our own OPD. After the COVID pandemic, we found that the number of new myopes are more in each month compared to what it was before. And we need to stop being myopic about the myopia management. So every diopter matters because even one diopter, we think it's only one diopter, but there is a 57% increase in myopic maculopathy, 20% risk of open angle glaucoma, similarly for cataract and RD. So these are all blinding complications. So what is the approach to treatment as of now? We were correcting with single vision lenses or contact lenses. Environmental and behavior modifications are paramount, especially if there is a high risk like a family with both parents myopic, and we need to stress upon them that these environmental and behavior modifications are very effective for prevention. That is before the myopia starts. Once it starts, the role kind of decreases. So from the beginning, the parents have to make sure that they don't encourage the kids on gadgets. And then there are specially designed ophthalmic spectacle lenses for myopia and tropical atropine as well. We have like 3 or 4 companies currently. The DIMS, the HALT and the CARE group of glasses are the ones which are commonly prescribed. All of them are equally and near about the same effective, provided you follow the correct guidelines for prescription. And I would say all of them are better than single vision lenses in the correct indication. That is simple progressive myopia, non-syndromic, non-preterm associated, and if no other retinal pathology, then if it is progressive, you can prescribe. And this is the newest addition that we have started doing now, the Spark, which is developed by the LV Prasad group, where you can assess the peripheral refraction. It's a very, very simple tool. You don't have to use a like earlier you had to use a open field auto ref, but you can use the Spark now, where you can, in this particular example, you see the central refraction is minus 2.5, whereas in the periphery it is coming 1.75. So there is a relative peripheral hypermetropia. Whenever the relative peripheral hypermetropia is there, you have to, all the glasses which work on peripheral defocus will work. If you give single vision, the focus is behind the retina. So that itself will help in the elongation. So this device has three markings where if you do at the correct angle, so you have to do it through the center, you have to do 20 degrees nasal and temporal. So when you follow the correct angle, that there is a red paint which kind of illuminates. So you will know the correct angle where you have to do the retinoscopy, that's all. So it's a very simple tool and it gives a lot more information. We have just started using on few kids, but I have to convince our refraction team to do it in all kids, which is a very big challenge. I don't know whether I will be successful in that. So rationale for vision screening is to demonstrate that people with amblyopia, see, you have to detect all these problems as early as possible in order to maximize the visual outcomes and treat amblyopia as early as possible. So the gold standard for screening, whenever the distance acuity is less than 6 by 9.5, it is 75% chance of having, 97% chance of having refractive error. But there are a lot of disadvantages of Snellen, which we are commonly using for screening because of the unequal distribution of optotypes and nonlinear progressions. Lot of barriers to spectacle wear as well. It's a challenge even among educated, even among doctor parents. It's very difficult. Sometimes their mind conception changes when it comes to their own children, when you say that they have to give and prescribe spectacles. So in conclusion, in a pre-verbal children, you should obtain a good history, be aware of developmental and refractive changes, know the refractive and strabismic changes that will necessitate spectacles, and also decide whether the indications for eyeglasses outweigh the reasons influencing the practitioner not to influence them. Thank you.
Thank you, madam, for that enlightening talk. I'd like to invite Dr. Ashoka Valsala, madam, of New Vision Eye Hospital, Manjeri, to kindly present a memento to Dr. Sandra, ma'am.
Thank you, Dr. Sandra. That was a wonderful overview of prescribing for children, stressing upon myopia and hypermetropia, each in its own aspects. So, actually, this is a newer technique of checking peripheral and central refraction retinoscopy. We have our open field refractometers also there, which can also. We are doing it in the myopia clinic, but of course it is, I don't think it is as worth to invest in that.
Next we move on to case presentations. The first case is being presented by Dr. Shrishma K, postgraduate student, Manjeri Medical College.
ഹൗസ് പോയോ? വന്നല്ലോ.
Any questions from the audience regarding?
I have one question to Sandra, madam. When you consider a small child less than 5 years, suppose, do you take into consideration the parental history while prescribing glasses? Suppose the refractive error is within observable range, but the parents have a history of high myopia, or maybe the sibling has a history of accommodative esotropia and hypermetropia. So does your threshold reduce for prescribing glasses?
We definitely have to take that into account, especially in a case of myopia, because once the myopia starts at the age of 5, which you said, it's very unlikely that it is going to remain the same. It is definitely going to progress. We hardly see any myopia which at 5, which stays like that. So unless the congenital myopias usually don't progress that much. Whereas the school age myopia which starts at 5 to 6 are the cases where these kind of behavior and environmental counseling and the effect of atropine or control glasses or whatever will have the maximum effect, because over a period of 10 years, the projection which shows around -6 or 7 can be brought down to -2 or 3, which is a huge improvement regarding the ocular health. So definitely I would take that into consideration and keep them on a closer follow-up. But you have to prescribe also. If there is even a 0.75 in that age group, less than 5, you probably, if you have to see, only thing, the myopia which is from birth will not be a very small value. Usually it will be like -4, -5 and all. If that is so, then you can just keep them on a closer follow-up after prescribing. But if it is starting at -0.5, you can look for 2 visits and just document the progression both in axial length and your glasses, so that parents also will be convinced to take up your interventions.
I think we have to stress upon the point that it is the simple myopia who need the progression prevention strategies, including atropine. We have seen some of the children who have high myopia also coming with atropine usage. So that has to be stressed, as she has already pointed, that it is the simple myopes and school myopia. There is a lot of controversy regarding the pre-myopes, whether we should start giving spectacle before 5 years or not. But again, so
pre-myope means, what is pre-myope? Pre-myope is whenever the hypermetropia is less for that particular age. That is just before when myopia starts. So whenever you see pre-myope, you have to be very careful. Like for an age of 4, say you will expect like a +1 or so something. But if you are seeing less than that, if you are seeing +0.25, that means the kid has a very high chance of going for myopia in future. So the pre-myopes have to be really kept under close follow-up. Also document the axial length in these cases, so that in the future it will serve as a baseline reference.
I think we can move on to the case presentation.
Good morning all. I am presenting a rare case of post-trauma complication. It is not a pediatric case. Unraveling a post-trauma complication. A 56-year-old male patient who is a manual laborer came with the complaints of drooping of left upper eyelid for 5 days. He had a history of fall under the influence of alcohol 10 days back, following which he developed pain over the left eye, cheek and left side of face. History of nasal bleed present. History of numbness over the lower lid, cheek and left side of face present. No history of double vision or vertigo. No history of deviation of angle of mouth or drooling of saliva. No history of hearing loss or tinnitus. Personal history. He is a chronic alcoholic and smoker. No history of diabetes, hypertension or dyslipidemia. Ocular examination of right eye showed 30-degree exotropia with hypertropia. There is no evidence of enophthalmos of left eye. Extraocular movements of right eye is full in all directions.
Adduction, abduction, elevation and depression showed grade 3 limitation in left eye. Dextroversion, dextro elevation, dextro depression. Levoversion, levo elevation and levo depression showed grade 3 limitation in left eye. There is absence of indotion in left eye. Forced adduction test is negative for adduction, abduction, elevation and depression. Diplopia charting was done at 1 meter, which was not that much reliable because of the poor vision, even though it showed horizontal uncrossed diplopia with a maximum separation on levoversion. Visual acuity of right eye is 1 meter counting fingers and that of left eye is 2 meter counting fingers. There is no red-green desaturation. Field of vision could not be assessed due to poor vision. On examination of right eye, anterior segment, right eye showed direct and concentric right reflexes are brisk, immature senile cataract, nuclear sclerosis grade 3 and posterior subcapsular cataract. Anterior segment examination of left eye showed severe ptosis, lower orbital margin tenderness present, infraorbital and forehead anesthesia present. Ptosis measurement showed a palpebral fissure height of 0 millimeters and LPS action of 2 millimeters. That is severe ptosis with poor LPS action. Corneal sensations are reduced. Direct and concentric right reflexes are sluggish in left eye and pupil is of normal size. Lens showed immature senile cataract, nuclear sclerosis grade 3 and posterior subcapsular cataract. Fundus examination and intraocular pressure is within normal limits in both eyes. Our provisional diagnosis were post-traumatic total ophthalmoplegia of left eye involving 3rd, 4th, 5th and 6th cranial nerves. Likely lesion is in the superior orbital fissure of left eye. Also, there is blowout fracture of floor of left orbit. Cataract of nuclear sclerosis grade 3 and posterior subcapsular cataract in both eyes. Here is the CT finding showing the superior orbital fissure fracture. There is orbital floor fracture with a teardrop sign. Patient were managed with the systemic steroids and neurosurgery consultation was sent. After 2 weeks of systemic steroids, patient improved remarkably. Thank you.
Thank you for that presentation. Actually, superior orbital fissure syndrome in trauma is not very common. It's a quite uncommon finding. And diplopia charting, more than the vision, I feel because of the gross limitation of movement, it might not have been very reliable. Patient might have been projecting only with the right eye. But yes, so it's a combination mid-phase fracture, maybe a combination of Leaford 3 and extending posteriorly along with a blowout fracture.
Yes,
and superior orbital fissure is actually quite rare. So management is just like this, high dose steroids followed up conservative management initially at least for the 2 weeks, and maybe surgical intervention only if there is any fracture fragment or impending optic nerve involvement or a hematoma. So since nothing is there, then I think
usually it is due to the hemorrhage and hematoma, which produces lot of pressure on these superior orbital fissure structures. But if there is a blow-in fracture as well, then you may have to reduce it. Otherwise, it is mainly a conservative management because a lot of important structures are passing through. So, of course, high dosage steroids, they do well in these cases, just as you would do in an optic neuropathy also. Traumatic optic neuropathy, they do well. So, as she has already said, it is very rare, as you have already said, not common. But here you have both superior orbital fissure as well as a blowout fracture is also there. So, you have infraorbital anesthesia as well. So that has to be also taken care of, whether there is it has to be reduced or not.
Do you have any explanation for the normal size of the pupil? Because third nerve is involved, no?
Both
the pupil is normal and sluggish. Why is it so?
Both the sympathetic and parasympathetic supply of pupil is involved.
So you mean both dilator and sphincter is
involved.
affected because fifth also is involved. No? Okay.
One thing is with regard to the diplopia charting, as Lakshmi also said, vision was 1/60. Said, no? With 1/60, it is very difficult to get like proper diplopia charting done. Secondly, the teardrop sign was seen on the scan.
Maxillary sinus.
And at the end of 2 weeks, their motility is full. How do you explain that?
Edema, reduction of edema due to intravenous steroids. There is no muscle entrapment. There is no muscle entrapment,
Yes.
only soft tissue and fat.
Exact. Yeah, so there's no, the patient is very lucky, I think. And did you do a force duction testing?
Was done, which was negative in all directions.
Thank you.
Is there any name for the superior orbital fissure syndrome? It's called Roshan-Dubinow syndrome. It's a named syndrome.
You said there is exotropia of right side, no?
Yes,
Why
sir.
is it so? Whether patient is having this problem prior, any old photographs available?
There was no deviation of right eye previously. It may be due to more vision in the left eye, which caused a secondary deviation of right eye.
Possible, but
Thank you. Any discussion from the audience? Any questions? Sir?
Any orbit person sitting here would like to add on to this? Okay.
I have a doubt actually. When in such a scenario, when 3, 4, 6 are involved, an MRI is also indicated. Is an MRI also indicated because there could be something happening in the cavernous sinus also?
I think in this particular case, when there is trauma, when you are suspecting bony changes, that's what you want to know, whether you need to intervene or not due to a fracture pressure with pressure effects. Then CT scan is the first mode of management, I think.
Anyway, it has improved dramatically with the steroids. So I think our diagnosis must be correct because something inflammatory was there at the superior orbital fissure. But we do see cases where within 2 weeks also they can present with a carotico-cavernous fistula. So usually literature-wise they say the carotico-cavernous fistula appears most often after 2 weeks, but we have had situations where CCF presents earlier and the typical pulsatile proptosis might not be there. And in your, can you go back to your diplopia charting? It was an exotropia, right?
No,
But she said it has crossed diplopia. I think it is. And it must have been a crossed
Uncrossed
diplopia.
diplopia with an exo, where you have shown the pictures, they don't match. We have taken it as not reliable because it doesn't.
No,
it
I think
doesn't match.
for most of the people it is confusing. The simple thing to remember is in an ESO, it is an uncrossed diplopia. In an EXO, it is a crossed diplopia. Okay, so remember that much at least.
Thank you.
Thank you, Shrishma. We go on to the next case presentation by Dr. Anthony Akash Albert, postgraduate student of Calicut Medical College.
Good morning. Presenting a case of Sanim, 4 years, male child from Malappuram. He presented to our OPD with complaints of squinting of eyes, which was noticed by mother since 2 years of age, which was alternating in nature. The child is using spectacles since 2 years of age. Past history, the child was having a full-term normal delivery, no history of any NICU admission, no history of developmental delay, no history of any previous ocular surgeries. Family history, there was no history of any squinting in family. On ocular examination, head posture was normal, there was no facial asymmetry. Corneal reflex test showed a right esotropia of 15 degrees. On cover test, there was an alternating esotropia of 15 degrees with equal preference to both eyes. Prism bar cover test showed a 30 prism base out for both near as well as distance. And with prescribed glass, prism bar cover test was orthophoric for both near as well as distance. Extraocular movements were full in all directions in both eyes. The interpupillary distance was 40 mm and the AC by A ratio, which was calculated using heterophoria method, was found to be 4:1. BSV, the child was not cooperative. Anterior segment and fundus was within normal limit. And vision with picture chart, it was 6/24 in right eye and 6/36 in left eye. And with correction, it was 6/9 in both eyes. So here we can see that in the first picture, the child is having esotropia without proper correction, and in the second picture, the child is orthophoric with proper correction. The PG power was +5 ds in right eye and +6 ds in left eye, and homide refraction showed +6.5 in vertical meridian and +7.75 in horizontal meridian in right eye, and +7.25 in vertical meridian and +7.5 in horizontal meridian in left eye. After distance correction and tonus allowance, it was found to be +4.5 in vertical meridian and +5.75 in horizontal meridian in right eye, and +5.25 in vertical meridian and +5.5 in horizontal meridian in left eye. Provisional diagnosis: accommodative esotropia, refractive hypermetropic type, and compound hypermetropic astigmatism with the rule. Thank you.
Yeah, that's a very looks like a very straightforward accommodative refractive accommodative esotropia. But whenever there is an anisohypermetropia, here it is a very small one, still there is such high chance that he may go in for amblyopia. It was a freely alternating one according to what you said. So you have to look for binocularity also, whether he is using his both eyes. Sometimes there may be a very residual remaining esotropia. He may develop in the long run also. He may not use one eye, the more hypermetropic eye. So that's what we have to follow up and see also whether the hypermetropia increases over time. So
okay, we have prescribed the glasses to the child. What are the problems that you foresee with the parents after you prescribe the glasses?
The child may not be compliant with keeping spectacles. So in such cases, we can consider keeping contact lenses. And then until the child is accepting the spectacles, we can try meiotic therapy for a few weeks using drugs like cyclopentolate.
Not meiotic. See, they may not accept the glasses immediately, especially in the higher plus powers. But if there is such a big esotropia, we have to give the full correction. So what happens is, you can prescribe with some cyclopentolate. You can probably give cyclopentolate for a week or so, and then you can prescribe if they are not accepting, so that then they have to wear it full time, so that the eyes will adjust to the glasses. Otherwise, suddenly they may say that when the eyes come back to normal after the cycloplegic effect wears out, the kid may not be seeing clearly. So that is one problem which may come. Secondly, as you said, compliance is very important. Otherwise, the kid will become amblyopic in the eye which is deviating inwards. Thirdly, the parents may refuse glasses. They will tell you do surgery. But that's simple for them because they don't have to make the kids to wear glasses. But we have to make them understand that for this accommodative, fully accommodative esotropia, doing surgery is not the treatment. Because many parents will demand surgery to correct the squint so that they don't have to wear glasses. But that is one of the practical problems. So we may think otherwise. But the stigma to wearing glasses is more than doing the surgery actually.
Actually, some parents initially, not as the child grows, but when the child is small itself, initially they'll tell, we used to see the squint only intermittently, but after wearing glasses, immediately after removing the glasses, we see the squint. So that is a common thing that we face. So counseling is more important. And thank you for bringing out that simple and beautiful solution of a spectacle for a child to prevent amblyopia for lifetime.
Yes. Actually, if they are not very compliant, what I do is I ask them to continue atropine once a week for some time till the patient is well settled with his own. Usually it is not just plus, it's a very high hypermetropy correction. So that's what I do.
Will you prescribe that small cylinder with this high type of hypermetropy correction? It's small cylinder in this, there on the right side. It's with the rule.
Yeah, if we are prescribing, we can prescribe fully. Whatever correction is coming, we will prescribe. We'll just see the subjective acceptance and we can prescribe regarding the cylinder. And such cases you have to be, the near distance disparity anyway here it's not there, but you always have to, it's very important to look at both the distance and near measurements. In case there is a disparity, we have to give bifocal addition. And then how will you decide on what is the long term effect, like how will you wean the glasses for these children? So what happens is as they grow older, the hypermetropia will slowly come down and the esotropia may also reduce, but it takes many years. So it may, if the hyperopia is like lower, then they may be able to totally discontinue wearing glasses. But if the hyperopia is little on the higher side, they will not be able to discontinue glasses entirely. So when the child becomes older, then we need to decide, especially in partially accommodative, we have to correct the non-accommodative part. For bifocals, we can decide something like Faden operations in order to remove the bifocal segment. Yeah, contact lens is not actually.
No, contact lens is not an option, but regarding the cylinder, if it's a significant cylinder, yes, the accommodative part doesn't need the cylindrical correction, but as the child grows, if the cylinder is not given, then that visual acuity and the sharpness of vision is actually less. So better to prescribe the cylinder. Yes.
Any audience questions or comments? Yes.
Ma'am, when it comes to giving this full correction, many a times when the kids, once they start going to the school, rather than the full correction, a little less correction will give them better visual acuity. I find in some cases like that. So should we stick on to the full correction compromising the visual acuity, or we should measure the squint, and if it is in a Fourier range we can give the less correction? How do we go about that?
Usually this accommodative esotropes patients will accept the full correction because they would have been wearing it for a long time. Only later on, as they grow older, they may outgrow the, when that's a point when you try to reduce the plus correction. So you decide based on the cycloplegic refraction also you see, and then based on that we can reduce. But if the ESO, provided the ESO is in a Fourier range, so if the ESO is increasing, then you may have to operate at that stage so that you decide based upon the best visual acuity, and also you don't allow the tropia to manifest.
I would like to add on, after 8 to 9 years, even though the retinoscopy value remains the same, you need not, if the esotropia is fully correct, sometimes you see the child comes back after a very long time with a basin. I mean exophoria or tropia with the full correction. So then you have to reduce. Even though the retinoscopy is the same, you have to reduce. And then and you have to give a margin space for the child to metropize, because you don't have to fully correct it. The retinoscopy value need not be fully translated to a prescription if the esotropia is corrected with less amount of hypermetropy correction.
I'd like to invite Dr. Enjini Madam to kindly present a token of our appreciation to our panelist, Dr. Leela Mohan Madam. Dr. Suma Unnikrishnan Madam, kindly accept a token of our appreciation. Dr. Lakshmi C. Dr. Almas. I request our PG students, Dr. Shrishma, to accept a token of appreciation. Dr. Anthony Akash Albert, please accept a token of our appreciation. So that was a great informative session. Thanks to the speaker, Dr. Sandra Madam, and all the panelists. We move on to the fourth session of Oculus Season 5, that is on retina. Our first speaker, I'd like to invite the panelists, Dr. Padma B. Prabhu, who is Additional Professor, Government Medical College, Kozhikode. Dr. Shabarish, MD, Consultant VR Surgeon, Puttula Thai Hospital, Kozhikode. Dr. Sharmila MV, Retina Consultant, Aster MIMS, Kozhikode. Dr. Sharath Ravi, Consultant VR Surgeon, Dr. Sreekanth Eye Care Hospital, Calicut. So our first speaker for the retina topic is Dr. V.R. Sharvanan sir. He is Consultant Vitreoretinal Surgeon, Arvind Eye Hospital, Kozhikode, with a vast surgical experience, as well as he is a postgraduate teacher with many years experience and many publications to his credit. He'll be speaking on the management of cataract with diabetic retinopathy.
Thanks for the kind introduction. I'd like to thank Dr. Sreekanth sir for having me here. So this is a common dilemma or common situation where all cataract surgeons face. Because if you look at the numbers, we are only second in the world next to China as regards to number of diabetics. As you can see here, it's a huge number. Almost the whole population of the whole state of Tamil Nadu, that much number of people are suffering from diabetes in India. And you can understand that approximately if you take like 15% of your cataract surgery patients will have diabetes, of which 2 or 3 people can have some sort of retinopathy. And this can lead to some issues in the postoperative visual recovery as well as intraoperative complications as well. When dealing with a patient who's got coexistent retinopathy as well as cataract, you have to make the patient understand that you have 2 different diseases, 2 different etiologies or causes, and 2 different lines of management. So as regards to cataract, it's like a sprint, like you can give the example of Usain Bolt, whereas for retinopathy, it's going to be like Kipchoge, it goes to a marathon treatment till the life of the patient ends. You're dealing with a patient who's got a significant posterior subcapsular cataract with a poor vision. You're confident that the vision loss is mainly because of cataract and less likely to be because of retinopathy, and doing surgery in these patients can vastly make the patient happy because the postoperative recovery is quite good. But you are dealing with a sort of a NS1 or NS2 cataract, and if you feel that the refractive correction cannot give back 6/6 or 6/6 parts, then you should look at the macula carefully, because in early nuclear sclerosis, the vision tends to get 100% with correction, and if you're not getting a good correction, that means suspect either macular edema or macular ischemia, and these are the patients who are least happy after a successful cataract surgery. So that said, like early surgery is much less complicated, much more successful as regards to the surgery part. And operating early in these patients can be easy and beneficial also. So now comes the question which to treat first, whether the patient has got both retinopathy as well as cataract, whether to treat the cataract first or the retinopathy first. But as you can understand, the visual recovery is best when the retinopathy is quiescent in a patient who's got coexistent retinopathy as well as cataract. As regards to PDR, if you're dealing with a case of PDR, if the media is clear enough, try to do a pan-retinal photocoagulation before the surgery so that the postoperative inflammation cannot produce other complications. But in case the media is not clear enough to do PRP, then you can do cataract, and then depending on the severity or the imminence of need of PRP, we can even do it the next day itself. Like patients who have got NVA, sometimes you do before the discharge only we do indirect ophthalmoscopy laser. But if it is focal laser, you may have to wait for at least 2 to 3 weeks. When there is coexistent iris neosclerosis, as pointed out by Satyan sir in the previous session, bleeding can be a significant complication during cataract surgery. So in these patients, you can pre-treat them with intravitreal or even intracameral Avastin depending upon the severity. And if the intracameral Avastin can give you regression within 1 day, whereas intravitreal Avastin will take at least 2 to 3 days to make them disappear. So depending upon the severity and the imminent need of cataract surgery, you can inject it more commonly in the intravitreal cavity, or as if it's an acute emergency, you can inject into the intracameral also. Sorry, intravitreal is normally what we do. Intracameral can be done occasionally in very acute cases also. So after the surgery, once the media becomes clear and the iris and this disease becomes quiescent, then you can go for a indirect PRP with indirect laser, PRP with indirect laser. When you have a coexistent cataract and diabetic macular edema, then there's a significant question whether to treat the edema first or do the surgery or combine it with injection. So a lot of times people tend to treat the edema first so that the immediate postoperative visual recovery is good enough and patient is also much more happier. But we have done a few case series of around 100 cases in our hospital to see whether giving for us mainly because most in our hospital most of the patients are referral patients coming from outside the city, trying to make them come twice, once for injection and then for the cataract surgery becomes an issue. So what we try to do is combine both the injection and the cataract surgery in a single sitting. So the fear is that after the surgery when you try to inject intravitreal anti-VEGF, the intraocular pressure can increase, it can cause decentration or iris prolapse, or the risk of postoperative endophthalmitis can be high. These are some of the concerns. But in our series, we found that neither of this was an issue. In steroids also, there was no significant rise of pressure. There was no increased risk of endophthalmitis. And there was no case where there was an intraocular complication like a decentration of the lens or iris prolapse to the wound. So nothing was noted in these cases. So it is safe enough to give both surgery and injection in a single sitting also. So when to do laser? As I told you, PRP can be even done the very next day provided the cornea is clear during using the not the contact lens but the indirect delivery system. But in case you are doing focal laser, you may have to wait for at least 2 to 3 weeks. But in the US, I have seen people doing laser even the 3rd or 4th day also. But in India, at least in our hospital, we don't do it immediately. We try to postpone it at least 2 to 3 weeks in case you have to use a contact lens for the laser procedure. When to advise surgery for the other eye? So if one eye has got a significant retinopathy, the other eye also is bound to have. Like in the previous case, one madam was one eye is a moderate NPDR, other is a severe PDR with the NVG. So sometimes it's unusual to get such a asymmetrical presentation. So usually both the eyes tend to progress together. So one eye has got a significant retinopathy. Better to operate the other eye early also, because it helps to monitor the patient's retinopathy progression much more easily. It is difficult to monitor in a cataract eye because the media is not very clear. So as you know, the preoperative workshop should include all the monitoring of the systemic parameters as well as visual. Sometimes we are not sure what will be the postoperative visual acuity in a cortical cataract. You can use a potential visual acuity meter to sort of prognosticate what the patient's vision will be in the postoperative period. Apart from that, to assess the optic nerve function, because ischemic neuropathy is one common occurrence in diabetic retinopathy patients, you can do a routine slit lamp as well as torchlight examination, and always look for NVA and NVA critically in these patients before surgery, apart from the fundus examination. So other things which you normally do is, nowadays everybody does OCT as a routine testing during preoperative cataract workup, so that is very good. We also can do fluorescent angiography in cases, selected cases, B-scan where the media is very poor, and OCTA is also a new indication for which we have in the now doing occasional cases where the vision is not corroborating with the amount of cataract. So intraoperatively, you should know that both the epithelium and endothelium is not very healthy in advanced diabetic eye disease. So the decompensation as well as postoperative epithelial defect can be an issue here. And especially in the presence of NVI, the pupillary dilatation can be an issue which you should be taking care of with adequate devices. And patients who have pre-existing NVI, as again Dr. Satyan sir pointed out, pre-treating them with anti-VEGF will help the intraoperative bleeding during the surgery. In case you have a PC rent, so PC rent is not a thing to be very much afraid of. If you are taking care of it in a proper way, clearing all the vitreous cortex, taking care of all dropped lens matter, and then it's not going to be an issue. You can also use Tramslone to identify vitreous strands in the anterior chamber so that you can remove much more particularly. One common question, especially postgraduates ask, is what are the settings which you need to use for doing vitrectomy in the anterior chamber when you're having a PC rent. So this is what I tell you, double. So 20, 23 and 25, whatever cutter size you are using, it is 150, 300 and 600. You can use this as a sort of a rough estimate to what is the suction you need to use. And the cut rate should be whatever maximum cut rate is available in the machine. So for 20, it is 150, for 23 it is 300, double it and make it double for 25. This is a rough estimate, and the cut rate should be maximum. In case you are afraid of creating a traction and retinal tears, you can decrease it by half also, but the efficacy becomes lesser in decreased suction apart from what I am given here. So post-operative inflammation is going to cause a big difference in the progression of macular edema, especially in patients who have got early macular edema. In case of uncontrolled or improperly treated post-operative inflammation is going to make the macular edema really worse, so you should have to take care of that in the post-operative period. So retained lens matter. So normally in a little bit small cortical bits is okay, but you're having epinuclear bits or nuclear bits, it's always better to remove them, especially in the presence of preoperative macular edema. So macular edema tends to get really worse in eyes with retained lens matter. So if it's a very mild or retinopathy, you can observe small cortex or epinucleus bits. But in case of pre-existing macular edema, don't hesitate to rush in to remove these bits, because that can really make the edema worse. So NSAIDs also helps to decrease the amount of postoperative CME, occurrence of postoperative CME, as well as the progression of diabetic retinopathy. There are a lot of studies to show this. This is one study which was used 0.3%, not the routine 0.1%, but the Elevro, which the formulation 0.3%. They showed that there's an increased risk of worsening of macular edema in diabetic patients, and using this helps to prevent the progression. So one question commonly asked is, when you see a edema after the surgery, whether it's because of diabetic macular edema or is it because of the postoperative CME. You should remember that the postoperative CME needs at least 1 to 1.5 months for it to manifest. Edema which you see before 1 month, within 1 month of surgery, is most probably not CME, but because of the diabetic macular edema, which can mimic a postoperative CME also. So that is one thing which normally in the previous studies they assumed that anything within 3 months of surgery is because of diabetes and not because of postoperative edema. So anyway, so treat accordingly. Whichever you feel is bad. If you feel it's a postoperative CME, you can use NSAIDs and steroids. If you feel it's a diabetic macular edema, you can go for injectable anti-VEGF or intraocular steroids also, intravitreal steroids also. Some of the reasons why edema, risk factors which can cause worsening is the duration, coexisting disease, as well as the pre-existing DME as a higher risk factors, and postoperative complications like PC rent or retained lens matter and inflammation can be a real issue. So then one more common question asked is, what is the type of materials to be preferred in diabetic patients with diabetic retinopathy? I am not a specialist in this, but anyway, hydrophobic lenses are much more preferred as per I have discussed with my surgeons. And as regards to advanced technology lenses like the toric, definitely can be used. For multifocal is the issue. Multifocal, because most of the times, even though the manifest edema may not be there in the patient's fundus, people have early macular ischemia which can really compromise the contrast, and placing a multifocal lenses in already compromised eyes can really damage the contrast sensitivity of the patient. Some people say that accommodative IOLs, because they are a monofocal lens design, can be beneficial. I mean, it will not affect the contrast sensitivity as much as a multifocal lens, but I am not as, I have to ask the concerned experts to get a correct idea of this. So as I told you, sometimes even though there is no like in this case, this patient has got a 6 parts vision. He's not very happy. He's saying that the last 6-8 months, my vision is not that very good. But you can see that the macula is almost paired. Only a few hydroxylates the parafoveal vision. This patient underwent cataract surgery and is not very happy with the postoperative vision. He's got around 6 parts to 6-9 vision. The reason is that it's not because of macular edema, but because of macular ischemia. This is Octa OCT angiography showing the enlarged FAZ margin. So even though there is no manifest edema, because of the presence of macular ischemia, he is unhappy with this post-surgical vision. So this has to be kept in mind that especially if you are considering multifocal IOLs in these patients, better think twice before going in for these lenses. Again, OCT can also be preferred as a modality as a replacing the fundus fluorescence angiogram. This is a case of one eye had a mature cataract, this eye had a suspicious, but still cataract was not giving a good view. But you were able to do a OCT angiography, and you can see that there is a very small NVE presenting in the superior arcade. So OCT can replace FFA in select situation where the media is not too bad. So last is that what are the issues when you are operating cataract surgery, doing cataract surgery, and a patient who has already undergone vitrectomy for diabetic retinopathy. As you know, because of the poor glow, you don't have red glow, and you are doing capsular access can be an issue. And always when you are doing cataract surgery in a vitrectomized eye, assume that the PC is not good. Treat it like a posterior polar cataract, so that expect PC dehiscence and PC rent in all cases, even though the surgeon may not tell there's a lens stage during surgery, but still assume that there's either a minor or an indeterminate lens stage which can compromise the PC integrity. Treat it like a PPC from the word go. And in eyes where the oil is persisting for more than 6 months or 1 year, the cataract is very leathery also, and the capsule also is very stiff. So doing with the routine needle cannot be very easy. You may have to use Utrata OSAPs to complete the axis in a proper way. And so this is something which you have to keep in mind. Plus, because the zonula support is not that very good, reverse reverse pupillary block can be issued in these cases. You have to take care of that during using your iris hooks as a cataract. You all know about this. So as I told you, always expect a PC dehiscence treated like a PPC cataract. And one more question is whether if you are doing a vitrectomy in a patient who has already got minor cataract, whether to combine or to do it separately. So a lot of points for and both. So depending on whatever suits the patients and the particular condition, especially in the patient who has got a significant retinal detachment, the IOL power calculation can be issue. In this case, it's better to phase out the two surgeries. But otherwise, in case you are doing both surgeries together, the chance of corneal edema is less. If 2 people are doing it, then the chance of corneal edema, when there's a time gap between the both surgeries, can be significant. So depending on what the situation is, you can try to choose whether to do it combined or do it in a phased manner. So this is some of the indicators of poor visual outcome, that the presence of nephropathy is a very critical indicator. So patients who have got nephropathy have got a very significant risk of having macular edema. So that is one thing which you have to be aware of. So as regards to follow-up, this is one thing which a big real-world scenario. Even though a lot of controlled studies showing that properly done uncomplicated phaco surgery does not cause a big difference in the progression of retinopathy. That was what the routine big studies have told. But this is a very big study in real-world data, and they showed that down the line at 1 year, the risk of progression of retinopathy following cataract surgery is really significant, and these patients have to be really followed up close, especially when they have preoperative retinopathy changes in the fundus. Just to give you an idea of how to follow up these patients, if there is significant macular edema, you may have to follow them every 1 month immediately after post-cataract surgery. If there is fovea threatening, you may follow them every 2 to 4 months. If the fovea is not threatened, 4 to 6 months, and the very mild retinopathy, then you can call them after 6 months to 1 year also. So I'll stop here, and thanks for the opportunity.
Thank you, sir. I would like to invite Dr. Meena to please come forward and present a token of our gratitude to Dr. Sharavanan, sir. Thank you, ma'am. Thank you, sir. We move on to the next talk in retina. Our speaker is Dr. Gopal S. Pillai, Professor and HOD, Department of Ophthalmology, Amrita Institute of Medical Sciences, Kochi. Sir is an expert surgeon and he has a vast experience in postgraduate teaching as well. And we are very happy to have you, sir, here today. Sir will be speaking on OCT interpretation in muscular disorders.
Thank you very much for your kind introduction. So if there is one investigation which has completely revolutionized our practice, it is OCT. Optical coherence tomography has really come handy, and it makes not only our understanding in the diseases much more better, it also has revolutionized our treatment. Because almost just before the intravitreal injections came out in maybe 2003, 2004, immediately before that was the advent of OCT. And imagine intravitreal injections in our hands without OCT. It would have been a real disaster. So here, this is the histopathological picture of the eye in the lower part, and the OCT image in the top part. Now, when you look at an ultrasonography or even a CT or an MRI, a CT or an MRI may have a resolution of about 1 millimeter. An ultrasound may have a resolution of about 500 microns. Here is an investigation. You can always talk to your friends in other disciplines that we look at a resolution of 5 microns, which is very, very high. Now, it's very quick, it is non-invasive, and it is reproducible, and definitely we require to repeat it multiple times because it is completely non-invasive and quick in order to get the maximum best results. If you look at the evolution of OCT, do we have a pointer here? So if you have the evolution of OCT, it moved from time domain OCT, which was like in the 2000s, to spectral domain OCT in about 2007, 2008 onwards, and now we have the swept source OCT. So these are the 3 levels of OCT which are there, and the principle, I do not want to go deeply into physics. There is interferometry, in which that's a technique differentiates between superimposing waves, and what happens is these waves are applied onto the retina, and whatever comes back, there's a time delay of certain waves as compared to the others, and that time delay gives you different structures differentiation. And we can 3-dimensionally reconstruct these structures as well. Just to go into time domain and spectral domain and swept source, here we have, you can see the basic difference, 400 A scans per second, 27,000 to 70,000 A scans per second, which increases to 1 lakh to 4 lakhs A scan per second. That's a very, very fast acquisition of images, and that is why the resolution increases from about 10 microns to about 5 microns. That's the axial resolution. So, in a swept source OCT, you can have much more visualization of the choroid. The choroid is not so much studied now because we commonly talk about the retinal changes, But a lot of choroidal changes also occur in all these diseases, and that is getting more and more evaluated now with the presence of subsource OCT. Now these are some of the common OCT machines. That's a spectralis type of machine, and this is the Zeiss OCT machine. There are a lot of other machines as well. Now these are different types of scans. You can have standard scans like raster scans. These are like lines, and each lines are a little apart, and you can have higher resolution here, or you can have radial scans, or even you can have 3D scans. Complete this cube is basically scanned, in which the information is basically stored as a DICOM, and then that is converted into a JPEG image for us. Now, usually you can have undilated OCTs as well. OCT generally looks into the posterior pole, but with the newer versions you can have very wide field OCT, but magnification, pupillary dilatation definitely gets a better image. So patient is instructed to look into one particular central dot, and then we take the OCT. So now we will go to how to interpret it. So you should understand that these are the different structures that we will understand by looking at the OCT, right from the vitreous. Okay, the vitreous can be completely clear, or can have cells, or can have PVD, a lot of things in the vitreous, and then the interface here, and then you will have the retinal nerve fiber layer right on top, and then we will have these two lines. One is the outer nuclear outer plexiform layer, the inner nuclear inner plexiform layer, and the outer nuclear outer plexiform layer. You can see that this dark images are the nuclear layers, and the lighter images are the plexiform layers. Okay, and then the outer retina, you can see clearly here that there is the external limiting membrane first. This one is the external limiting membrane, and just below that, a very clear area is the myoid zone, and then this is the ellipsoid zone. This thick white line is the ellipsoid zone. And below that, we have the interdigitation zone, and then the retinal pigment epithelium. So these are the structures that we will look at in the outer retina. Okay? And then obviously the choroid and the sclera here. So the choroid sclera differentiation will be seen in the EDI scans. Now, whenever you are getting a scan in front of you, don't forget to look. I have had bad experiences with people coming to me, and a scan is provided by somebody else, and it is absolutely another person's scan. And I talk to that patient, oh my God, you have this problem, that problem, and then finally I have to eat my own words because clinically if it is not correlating, or that patient's look is completely bewildered because he has been treating all this time and he has never been told all this, you immediately go back and look at what is here, and that is a very important thing, definitely. Okay, because now a lot of OCTs are coming, a lot of patients are coming, mix and match is a basic problem. And identify the signal strength. Sometimes what happens is that, some areas are not very significantly, the signal strength is very poor. And in such areas, or sometimes some areas are not scanned at all. So some of the RNFL defects or so-called ganglion cell thickness reduction may be secondary to a poor scan. So you should look at all that. Okay? Then, as I said, you can look at the vitreous, the epiretinal area, the vitreoretinal interface, inner retina, outer retina, and subretinal space. All right. So we have hyper-reflective and hypo-reflective areas. So we'll go to that. Okay. These are some of the layers which are hyper-reflective, but these structures, like the drusen, the pigment epithelium, detachment, ERM, the choroidal neovascular membrane, scar, hard exudate, hemorrhage, these are all hyper-reflective, which means they are whiter than the other tissues. And these are the hypo-reflective tissues, the ganglion cell layer, the inner nuclear layer, and the outer nuclear. The nuclear layers are generally black in color, and the plexiform layers, which has all the fibers, are actually white in color. And fluid, intraretinal, subretinal, fluid, or even sub-RPE fluid, they are the ones which are completely black in color. Okay, so they are hyporeflective. So we have hyper-reflective lesions, we have hyporeflective lesions. These are some of the hyper and hyporeflective lesions. Now, how do you, qualitatively describe the OCT? You have to describe it by location. Where are you finding the lesion? And then, what is the form and structure of that abnormality that you are seeing? And we'll try to identify which layer is involved in that anomalous structure. And then we will also talk about the reflective characteristics, hypo or hyper reflective, etc. In quantitative measurements, in most of the quantitative measurements are inbuilt, in the sense that the company has given it the software there, so you just have to see that, and the analytic quantitative analysis immediately comes out. So, but we should understand that the spectralis versus the size versus a TopCon versus some other machine, they all have a little differentiation in their quantification, so it cannot be completely translated. Like in the TopCon machine, you had 280 microns or 380 microns, and then you gave an injection, and the size machine you got 320 microns. It cannot be translated like that. In the same machine, you should basically look at translation. All right. So you should also understand that spectralis, it's ILM to the posterior edge of the RPE which is measured, which will be a little higher than the cirrus, in which ILM to the anterior edge of the RPE. So the thickness of the RPE will be additionally measured, maybe about 10 microns or so in the spectralis machine. Macular thickness is given like this. You all know, you would have seen these scans. This is a central one, inner circle, outer circle, and there is a color-coded map as well. So these are the same. Now, what are some of the interface diseases? Now, we can divide the vitreoretinal interface into vitreomacular adhesion, vitreomacular traction, and even a full thickness macular hole. So, vitreomacular adhesion is usually, it can be focal, it can be broad, isolated, or concurrent. Similarly, vitreomacular traction can also be like that, focal or broad. So, the difference between adhesion and traction is, traction will definitely have a anteroposterior push. Okay, so here are some examples of adhesions. These are textbook pictures. Some adhesion is coming on here, whereas traction will have the vitreous which is pulled up, and the macula or what part of the area which is connected, that will be elevated significantly. And epiretinal membrane also, you can have 1A outer retinal thickening, okay, with minimum inner retinal damage. There is some thickening here, and then retinal inward projections like this with inner retinal thickening, and then prominent thickening of the inner retinal layers completely. So this is 1A, B, and C, and then 2A with formation of a pseudo hole, and 2B with more of a schisis cavity inside. And these are some of the epiretinal membranes pre and post surgery. You can see the membrane here, which is completely removed here. A vitreomacular traction before surgery and after surgery. These are all broad adhesions before surgery and after surgery. Macular hole, it's a clinical diagnosis. You can see, you can do Watsky-Allen test on slit lamp. You can actually find out the macular hole on a slit lamp biomicroscopy. But this provides confirmatory findings. This tells you the size of the macular hole, the type of the macular hole, and so that we can plan our surgery accordingly. So we have different stages of macular hole, and you should understand that Don Gass had classified macular holes based on his drawings, based on slit lamp biomicroscopy. He did not have an OCT at that point of time. See how accurately he depicted his slit lamp biomicroscopy into drawings, and that is completely now acceptable with the OCT. So that is a skill that each one of us, all junior PGs and all, you should understand that that is the skill that you can develop if you look at a long period of time with a stereoscopic biomicroscopy. Not just look at some hard exudates or hemorrhages, but look into the inside of the retina, the inner retina, the outer retina. You can see through it, just like you are seeing through the cornea. You can see through the retina because it is completely transparent. So we all know, stage 1, 1A, B, 2, 3, and 4. These are this is another type of classification. Let's move on. This is a hole, typical hole, in which this is a little elevated here on either side. This is a central hole, and this is again another hole. Pre-surgery and post-surgery. Now with internal limiting membrane peeling, as well as an ILM flap, we can have very good results with the before and after surgery. You can see the surgical results. Vascular diseases generally involve the inner retina. Vascular diseases primarily are the diabetic retinopathy and the retinal vein occlusions. And primarily it involves the inner retina. So inner retina, you can have myriad types of edema. But one should understand that the rods and the cones, which are critical in vision, are in the outer segment. So just based on an inner segment edema, your vision may be very variable, and with injections, these edemas significantly come down. And if there is not significant ischemia or significant outer retinal damage, your visual acuity can improve significantly. Okay, so the types of in retinal vascular diseases, you always look at the patterns of diabetic macular edema, and that would have a little bit of decision-making capacity on the treatment, protocols. And we will always quantify the CME in any of these, and then that is helpful in monitoring the response to treatment. And we also have a lot of prognostic biomarkers, which I am not going to in this study, okay, in this particular presentation, because that is again another long topic. Okay, so diabetic macular edema, you can have spongy or diffuse thickening, cystoid macular edema, serous retinal detachment, posterior hyaloid traction, and even TRD. So this is diffuse edema. You can see that there is not just one layer, the whole layers are completely edematous. Whereas this is more of a cystoid space with interdigital septa, etc. You can have central, you can have round cysts like this, usually in the inner retina, not so commonly in the outer retina. Cystoid macular edema. Then the whole of this particular area, this retinal, right from the retinal pigment epithelium, it is going up in a serous retinal detachment, and you can have mixed type of retinal, mixed type of diabetic macular edemas as well. In vein occlusion also, you can have cystoid macular edemas, or even submacular detachments, etc., etc. In BRVO, it will be usually confined to one area, and in CRVO to all the 360 degrees. These are some of the examples like this: branch retinal vein occlusion and central retinal vein occlusions with edema. Sometimes if there is traction, retinal detachment, that can be, or a secondary regmatogenous retinal detachment, in which, like in this particular case, it is a little covered with blood, so it's not very clearly seen clinically. You can see an OCT and you can make out the retinal detachment in that particular area. If there is an artery occlusion, what usually happens is the inner retinal layers become completely hyper-reflective. It will become completely hyper-reflective. That is because of ischemic infarction, and the cells become so much necrotic that it becomes hyper-reflective. And later, in the chronic phase, that hyper-reflectivity can be gone, but generally the retina becomes atrophic, thin, and foveal atrophy ensues. Now coming to the outer retinal diseases, more common would be the retinal pigment epithelial damages, which are like drusense, dry age-related macular degenerations. There will be excrescences on the drusense, and based on whether it is on top of the RP or below the RP or at the RP, or whether its hyperreflectivity is more, we will term these drusense as basal laminar, basal linear, calcific, cuticular, like that. We will have a differentiation based on that. Whenever you are moving to an exudative retinal detachment, what happens is there is going to be fluid here. So whenever the presence of fluid, tells us that it is exudative retinal detachment. Fluid can be intraretinal, like this is the inner part of the retina. It can be intraretinal fluid, or it can be subretinal fluid, which is on top of the retinal pigment epithelium, and sometimes under the RPE in a large pigment epithelial detachment as well. So these are some of the cases in which you can see here that there is this RPE itself is going up like that, and there is some inner retinal fluid and some subretinal fluid and sub-RPE fluid. This is how fluid will occur. This is predominantly a sub-RPE fluid, but you can see some subretinal fluid here and some intraretinal fluid in these particular areas. So fluid in an OCT in the retina associated with outer retinal damage will signify diagnosis of a choroidal neovascular membrane. Always rule out a CSR or something like that as well. Here you can see more pertinent subretinal fluid with a pigment epithelial detachment and sub-RPE fluid here, not so much of an intraretinal fluid. So the types of CNVM are, if there is predominant inner fluid, then it is a type 2 choroidal neovascular membrane. The whole choroidal neovascular membrane is on top of the RPE. Whereas if it is below the retinal pigment epithelium, what usually happens is a pigment epithelial detachment with subretinal fluid. So that's a type 1 choroidal neovascular membrane. So this is again, you can see a large pigment epithelial detachment with subretinal fluid, no intraretinal fluid detected here. We should not just mistake. I have many time and again, I have seen a lot of patients getting an OCT done and they have some fluid and they will have one PED here, 1 or 2 PEDs here, and they are asked to get an injection done. Some of these are CSR patients. So always look at the age group of the patient. If it is younger, if the patient is on stress, and if there is only fluid and one small pigment epithelial detachment. Pigment epithelial detachments are seen in a lot of cases of CSR. So just because there is a pigment epithelial detachment and some subretinal fluid doesn't make it a choroidal neovascular membrane. A lot of these patients with observation will just go well in hand. You can see the right, round central this thing. Okay. So these are central serous retinal. A small short introduction to OCT angiography also I have planned here. So OCT angiography, now till this point of time I was just looking at the layers, and these layers we were just taking, we were putting waves inside, and the reflective waves were being timed and looked at what is happening. Now we are looking at the RBC movements. So when you are looking at the RBC movements, either to this side or that side, and we are looking at the differential RBC movements based on scans. That is how you get OCT angiography. So again, acquisition, the number of scans that you will require are much more, like 1 lakh to 4,000 scans, and for 4 lakh scans, and then it's processed, and the reconstruction is something like this, an OCT angiography map. Okay, so that is what is generated, and you can see that the arterial flow and the venous flow can be differentiated and differentially color coded because of the movement of the RBCs that we can scan and find out. Clinical use, again in all these conditions we can clinical use, very rapid rundown of those. This you can see a neovascularization here. You can slice the slabs, and each particular slab you can look at how is the neovascularization, how is the fluid, etc. So here is a condition where you can see that the neovascularization is increasing. And you can see these are neovascular tissues. A medusa head appearance is there here, right? So these are all, type 1 and type 2 choroidal neovascularizations are made out by saying whether it is on top of the RPE or below the RPE. On top of the RPE is type 2 and below the RPE is type 1. You will get, neovascular processes like this. And, here you can see, type 3 neovascularization, which is fairly rare. You can also see fibrotic changes. This is a large pigment epithelial detachment, and within the pigment epithelial detachment you can see the fibrovascular changes. Polypoidal vasculopathy also, you can see polyps on ICG, and here also you can see the typical shape of the retinal pigment epithelium, and these are the structures on OCT angiography where you can see the polyps. In non-proliferative diabetic retinopathy, it can vastly replace fluorescent angiography. Just like Saravanan said, in an OCT you can pick up new blood vessels. So these are ischemic changes which are showing. This is the fluorescent angiography, and this is the OCT angiography. And you can see diabetic macular edema also. One thing that you can upon
NSAIDs for at least 2 months, but usually post-op CME happens after 1 month. Not immediately after surgery. So in these cases, recently we have done PRP also. So that inflammation also will be there. So it will be better to give topical steroids and NSAIDs for a longer period of time. And
okay, so audience, do you have any questions or any queries which need to be addressed?
My question is to Dr. Saravanan. You were talking about combined cataract with injection. Would you prefer injecting DEX implant or an anti-VEGF, Ozurdex or an anti-VEGF while treating DM?
So it doesn't make a big difference, depends on the, one is mainly I think about economics, because we don't inject IVT in a hospital, we only go use the Ozurdex. So Ozurdex pushes the cost almost double. Cataract surgery is around 20,000, this is again 20, another 20,000. It doubles the surgery, cost of the surgery. So that is one thing. Otherwise, if the patient is not feasible, I'll go for anti-VEGF also. So ideally, steroids is better, depending on, you'll have to look at the OCT biomarkers of hyperreflective spots as well as SRF. If those changes are there, I would prefer steroids, because it will cover for the postoperative inflammatory changes also. But if it's only a purely cystoid macular edema, or the patient has got coexistent PDR, or the economics is an issue, then I would prefer to go for anti-VEGF actually.
But if you're injecting an anti-VEGF, would you then still repeat the anti-VEGF every 1 month after the initial procedure, because after 4 weeks then the drug is not there?
So this is not anyway it's not a one-time event. Even if a patient is not undergoing cataract surgery, the rough estimate by many studies have shown that in 1 year, in the first year in initiating therapy, the patient needs at least 5 to 7 injections in the whole year when you are treating for macular edema. Minimum of 5, average of 5 to 7 in the first year. So anyway, that is repeat injection is a routine thing, even if the patient is not undergoing surgery, so not a big issue actually.
So would you prefer to inject anti-VEGF before the cataract surgery or just after?
That question is not, I was putting in one of my slides also. Normally if you inject before, by the time the edema is resolved, the patient will look forward to the immediate post-cataract vision. No, what I'm saying is the patient is always looking at the immediate post-cataract vision. So if the edema is already subsided, he'll get a good vision and he's happy with vision. But in our hospital, the problem is that asking them to come back and forth for each procedure. Once injection, then surgery. So we try to give it as a combined injection on the...
He was asking us, just before the procedure itself.
Okay.
Start of cataract surgery you inject or end of cataract surgery?
We inject at the end of surgery. Sorry, I didn't get the question right. It's at the end, immediate of the surgery. So I asked the surgeon to keep the eyeball a little bit soft so that all these complications of iris prolapse all does not happen. But usually in phaco is not a big issue. So I asked them to keep the eye a little bit soft. Don't hydrate the antechamber tightly. Keep it a little bit soft. Inject and then compensate if there is any hypotony.
I'd like to talk a bit about comorbidities. We had a Indian Ophthalmology clinical trial network in which about 10,000 patients were enrolled, and the average hemoglobin A1C in diabetic patients is about 9 in the first year. By the end of the first year, because we have injected many patients, etc., and we will counsel the patient that if you keep your blood sugars low, then the injection will come down. By the end of 1 year, the hemoglobin A1C average in the country is about 8. So that is the hemoglobin A1C control. Many of these patients come when urea levels are fairly high. Creatinine is on the brim, 1.3, 1.4. At that point of time, many of these patients, if you look at it, comes. Then another thing is, regional variation, which is very, very important, which is very interesting also. In Kerala and in West, it's like Mumbai and all, we have a coronary artery disease of about 25 to 30%. In central India, it is only 3 to 5% because they are rural. The rural-urban divide is so stark because our lifestyle diseases, all the lifestyle diseases including cholesterol, including hypertension, everything is higher here. Stroke is about 11 to 15% incidence in Kerala and in Mumbai, whereas in center and in east, it falls down to 3%.
So on this very interesting study on regional variations from our hospital, Dr. Siddharth Narendran, son of our CMO, he did a study on comparing the retinopathy levels between Kerala and Tamil Nadu, and he found that it is quite high in Kerala, and he did a small survey and isolated the use of coconut oil. He feels the excessive use of coconut oil in Kerala pushes the incidence of retinopathy amongst the Kerala population. It looked at various factors, food, their economic status, and a lot of factors he considered, and finally it narrowed down to the use of coconut oil, which is vastly different between Tamil Nadu and Kerala.
I have also encountered in Madurai when we were doing vitrectomy for diabetic vitrectomy, intra bleeding was relatively less. But when I came here, it is so much that I have to give pre-op. I was asking for almost every case. So I don't know whether it's some bias or.
When I was in Aravind, during camps, the patients from Tamil Nadu will have only, I think, less than 10% diabetic. And Kerala camp patients nearly 60% diabetic. So that also there.
So at the end, I think the take-home message at your level is check all the comorbidity indicators and ensure that all biochemical parameters are good. Hemoglobin, anemia, one enzyme which has to be considered, nephropathy and other such macro and microvascular complications have to be taken into consideration. Carotids have to be evaluated. Do an angiogram, OCT or OCT angiogram, so that we know what are the areas of capillary non-perfusion. Support the retina very well with PRP, with and without anti-VEGFs, and please bring the patient to the routine, regular compliance follow-up pattern, and finally plan cataract surgery accordingly. And finally, maybe patient will need vitreoretinal procedure later on. When you have a localized vascular occlusion in hypertension, it's very common, and that may be the reason for asymmetry in this case. So thank you, doctor. It was a wonderful presentation. Thank you.
Thank you.
Thank you. That was a wonderful session. I'd request Dr. N.P. Baburaj, sir, to please come forward to present a memento to our panelists. Dr. Baburaj, sir. First to Dr. Padma Prabhu. Dr. Shabarish. Dr. Sharmila MB. Dr. Sharath Ravi. A token of appreciation to Dr. Yasser Arafat. Thank you, sir. With that, we come to an end of the pre-lunch sessions of Oculus Season 5. Please enjoy your lunch and please collect your certificates from the reception area. Thank you. Will be a postgraduate update session conducted Sir is a veteran teacher with many years of academic, clinical and surgical experience. I request all the delegates and the postgraduate students to please occupy your seats for the session. I request all the postgraduates to kindly occupy the front rows. Please come forward. All the postgraduate students, please come and occupy the front seats. The session is about to begin.
Random question.
Sir, there is a list of around 50 of them are there in the list.
Start பண்ணலாமா? Hello, good afternoon. Can you hear? Can you hear? I thank Dr. Sreekanth for this great opportunity. I am very happy to be here because I left government service nearly 13-14 years back, and I have come again to meet. Of course, I have been meeting students for the past so many years. And I am a DNB teacher for FRCS teacher and all, so that naturally I am concerned with only students only. I will ask few questions only. Hello, don't be bothered about that. Don't be tensed up. Don't get depressed. Even if you don't answer, I will tell the answer, don't worry. This is only an interaction. Hello, interaction. I will select few PGs randomly. Anaga. Where is Anaga? Absent. Anaga. Anaga, come here. Anaga, please come front. Because I know one Anaga, she is in E-Road now. Come on. Suma Makkanduko, hello. Don't worry. Anju. Anju engada? Anju, come on. So first page I have selected 2. Okay, I don't know whether name is there in first page or not. Brinda. First row. Hey, come, Anaga, first row. Anaga, apre enga other friend, other girl. Fatima absent. Hey, Fatima, don't get depressed. Hello, come forward. Where is Fatima? Da? No. Sorry, pona podu. Hello. You are 3 here, no? Don't get tensed up. I will ask questions. Slide change பண்ணணுமா? இந்த ஸ்லைடை எடுத்துடணும். இந்த ஸ்லைடை ரிமூவ் பண்ணி என் ஸ்லைடு வரணும். அஸ்வதி, நீ உட்காந்துக்கோ. One advice for the students, when you appear for theory exams, you will have some 10 questions, hope so. You will have some time duration, 3 hours, 180 minutes. That means for one question, you have maximum 18 minutes. Understand now? Suppose you know something more, don't write 30-50 minutes on all one question. Afterwards, you'll be losing 2 or 3 questions. You are going to lose the answer, marks. Just because you have written for so many pages, nobody will give you marks. Please remember, you have to attempt all the questions. That's the most important. Just because I know something anatomy very well, I cannot take 1 hour and write. And the remaining questions, I will not have time to write. Okay, this has happened with me. Hello, recently, 1980, Sunstone Hollow. Recently it has happened. Because I know I was knowing anatomy very well. Then pharmacology area, I got finished. I didn't have time. But follow, that's why I'm telling you now, advising, stick to the time. 17 minutes over, stop. Don't write further. Go to the next question. Next, of course, leave some space and then go. Write questions, answers in order. Whatever order is there, 1, now 1. Don't write, first I know 1 question 4, then come to 1 like this notes. In order you have to write, then only they will know the marks. They can give marks or all. Otherwise they will give, randomly they will give marks. I've seen. Okay, next clinical examinations, my advice is, most important, don't take clue from anyone, including your professor, including your assistant professor, whoever gives clue, don't take. You know one thing, what happened in my life I am telling now. We were appearing for MS exams. Outside they were telling, one case of sympathetic ophthalmia is there inside, finished. One case of sympathetic ophthalmia was there inside. The clue. One assistant professor only gave us. We were 3 students, please remember that time. Okay, when he entered, one patient, he had gone down, he told now some history of injuries there. Again, other I showed uveitis, agreed. Okay, then what happened now? My 2 students went first and then presented sympathetic ophthalmia. They will and left. My luckiest, that time it was pure luck. The examiner asked me, define sympathetic ophthalmia. Instead of going to the case, I told, it's a bilateral gangliomatosis uveitis occurring as a result of injury to one eye. Like that I told. Now only it struck, right eye history injury was there, left eye uveitis, right eye was quiet. There was no evidence of uveitis. Then suddenly I changed the answer to uveitis. Please remember, I got through the exams, other 2 fellows finished. This has happened to me. Understand now, these things, never take clue from anyone in the hall. Don't ask one student would have gone first now, she may be coming outside. Don't ask her, what did the examiner ask you and all, don't answer. You get confused, you get tensed up. Relax and go inside. Nobody is going to come there to fail you. Everyone wants to give you a pass only. Please remember, no examiner will fail you. If you want to fail, you have to fail. That's all. Hello. I don't follow. You have to work very hard to get failed. This is what my advice. Never take more time to write one question and all. Just stick to the time. Never take clue from anyone in the exam hall. Whatever finding you have seen, you just see and then present. That's enough. Don't bother about diagnosis. Don't bother about diagnosis. You tell the findings. If at all you want, you can tell differential diagnosis. That's enough. Nobody will penalize you for not knowing diagnosis. You follow. These are all the classical advices I used to give to my student. Okay, if you follow, you can easily. It's not real difficult, man. You are all what DNB, MS and all, whatever ophthalmology is there. Is the only easiest subject in the whole world. Easiest subject in the whole world is what? Anaga. Ophthalmology. What? Sure, no? You are studying where? Anaga. Your Calicut. Very good. DNB. Diploma. Then you can read. Okay, Simon. Don't worry. Now I will give a slide so that you can see the slide here. What finding you are going to see. So now what you are seeing is what? A vein. Can you see a venous pulsation? Now the question, because you know what will happen now, you are going to present a case of fundus. You know that everywhere you are going to present a case of fundus. Now fundus you will tell media clear, optic, this something you will answer, you will tell what of this color, cup, margin. Like that you see, normally you are supposed to see a pulsation also. The venous pulsations are normally seen, may be absent in 20%, that's all. Venous pulsations are normally seen on the optic disc, may be absent in 20%. Otherwise 80% will have this. Have you ever noticed? Anaga, have you ever noticed? See the fundus, you can easily see. Okay, that's a normal affair. But the question is what? Those are DNB now. MS. MS now you must answer. Which year? First year. I have selected a wrong person. Any third year? Final year? Hey, don't bother about hello. Any final year? No final year. Hello? MS, why do you bother about me? Any second year? Hey, nobody is opening. Divya, what is happening to your area? Divya, very bad. Your area is very bad. Okay. Anaga, no other chance. Anaga, your final year? DO final year. Don't worry. Slide us. Sit down. Don't bother about. Don't get something tensed up or not something because it appears as if I'm shouting and all. Don't take it seriously. Okay, it's fun. learn, relax and learn. Okay, this is what the venous pulsation. Now the questions will come like this. Doctor, this venous pulse is the common affair I told you. Can you tell me in what part of cardiac, a period of cardiac cycle you can get it? This is the question. No, what will happen I will tell you. During systolic cycle, more amount of blood enters my eye, intraocular pressure increases. It's going to compress the vein. Diastolic cycle, less amount of blood, IOP is coming down, veins are dilating. That is what's venous pulsation. This venous pulsation on the optic disc is normally seen, occurs during diastolic. That is why it is called negative venous pulse. What you are seeing is called a negative venous pulse, not positive. Positive, what do you mean positive? It occurs during systolic. But normally you get what diastolic cycle only you are getting, that's all. You have to follow. Understand? Now the important clinical examination, what? A classical exam question. See, normally these venous pulsations are spontaneous, may be absent in raised intracranial pressure. A papilledema patient. See now, papilledema, suppose in doubt, you are having a margin is blurred, like that, no, you're telling now. You doubt is a case of papilledema, bilateral case, that's okay. Doubt. That what one significant finding is what this absence of venous pulsation. You have to follow. Anaga, are you able to follow me? I will tell you, tell now, sir, venous pulsation absent, a case of papilledema, I will tell. I will tell, doctor, 20% normally absent. 20% normally absent. Now it's only slightly blurring of the disc. How do you know if this is the papilledema or not? We'll ask you. Now your answer is, sir, I will give pressure over the eyeball. Press it. See the, of course, optic disc. The veins will collapse because you're increasing intraocular pressure. You release the pressure. The veins will dilate. That is, understand now, that's venous pulse. We are created now. That also is not possible. Even by pressure, I cannot elicit the venous pulsations. That's a classical finding of a papilledema patient with raised intracranial pressure. Then it's called the question we will ask in the exams. Vanaga, understood? Sure. What is negative venous pulse? What is positive venous pulse? I told you during systolic cycle. Can you get? Now you should know something basics. In systolic cycle means how it's possible now. You know right ventricle, left ventricle and all. Right ventricle, when it contracts, it enters your pulmonary artery. Instead of pulmonary artery, when a tricuspid incompetence is there, the blood can enter my right atrium. From right atrium, it can go to superior vena cava. From there, it go to my eye. The veins will dilate that time. Understand now? That means what? Positive venous pulse in systolic cycle can occur in a case of tricuspid incompetence. This is what exam question, Viva question. You know, how do you follow?
Yes, sir.
Any doubt?
No, sir.
Sure?
Yes, sir.
Definite?
Yes, sir.
Tomorrow I will come and ask you questions. Your name is? Brenda. Anju. First year. Brenda in the year? First year. Same class? No. In the college? Chandragana. You are also, you told.
Same, sir.
Yeah, final year, hello, MS. DO, MS. Hello, nobody is there. Huh? Hello, hiding, I think. You are final year. Huh? Papa, yellow, come on. Yellow vision, come on. Hey. So, fun, don't take it serious. Hello. You are wearing yellow, no? Yellow, green. Green, light green. Mixed. Yellow, colorblind are you? Hey, you are considered colorblind. No, I am having. From distance, I can tell you. You are colorblind, considered colorblindness you are having. I know that. Hey, Anaga, you see this girl and tell me.
Green.
Hey, she is wearing green, then yellow. She is selling green. You are colorblind, no? Hey, considered colorblind, then illiya? No, sir. How do you know? Anytime you got tested?
I can identify color.
You can identify colors. What is this color? Blue. This is color, the rose, you know this. I don't want this answer. You must tell, sir, congenital colorblind, it is an X-linked recessive problem, female, only carrier. I cannot have. Lateral must is the answer. I can have acquired. Of course, optic neuritis can occur to anyone. But congenital colorblind, hello, remote chance, you will never get. Hello, that is why I asked you this question. You must tell what? In a past, no. Shut up, I'm a girl. You will tell what? Shut up, I'm a girl. I mean, if you tell the answer, then okay. That's why I asked this question. Understand now? In the exam time, Viva session, nobody will be under tension, anxiety. Now, one day, hey, we are having colorblind now, congenital. No, sir, I am more PK, sir. You must tell what? I am a girl. So, I am a girl. That's all, answer over. I don't follow. This is the way we ask questions in exams. Because the exam time, we will forget your name also. What's your name? She will tell. Are you follow? Anaka understood?
Yes, sir.
So this is the pulsation of venous pulsations with optic disc. Definitely, in a case of papilla edema, you are supposed to look for presence of venous pulsations. And then never forget to give a compression over the eyeball, see the veins collapsing, then release the compression, the veins are dilating, that also you are supposed to see. Then when you present, sir, venous pulsation, absent, sir, even on pressure, I am not able to elicit, sir. Finish, chapter close. This is the way I have to answer in the exams. Understand now? Hello. Your name is
Krishnapriya.
Krishnapriya, KP. KP then, a shortcut. Dr. KP. KP. Babare. So far I have told you what now venous pulsation, but I have told. Now we see now here. Now keeps on saying hello. See the artery. Artery starts pulsating. Can you see this?
Yes, sir.
Hello.
Yes, sir.
Therida illaya?
Yes, sir.
Malayalathilu enna? Therida ganapadtava ennadu? Mansulava. Manasilayi. Oh. Manasilayi thana. This artery pulsations. Hello? Sure. Now I'll tell you, when you see arterial pulsations with optic disc, is always pathological. Never forget this statement. Always pathological. It cannot be physiological. Venous pulse, yes, physiology. Negative venous pulse are physiology. Whereas artery pulsation is there, it's always pathological. Okay? Now, KP is going to answer because final year. KP, MS final year, MS. Which college? Manjeri. Then you have to answer. No other go. Okay, Manjeri. Come on, Manjeri. What is the normal blood pressure of CRA? This is why going on. In the Suma case of project artery pulsation, you are told. Now I am asking you, hey, come on, KP, tell me what is the normal blood pressure of CRA or ophthalmic artery?
8 to 13. 8 to 13.
Age 13. Enna solra age? Diva enna sonna?
8 to 13.
Diva enna solra purila?
8 to 13 millimeters of mercury. 8.
8.
8 to 13 millimeters.
8. That's vein. You are telling about the venous pulse pressure inside the vein is around 8 to 10 millimeters. This artery, hello. This artery 8 and all will hello going towards upper world. Artery pulsation, now it has to be something high. Okay, I will ask one question. Do you know some instrument was available those days to measure the BP of CRA? Ophthalmometer. Very good. Super answer. Okay. Now I don't have ophthalmometer. It's only museum. Then how do you measure the BP, CRA BP now? Your answer should be, sir, take the normal BPs. Brachial artery BP. Agreed. Now you tell now, 120 by 80 you tell. Normal systemic BP now. Normal. Brachial artery BP. Now you take now, systolic is 120. 2/3 of systolic. 120 ke 2/3 evala. 80. 80 is systolic BP of CRA. Understand now? Hello, KP. 120 by 80 then. 120 2/3 80. Now 80 then a diastolic outside, like half of diastolic, 40. So your BP in CRA should be approximately 180 by 40 when your BP is 120 by 80. 2/3 of systolic and half of diastolic is the BP of your CRA. Because you are not going to measure, please approximate. You have understood?
Yes, sir.
Or you follow?
Yes, sir.
Now never forget one most important point. This artery starts pulsating on the optic disc only when the intraocular pressure is above the diastolic pressure of CRA. Diastolic CRA, I told you what? How much? 40? IOP is 41. You see the impediment to the flow. Artery will start pulsating. You've understood? That's what you are doing after dynamiters and all. Just I'm telling you now, when you see arterial pulsation in the optic disc and you have taken a BP outside 120 by 80, that means your IOP should be more than 40. You do follow? Anaga?
Yes, sir.
IOP should be at least 41. This is an important finding. Your answer is, hey, KP, you will be present in case of glaucoma. You tell now, sir, BP, sir, I know you would not have taken also BP, exam hall. 120 by 80 you will tell. Then you will tell now, sir, IOP, sir, 45, sir, you will tell. Applanation tonometer at the time of wound, you will tell all these things. You will be waiting for the answer. Oh, what? Disc. Disc, you will say disc is normal, you will tell. Or cupping, cup disc ratio, vertical cupping, something you tell about glaucoma only, you tell. You will forget about the arterial pulsation because you are told now, hello, 120 by 80 solita. It has to be your IOP is 45. It is more than diastolic pressure of CRA. What we are supposed to expect? Artery pulsations. We will ask you a question. Have you ever seen any artery pulsation? No, sir. No, sir. Okay, thank you, doctor. So, thank you, doctor. We will meet again after 6 months. So, whether you will tell in the exams. We will meet you. What? For fun only. I don't take it seriously. This is the way we and for fun. Now this is what we have understood now question. Now the same thing we'll ask you. Okay, doctor, intraocular is only 15, 15. I see artery pulsations. What's your answer now? 15 only 15 artery pulsation is seen. That means what? That 15 is more than diastolic pressure of CRA. Then only can aortic pulsation. That means less than 15, 14 or 13. That means CRA diastolic is 13 means systemic will be about double the value, 26. All right, follow. We'll ask you a question. When do you get this? When the IOP is 14 or 15, you see artery pulse, your answer is what? Hey, shock, syncopial attacks. When the BP is very low. When you see, hello, artery pulsation, the optic disc, if your IOP is normal, think about the patient is inching towards the upper world. So, inching towards the upper world, hello. You are able to follow me. That fellow is going to die. You have understood now?
Yes.
This is what classical questions we expect. Pulsations of the optic disc. Nobody can escape these questions. Because anyhow you are going to present a case of fundus. You will tell optic disc only. We will be waiting for these questions. Even if you are not telling what about venous pulsation, we will ask you some questions so that I can spend time, hello. Can be understood. This is what the beauty of these pulsations and all. Now we see pupil. Hey, everyone will have to answer the pupil, you know that? Hey, you will see pupil, man.
Yes, sir. Yes.
Definitely will see pupil.
Yes. Yes, sir.
Pupil, direct, indirect, something you tell, no, all these things. Now we see right pupil contracting, left pupil start dilating. Can you see this? Now again right pupil contracting. Now go to left pupil dilating. What do you answer now? Answer.
Later afferent pupillary defect.
Left eye.
RAPD.
Don't tell RAPD shortcut.
Relative afferent pupillary defect.
Full. Marcus gun pupil. Relative afferent pupillary defect. I don't give shortcuts in exams. RAPD agreed. Everyone knows. But some examiners I have seen now, they get furious. You tell no. Fovea. Something you tell no. Huh? FR, friend, I will ask you. FR, very good. Thank you. Go and meet your friend outside. KP, understood? Yes. The FR, the muddy, buddy, don't tell. Whatever finding you tell, just tell. Foveal reflex, relative afferent pupillary defect. Sentence, full sentence you tell, at least. Beginning. In between you can tell nothing wrong, doesn't matter. Adhe madam, morning I saw someone was presenting cases, they were presenting general examination, okay, over. Then system examination they told. Then only came to eye. Hey, you are having only 20 minutes, man, or 30 minutes examination time. How can you examine systems, man? CVS, RS, hello, each system will take about 2 hours. If you tell system examination first, I will fail. But that has been taught like this. Everyone is telling the system exam first. That doesn't matter. But I can create problem for you in the exam hall. Are you follow KP? நீ சொல்லும் போதே சார் ஜெனரல் எக்ஸாமினேஷன் ஐக்கு வந்துரு நீ ஆப்தல்மாலஜிஸ்ட் தானே யூ ஆர் an ophthalmologist you are tell the eye examination first then go to system examination who bothers about depending upon the eye condition you select a system see no palsy is there you see CNS venous pulse you taste the CVS like that you select a system don't tell system examination all normal we'll there it will stop you and ask questions. Are you having knee happening? Hello, tuning fork, you will not have. Hello, then how can you say it's normal? Hello, reflexes pathia, and we'll ask you. You will not be carrying all these things in the exams. Are you to follow?
Yes, sir.
Are you to follow me?
Yes, sir.
Definite?
Yes, sir. Yes, sir.
Sure, very good. This is what RAPD. You know RAPD, problem, commonest cause is what? Optic neuritis, you know that. But not only optic neuritis, retinal problems also can produce CRA occlusion, vein occlusion, so many things are there. Understand now? Never forget, RAPD can also occur in midbrain lesions. You know why? Pupillary fibers, light reflex pathway, retina, optic nerve, chiasma crossing. Tract comes out, enters midbrain, dorsal portion, pretectal, Edinger spall. So, and the Edinger spall, up to the Edinger spall is an afferent pathway. So, when you have a pretectal nucleus problem, international neural problems in the midbrain, itself can have RAPD. It's an afferent pathway. Hello, Anaga, are you able to follow me?
Yes, sir. Yes, sir.
Afferent, relative afferent pupillary defect can also occur not only in optic nerve, retina and all. You can have even in tract, even in midbrain lesions you can have. Are you able to follow? You know one thing, RK, RP. KP. Now, optic tract tract has got what? Same side temporal fibers, opposite nasal fibers. You know that. You know one thing, nasal retina is important for our pupillary reactions. Never forget this. Nasal retina is more. That is responsible for pupillary size and reactions also. You have understood this point?
Yes, sir.
Nasal is important for us. Now imagine now, in the case of the left type people, RAPD. Okay, I told you nasal retina is very important for us reactions. Now the left type nasal retina is where now? After crossing is going where? Right tract. That means RAPD in left eye involved means the tract is involved means it is an opposite tract. Never forget. When you have a tract lesions, opposite eye will only we show RAPD. Are you to follow?
Yes, sir.
KP?
Yes, sir.
Midbrain lesion, I told you RAPD. Now optic nerve problem, I can have RAPD. Clinically, how do you know it's a midbrain lesion or something with some tests? Midbrain lesion is there, RAPD is there, optic nerve problem is there, RAPD is there. How do you know clinically? Is it cannot be midbrain? Your answer should be fields. Hey, midbrain, where is the visual pathway, man? You immediately must tell, sir, I will take fields, sir. Chapter close. No more questions for you. I will take fields, midbrain lesion, there is no visual pathway, so we cannot have field defects. Optic nerve, yes, senderless scotoma, sendosical scotoma. Tract, can have homonymous immunopias. Chiasma area, you can have bitomal immunopias. So many things can happen. Retina also can have scotomas and all. Whereas, never forget, understand now, midbrain lesions, there is no visual pathway, so field effects will not be there. This is what classical normal question. My question, hello. Anaga.
Yes, sir.
Now, examiner, you can tell yours to call me. I will come as examiner. I will have this question in front of other examiners. You will answer, no?
Yes, sir.
Then the other examiner will die. You will fall. Hello? KP, you tell Kerala University,
Kuhas.
Kerala University. You tell them to call me. I will come and ask these questions. Now we see light, no reaction. See, now is going to converge. Can you see now contracting? Hello? Light, no. Near works. Audible for is called light near dissociation. Hey, this is not from internet, no. This is a case from your area. Hello, not your area means what? Kerala. You don't know. Vavakavu, you know? Vavakavu. You don't know? Karunagapalli. You don't know?
Yes, sir.
Karunagapalli.
Kollam district.
Kollam area. Vavakavu, you know? Like your future president of KSY is from that area only, Vavakavu. Rajiv Sukumar, our student, sir, he sent me this photo, video. Rajiv Sukumaran, this case came to his clinic, his hospital. He recorded and sent me what this problem like that. They found out finally, light need association. You know what's happening now? Light reflex pathway enters the dorsal portion of midbrain. Never forget this. Whereas accommodation pathway enters the ventral portion of midbrain. There's something, pineal body is there. Dorsal portion of midbrain compressing. Light is out. Ventral leaf accommodation can work. That's what's happening here. He found out later to be a case of suprachiasmatic tumors. Rajesh Sukumaran told me, sir, this is a case of pineal body area tumors, that area. Hello? This video was sent to me about 10 years back. Okay? You know Rajesh Sukumaran? You don't know? Hey, supposed to be future, then sir, he is going to become president of your KSYS. You should know all your... KP, understood?
Yes, sir.
Light day dissociation, Purida, you are able to follow. Yes, now, then where can one, I told you now, dorsal midbrain syndrome, because of the presence of light reflex pathway in the dorsal, accommodation in the ventral. I told you the difference. One more thing is that Argyle-Robertson people can also produce the same problem, you know that? But what's the difference, they will ask you in exams. These people come, Argyle-Robertson people, what's the difference? Argyle-Robertson pupil is a small pupil. Here's the large pupil, slightly like that. Understand now? Why it's small, we'll ask you. Why in Argyle-Robertson syphilis case, why it is small? Your answer, sir. In Argyle-Robertson people occurs in tertiary stage of syphilis. Tabes dorsalis. That time, the spinal cord also might have been involved. The spinal cord only because center of budge, you know, center of budge.
Yes, sir. Yes,
level.
C8 to T.
C8, T1 or T2. That level of center of budge sympathetic system is there. That fellow is out. That means our sympathetic supplies dilator muscle. Are you follow? Dilator is paralyzed. Only fellow working is what? Constrictor. People is small. That's the way you are telling the exams. We'll ask you, light day association doctor, can it be syphilis? We'll ask you, sir, you must tell. Sir, see the pupil size only, so tell me. Will you follow? Sure.
Yes, sir. Yes, sir.
Sure.
Yes.
Very good. Now we'll ask you one question. Now imagine now, you are measuring, normally when you tell people, you tell what, people, something, small size, diameter, something you tell round, regular reactions, like that you tell. Round, regular reaction, like that you must remember. Pupil is round, diameter, size, you are going to tell. KP, now I measure the diameter is 4 millimeter. It is
4 millimeter.
4 millimeter. KP is telling now. Sir, people diameter 4 millimeter. Telling now. I will ask now. KP, imagine, sir. KP, imagine you are sitting in anterior chamber. As if you are, imagine mention, you are sitting in anterior chamber measuring. What the size? Like, I have measured now 4 millimeter. Imagination now, you are sitting in the anterior chamber and measure. What's the size? Exam question over. Hey, this what exam question? I want to know whether you are applying your brain or not. Please remember, what you are measuring outside, you are measuring through the cornea. Cornea is a plus lens, you know that. plus 40, 45 like this. That's why anything thin to the cornea is magnified. When you're sitting in anterior chamber, cornea is not there. It has to be less only. Will you follow? Hello?
Yes.
You are having a magnification of the cornea is added to the pupil when you are measuring from outside. Go into the eye. Imagine you remove the cornea and measure. It has to be less only. This is what our common exam questions. Understand now?
Yes.
Anaga is sleeping. For fun. Pupils what? Anaga is sleeping. Pupil size what? Anaga, ni thungara. How do you know you're really sleeping or not?
Pupil size.
Huh? Anaga, pupil during sleep, what size? Size, I'm not asking the exact size and all. Larger, smaller, no change.
Smaller. Smaller.
Smaller. Why small? Hey, you are sitting, suppose you are seeing the under sun, maybe light. Now you imagine now you are sitting under the bench. You go down and be sleep here. What will be size? Everything is dark. Pupil is what? Anaga, tell me. Are you able to follow? Question.
Yes, sir.
Hey, either light, everything is there, you are sleeping, naturally light is falling, my eyes, you told now you're so small. Imagination, you are sitting under the bench, no light. What will happen to people? KP, you tell now, you're final year. Purida, your question, are you able to follow?
Yes, sir.
Your answer is never forget. During sleep, pupil is always small. Why in Katangana? Because during sleep, the hypothalamus, which is controlling your sympathetic system, is knocked off. Out. So the sympathetic is gone. Only follow working is parasympathetics. Pupil is small. It's supplying constrictor muscle. That's the practical important what now you know glaucoma case. Angle closure glaucoma, something attacks, suppose you have suspicion, you do a dark room test. Dark room test line up and you are advising not to sleep. The reason is this. When you sleep in the dark room, naturally the people is constricting. Your idea of getting a problem is out. How to follow? That's why you are telling the people not to sleep. It's also you can add in a sense test for malingering also you can write. Imagine Anaga is pretending to be sleeping. Anaga, you go to a room. She doesn't want to see you. Now, if you want to confirm, just open the eyelid. People is large and she's a malingerer. Anaga, are you able to follow me?
Yes, sir.
You can find out malingering as if a person is pretending to be sleeping. Naturally, you can easily find out just by opening the eyelids. Anaga,
Yes, sir.
these are all exam questions.
Okay, sir.
KP, come on, KP. KP, now we have got patient dead. Morning 8 o'clock dead. So,
Morning 8 o'clock.
you are asked sleep at 8 o'clock. You are going to pronounce the patient is no more or something. How do you say?
Pupil will be fixed, dilated and fixed.
Pupil dilated. Can you see with the pulsations? Not possible. Can you with stethoscope? Not possible. Understand now? That's why everything to confirm you are seeing the pupil only. Understand now? Morning 8 o'clock. Imagination. Morning 8 o'clock out. Evening 8 o'clock you go and see. Nobody has seen that fellow. Now hello, you appears to be dead. You are asked to go and see. Pupil is what? Morning 8 o'clock pupil dead day you told, now pupil is dilated. No, it was something you told. But I am asking you a question now. Night 8 o'clock, nobody seen that fellow. Morning. Now night 8 o'clock you go and see. The patient now is what? In rigor mortis. Everything is contracted, no? Like biceps, everything is contracted, know that?
Yes.
Now tell me the pupil is what?
Be
Pupil is what, man? Idalam muscles are contracted. Everything rigor mortis sets in. Pupil is what now, you tell me?
Pupil will be small. Both sphincter and
Just tell me, pupil is what?
small.
Small. Now I ask you a question. These are all what? Voluntary or involuntary muscles? Biceps. Voluntary, involuntary?
Voluntary. Voluntary.
A pupil, I put a torch, can you stop it? Is what? Involuntary, voluntary?
Involuntary. Involuntary.
Now you tell me the people.
Dilated.
Hello, answer is considered only correctly. Because rigor mortis can affect all the muscles. And people consider it very powerful. The compared dilated, people consider it very powerful. That's why in uveitis case you can have constriction of people easily. Hello? Hello? Rigor mortis, people is small. Now you told them, normally you expect what people to be dilated after that. You go and see people is small. Don't tell he's alive. Hello? People smaller is no normal. Like that you don't tell. I don't follow. These are funny exam questions. You get caught in the pupil. Because you are going, anyhow you are going to present a case of pupil, you will tell no. Right eye pupil, left eye pupil, direct conceptual. So that these things will strike our brain. Let me ask you whether this girl knows or not. Anaga, are you okay?
Yes, sir. Yes, sir.
No giddiness?
No, sir.
No chakkar?
No, sir. No, sir.
Chakkar aa gaya?
No, sir.
Hindi you know?
Little bit.
Don't know. Hindi theriyuma? Koncham. But in the pupil sonal lamp, this is another important point. I told dorsal portion, all these things. Take the pathway, accommodation pathway and all. Light reflex comes out, light reflex. Third nerve, lower division comes to my, you know that ciliary ganglion?
Yes, sir.
Ciliary ganglion is what? Parasympathetic ganglion. How many parasympathetic ganglions in the head? How many parasympathetics? 4 என்ன சொல்ல? Ciliary, sphenopalatine, or the lacrimal gland, sphenopalatine ganglions, and arterial ganglion. You know, submandibular ganglion. There are 4 parasympathetic ganglions in the head. You have understood? Upper ciliary ganglion is one. All ganglions will have postganglionic fibers. You know that? All ganglions will have postganglionic. Now you tell me the importance of these postganglionic of short ciliary nerves. Ciliary ganglion, postganglionic fibers are coming. What is the classical point you are supposed to know about this postganglionic nerves from ciliary ganglion? Your answer should be, Anaga, they are the only myelinated. Myelin sheath is there. That's why rapid conduction. When you put a light, sarin is going, people is immediately constricting. That's why demyelinating problems, you get a problem, man. Rapid conduction is because of myelin sheath. They are the only myelinated postganglionic parasympathetic in the whole body. Hello, Anaga?
Okay, sir.
They are the only myelinated postganglionic parasympathetics in the whole body. Nowhere else myelination is there in the postganglionic fibers. You have understood?
Yes, sir.
This is called a classical MCQ, ma KP. Classical MCQ. If you want to write FRCS, this is a classical MCQ. Are you to follow?
Yes, sir. Yes, sir.
If I come as exam, I'll ask you questions. What are the various steps? What's the difference? That's all. Now tell me. Now, if a light reflex pathway, 100% enters your ciliary ganglion. 100%. Accommodation pathway, now trace it. You know, accommodation difference. Light reflex pathway comes from tract and enters the midbrain. I told you. It doesn't go to LGB. Whereas accommodation pathway, entire visual pathway, I tell. It goes to my occipital lobe. From there, it's coming down to my midbrain. Somehow, it enters the ventral portion. I told you. Same third nerve. Same lower division. Same nerve to inferior brain. Coming out. Now trace. You trace the accommodation pathway now. Hey, basic shaking. KP, basic shaking. Accommodation pathway trace panda from, I have come up to the inferior division of nerve now. Now ciliary ganglion level is there. From there you trace up to, before ciliary ganglion trace. See the anatomy particular, you are not studied. The classical thing about accommodation pathway, only 20% enters your ciliary ganglion. Accommodation pathway, 20% only enters your ciliary ganglion. Remaining 80% bypasses. They go to another ganglion called accessory ganglion of Axenfeld. They are unsclera. Don't follow, that's why, never forget. Ciliary ganglion problem is there. Light 100% gone. People will not react for direct. Light reflex cannot work, whereas accommodation can work. Like this, light ray dissociation. Understand now? Classical example what? AIDS people, hello, AIDS people. You have heard about AIDS people?
Yes, sir.
AIDS, what is that? It's a denervation, partial involvement of ciliary ganglion and short ciliary nerves, postganglion fibers. That's all AIDS, viral infections. Anaga,
Yes, sir.
are you able to follow me?
Yes, sir.
That means light ray dissociation, short notes if it comes. You write now dorsal midbrain syndromes. You write about Argyle Robertson people. You write about ciliary ganglion problem also. Are you able to follow? No.
Sir.
Very good. Now, some anatomy, of course, I don't. Can you tolerate anatomy and all? Anatomy. Can I ask you questions? Hey, for fun. Hey, for fun, like, because these are some of the things they can project in the slides in your OSCE. Now, I will ask you a question. Deep optic artery,
Deep optic artery.
supplies which part of the optic nerve? Deep optic artery supplies which part of the optic nerve? Deeper part or superficial part or middle part? Deep optic artery. Sumaida solla, something you tell so that I'll be happy.
Superficial.
Superficial part. Anaga?
Superficial part.
Deep optic artery supplies which part of the optic nerve? Deep.
Superficial.
நாலு கத்துக்கத்தினு வச்சுக்கேன் automatically you will change the answer. Superficial will come. You will tell what? Deep you will first answer. Then later on come to superficial. Middle you will tell. I've seen students change their answers, kept on shouting. They keep on changing the answers. Now the question is what? You have inference I have got. KP, Anaga, you are all not studied about the blood supply visual pathway. Nobody has read visual pathway, blood supply. No excuse, KP. No excuse. Because you are an ophthalmologist, man. It's a full question for you. Blood supply visual pathway is a full question. You have to draw the pictures. You know one thing I'll tell you? Can you see this artery? Hello, this artery therida. This artery is coming from middle cerebral. That is called deep optic artery. Understand now? Hey, it's not concerned with optic nerve at all. It's optic radiation. Can you see the radiation supplying? You to follow? Now I will ask you a question, one more question. Of course, don't get confused. Anterior choroidal artery supplies which part of the optic nerve? Choroid, anterior part or posterior part? Anterior choroidal artery supplies which part of the choroid? There are choroid 5 layers parts. Inside chorial capillary, Brooks membrane, chorial capillary, medium sized vessels, large vessels, lamina fusca. There are 5 layers.
Yes, sir.
Now you tell me, anterior choroidal artery supplies which part of the choroid? Tell some answer.
Posterior.
Posterior. Come on.
Posterior.
You tell something nonsense, ra? Hey, you know one thing? You are going to learn by committing mistakes. You know one thing? After some, suppose same question comes in examination, that time you will remember, hey, one fellow came from somewhere, I do not know, but that fellow asked me this question, I answered like this, you will remember like this. Hey, still I remember, man, when I was in first year MBBS and all 70s. English professor asked me some questions, I blabbered something, and the class was laughing with the answer I gave. Because I just went to middle college, from Tamil medium. So English was shaking. Hello. Are you follow?
Yes, sir.
Now I am telling you. Answer. Anterior choroidal artery supplies which part of the choroid? Question. You will tell. Suma, anterior posterior, you tell.
Posterior.
Very good. This answer. Please remember. This is anteroportical. This is anterior choroidal artery. It's a branch from internal carotid artery. Hey, that supplies your tract. Optic tract. Hello. Anterior choroidal artery supplies optic tract. And of course, it comes and supplies with LGB. The peripheral fiber circle, after crossing in all, it tell upper peripheral, lower peripheral. You classify this in the anatomy. Upper temporal, upper nasal, opposite side. Lower temporal, lower nasal, they call peripheral fibers. This antecoat artery supplies the peripheral fibers in LGB. Macula fiber circle, they will have separate blood supply from posterior cerebral. Hello. Hello. Even a antecoat artery supplies anterior part. So thank you, get out, sir. Thank you. We will meet again after 100 years, sir. I'll tell what? We will meet again after 100 years. You are able to follow me. These antecoat artery, man, this supplies, classical question now, this accompanies optic tract all along. Then supplies tract and LGB also. Some radiation also you can see. This radiation also, can you see the radiation also? This radiation also, this supplies. Here LGB area, here is a tract area. That is why, KP, short notes. This artery is called as satellite artery of the optic tract. Satellite artery. It goes along, all along with her. Anaga, understood?
Yes, sir. Yes, sir.
It's called as satellite artery of the optic tract. Are you to follow?
Yes, sir.
KP?
Yes, sir.
Are you okay?
Yes, sir.
I don't take it seriously. For fun only I'm shouting because I know. I have to talk with someone, otherwise you'll become mad. Hello? I can't ask Divya because Divya became big shot. Divya, our student recently about 15 years back. Hello? Recently about 15 years back. She was roaming around Coimbatore. Hello. Come on, Dr. KP. Can you come to a conclusion, something problem in association with this fly in the eye? Immediately you must tell trachoma. That's all. Trachoma, hello. Classically transmitted by flies only, you know that. You will ask questions where in trachoma, that's all. We will ask questions in trachoma, we will take you. Or do you follow? Trachoma completely eradicated in India, so it has come less than 0.5% now. By 2017, they were reported. You don't know. Trachoma free India. You don't know. Hey, you are, what that 2020 program? You don't know.
Yes, sir.
2020 program.
Vision 20.
Trachoma has been supposed to be eradicated from India, published in 2017, announced by government. Now the questions will go on trachoma, understand now? Chlamydia, trachomatis, so many things come. What is follicle? You know definitions and all. Follicles, papilla, pannus. Pannus, you know?
Yes, sir.
Define pannus.
Vascularization plus infiltration. That is pannus. It is progressive and regressive.
Definition, only pannus. This exam will ask you. Your answer, superficial. And the that word should come. Vascularization of cornea, along with infiltration of inflammatory cells. Progressive, more cells. Regressive, less cells, that's all. Understand now? Now you will ask one question. Pannus can occur so many conditions, man. Please remember. Not only trachoma. But you will ask only question. Let me see. Pannus, trachoma. Pannus, tuberculosis. Difference. Difference. You know, you will not know. I will ask one question. Pannus, trachoma. Pannus, leprosy. Can you tell me the difference? Anaga?
No, sir.
Out. Pannus, trachoma, bilateral, superior aspect. Pannus, tuberculosis, unilateral, inferior aspect. Pannus, leprosy, can be bilateral but usually temporal aspect. These are classical questions. Exams. Hello? Anaga?
Yes, sir.
Pannus, trachoma, superior. That's all you are supposed to know. You have understood?
Yes, sir.
Hey, KP, what is bullet therapy? Bullet. Bullet therapy for trachoma, bullet. Hey, Ganda. Tsh. KP gone. Single shot like KP is out. இதான் கன் நினச்சிக்கோ. டங் கேபி ஃபட் அவுட். Now tell me what is bullet therapy or trachoma?
1% tetracycline.
Tetracycline you are all in the 1940s ல இருக்கு.
Azithromycin.
Huh?
Azithromycin.
சொல்லு கரெக்டா. Azithromycin
1% iron.
1%. அது என்ன 1%? டை 20 mg per kg body weight given orally. நீ 1% சொன்ன நீ ஹலோ ஃபார் ஐயா ஆயின்மெண்டா? சரி ஒரு क्वेश्चन இப்போ நீ only got in the exams. What do you mean by 1%? 1% சொன்னல. What do you mean by 1%? Tell me now. Hey, 1% she is answering. Now you timolol 0.5%, 0.25. அப்போ atropine 1%, home atropine 2% சொல்றல. What do you mean by that? Chapter close. அனகா இந்த 1% என்ன அர்த்தம்? What's the meaning? டேய் 1 gram in 100 ml சொல்லு.
1 gram in 100 ml.
அதான் 1%. 1 gram how many milligrams? 1000 milligrams. அப்பனா 100 ml 1000 milligrams. 1 ml எவ்வளவு இருக்கும்? How much? 100 க்கு 1000 டா. 1 க்கு எவ்வளவு? 1000 by 100 எவ்வளவு? 10. So very easy. 1% multiply by 10. So milligram per ml. Finished. 2% 20 milligram per ml. No need to think in the exams. 0.5 hey 5 milligram per ml. Multiply by 10 and that's all per ml. But actually it's what gram per 100 ml I told you. But you convert in terms of milligram is easier for us. Hello. 2% and what do you mean by that? Answer tuck. 2%. 3%. 20%. எங்க வரும் 20%? Where you get? Man it all. Die. Man it all. 20% they will ask questions. Oh 20%. Oh what is how many milligram per ml will ask you. Exam time you will forget your name also. Please have anxiety. You will forget your name also. I will ask KP what's your answer? My name is Anagano. She will tell. KP understood? Krishna Priya Purita.
Yes sir.
Either port will take it to trachoma if you want. It's only leading slide. With a tick, heart tick, spirochetes, borrelia, Lyme disease, so tick, we have to correlate these 3 slides. Example, if you are projected, this is heart tick, sir, this is something, spirochetes, sir, spirochetes, heart tick, Ixodes, tick name is Ixodes, transmits borrelia burgdorferi, Lyme disease. If now question will go in Lyme disease. We will take it in neuroretinitis and all. It's the way we ask questions. Hello, correlation and then take you to the exams, that's all. It's not difficult. Anaga, don't get frightened. Okay? In the Ixodes name, you have to remember all these names. Ixodes and all. Hello? Now the great question, hello. Hey, everyone knows vitamin A, vitamin A, we are talking, you know. Vitamin deficiency, night blindness, what's the normal level of vitamin A in the blood? Chapter close. Anaga, the blood sugar, you are telling so many milligrams, something you are telling? You are telling, no. Urea, like that you are telling them. What about the vitamin level? Because you are an ophthalmologist. No, come on. If you tell correctly, I will give 1 crore rupees. Of course, I don't have that, but still I can vouch. Hello. The reason is what you will not tell, that's all. Vitamin and normal, if you tell, I will tell Divya to donate you at least 1,000 rupees. Divya, 1,000 rupees could have. If you tell correctly. Hey, you know only told, no, Divya? You only told me, no, morning. That the adapter and all. Divya vandirga. Yes, KP. Normal of 50 to 200 micrograms.
50 to 200 micrograms. Per?
என்ன சொல்லுவ? ml லிட்டரா என்ன சொல்லுவ? டெசிலிட்டர் சொல்லு. டெசிலிட்டர் 100 ml. Hey, 50 to 200 micrograms per Deciliter. Anaga, exam question. We'll ask you a question. Imagination. Hey, you know, we got this fellow, vitamin deficiency fellow can have dry conjunctiva, you know that? Cirrhosis, cornea cirrhosis, keratomalacia, night blindness, all these things, you know that. Problems can occur with the night blindness, you know that. But rhodopsin cycle, can you tell now? Example, hey, without knowing rhodopsin cycle, don't enter exam hall. Rhodopsin cycle, if you are not knowing, don't enter exam hall. If you want to know, you can go and peep. You tell the examiner, hi, everybody told you must come out. Rhodopsin cycle, don't enter. Don't follow. No. You are puri there. Now question is what? I'll give a clue. Now you are sitting in outpatient department. There are about 10-15 small girls.
Small girls, 10
from village side. In India. 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 They come to you. You are examining all the Yella conjunctiva, they have got black deposits. Black deposits. What's the answer? Girls. Speak this importance. Girls in India. Village girls in India. Black deposits throughout the conjunctiva. What do you suspect? With a solitina, hello. I donate my house. Hey, Divya, I give it your skin, no? My house. Are you a donator? Your answer is, sir, black deposits in the conjunctiva, maybe because of the mashi, kanmasi, mashi dana. Wanga Malayalathala, mashi dana. Kanmashi. Kajal da. Kajal, normally wet conjunctiva to get washed out. Now if it is dry conjunctiva, they get adhered. It cannot be washed out. But dry conjunctiva, vitamin deficiency, understand now? When you see kajal deposit conjunctiva of a small girl, that too in India, be careful, it can be a case of vitamin deficiency. You have to give treatment. Who told this? Of course, this you do not know. For the fun guy, I will ask you, who told this sign, man? Whose sign is this? No. Don't worry, I don't expect this type of questions. Hello, nobody will penalize you if you're not knowing. But at least know. See now, you say, of course, this is my diagram, hello. Because it's a bite out spot, I make some diagram, something like this. Painting like. Imtiaz sign, sir.
Imtiaz sign.
If you call me in examination, I will come there. Come on, doctor. KP, what is Imtiaz sign? Sir, black deposit conjunctiva and vitamin deficiency. Other examiner, what will happen to him? He will fall. He will fall and he will run away from that area. He will never be seen in that area for another 10 years. That examiner will not come there. Yeah, KP they will tell, KP is there, sir, she is answering so much, they will tell, Anaga is there. What to follow Anaga?
Yes, sir.
This is Imtiaz sign.
Imtiaz sign.
Imtiaz, original Indian, now Pakistani.
Imtiaz.
Before partition, he was in India. Now he went to Pakistan. That's why he's not a Pakistani. Understand now? Now, dry spots are there in conjunctiva. I told you, bite out spots and all. The same spots, dry spots, can be seen in the retina also. That fundus ka naam kya hai?
Xerophthalmic fundus.
Xerophthalmic fundus. That fellow will tell. Hey, who is distributing food and all? No, that fellow will tell. Xerophthalmic, you know dryness. Xerophthalmic fundus. That fellow will tell. You are what? MS final year PG. So, what's the name of the fundus? Anaga. Name of the fundus is vitamin deficiency. Anaga. Compare na suna? Brinda. Compare. Anju. Come on, Anju. Hey, ni varaya o per solle. Kubula. One friend is absolutely. Edi pude. Paravala. Blue unga friend ah. Blue. Hey, blue. Ungala sonna. ஃப்ரெண்டா உங்கள் ஃப்ரெண்டா பேர் என்ன? ஐஷ். அதான் ஐஷ். Come on, Aish. What's the name given for the fundus? I have not heard. Hey, these are short notes, ra. These are all called as short notes. One more chance, last chance. Hey, Uimura, sole. KB style up, I say, Uimura, sole.
Uimura.
நான் ஷார்ட் நோட்ஸ் கேட்குறேன்டா. உய்முரா ஃபண்டஸ் 2 மார்க் 2 மார்க்ஸ். அன்லஸ் யூ நோ இட்ஸ் விட்டமின் டெஃபிஷியன்சி யூ வில் நோ தட் 2 மார்க்ஸ் கான். ஹலோ, அதே மாதிரி சேட்டலைட் ஆர்டரி ஆப்டிக் ட்ராக்ட் ஒன் கொஸ்டின் இஃப் யூ நாட் நோயிங் ஆன்டிகோடால் யூ வில் ஃபினிஷ்ட். ஹலோ, எக்ஸாமில் க்ளூ கொடுப்பேன். உயிரே சொல்லு. அம்மா உயிரேனா உயிரோன யூ நோ சோல். அம்மா உயிரேனா தட் மீன்ஸ் வாட்? உய்முரா. You understood, KP? No.
Yes, sir.
இதெல்லாம் of course, you know, angular conjunctivitis and all. Suppose this slide is shown. Hello. This slide is shown. You will tell what? Gram positive or negative? Gram?
Gram positive.
Positive. Dai. இப்போ எக்ஸாம்பிள் ஞாபகம் வச்சு ஒரு ஃபன்னுக்காக கேட்பேன். கமெண்ட் டெல் மீ ஹவு டு டு கிராம் ஸ்டெயினிங் கேட்பேன் எக்ஸாமில். அதோட சாப்டர் க்ளோஸ் ஆகிடும். ஹலோ, கமான் ஹவு டு டு கிராம் ஸ்டெயினிங், சாப்டர் க்ளோஸா? கடைசியில் வந்து கார்பால் ஃபியூஷன் போடுவாங்க. யூனோ கார்பால் ஃபியூஷன்? ஐ ஹர்ட் அபவுட் டைலூட் கார்பால் ஃபியூஷன் அண்ட் ஆல்.
Yes, sir.
கார்பால் ஃபியூஷன் ஸ்டெயின் தான் வரப்போகுது. இந்த கலர் கிராம் நெகட்டிவ்ஸ். இட்ஸ் எ கவுண்டர் ஸ்டெயின். Gram negative rod bacilli arranged end to end. Arranged end to end. See now here. Hey, one rod. Can you see arranged end to end? Arranged end to end. Classical question is what? You see the picture other side. It has produced what? Angular conjunctivitis. Angular conjunctivitis. Hello, this is also a basic bacteriology. Angular conjunctivitis produced by?
Moraxella.
Moraxella lacunata. சொல்லு. Morax axonfil bacillus. அதானே? Moraxella தான். lacunata கிடையாதா? Morax axonfil bacillus. Full sentence. You understood? Sure. It can produce what problem with the cornea? Corneal you keratitis சொல்லுவாங்க. What even? Keratitis that is fetus can produce what? Classically, usually they may produce peripheral ulcerations. Peripheral corneal ulcerations. Hello, KP, can you tell me now the causes for peripheral corneal ulcerations?
Systemic causes. Systemic cause.
Systemic gota.
Systemic causes, local causes.
ஏதோ சொல்லு. Causes, some name.
Systemic causes like rheumatoid arthritis. SLE.
You know how to remember? You know how to remember? Any word ends with N. சொல்லு.
Any word
ends with சொல்லு. In. நான் சொல்றேன் பாரு. Flicton சொல்லு. Flicton keratitis, they can have peripheral ulcerations. Flicton சொல்லு. மூரன் சொல்லு. டெரியன் சொல்லு. டெரியன் இதுதானே? டெரியன் சொல்லு. அப்புறம் யூ டோல் ரோமாட்டாய்டு சொன்னேன்ல, கொலாஜன் சொல்லு. அதுவும் இன்னும் தானே? ஹலோ, இன்னும் அண்டர்ஸ்டாண்டா? டெல்லன் சொல்லு. டெல்லன். ஹவ் ஹர்ட் அபவுட் டெல்லன்?
எஸ் சார்.
டெல்லன், மூரன், டெரியன், ஃபிளிக்டன். ஹலோ, in you tell in the exams. At least you can remember things, something better, man. 2 more things is there, but there is no in. சொல்லு. 2 more things are there, there is no in. அது என்ன 2? But if you want, you can add a in there. There also you can add a in for completion sake. Staphylococcus இருக்குல்ல, you remember staphylococcus சொல்லு. What is that? Hey, staphylococcus. ஹலோ, பெலுசிட் இருக்குல்ல, பெலுசிட், பெலுசிடன் சொல்லு. எக்ஸாமில் போய் லூஸ் மாதிரி பேச கேபி டோன்ட் டெல் எக்ஸாமில் போயிட்டு பெலுசிட் அண்ட் புலிசிட் அண்ட் டோன்ட் டெல் ஜஸ்ட் டெல் பெலுசிட் ஸ்டெஃபிலோகோக்கை மூரன் ஃப்ளிக்டன் டெரியன் லதடிக் ரோம்பர் அண்டர்ஸ்டாண்ட் நவ் எக்ஸாமில் வந்துட்டு யூ cannot remember because you will forget everything I told you. Something you have to have remember Sambi. இது என்னது ultrasonogram picture. I can see a hyperechoic ஒரு ரவுண்டாக இருக்குது. Inside also you can have a round hyperechoic area. Okay, now you see the tapeworm, see the something, we can have a cyst-like thing is floating in the vitreous with the squalex, the darker, the whiter இருக்குல்ல அது squalex cyst. அப்புறம் என்ன அர்த்தம்? வடிச்சிட்றா? I have seen shown the worm also. Toxic, die. டாக்ஸிக் யாராவா? அம்மா இதெல்லாம் டேப் போம்டா அம்மா தாயே. அனகா இது என்ன டேப்போம்? யூ ஈட் போர்க்கு பிக்கு யூ கெட் வாட்? நியூரோசிஸ்டிக்கா? நேம் ஆஃப் த பேர்ம் என்னடா? டேப் பேர்முக்கு என்ன பேரு? டீனியா சோலியமா சஜினேட்டாவா? சோலியம் அதிகம் திங்க் பண்ணுறேன். ஹலோ யூ மஸ்ட் டெல் டீனியா சோலியம். சஜினேட்டா அந்த பீஃப், டீனியா சோலியம் இஸ் அ பிக். புரியுதா? நவ் யூ நோ த லைஃப் சைக்கிள் ஆஃப் டீனியா சோலியம். எக்ஸாம் கொஸ்டின் இப்போ எக்ஸாமில் வந்திருக்கு. இப்போ ஓரல் கோயிங் ஆன். இப்போ எக்ஸாமில் சார் சிட்டிங் கம் ஆன் டாக்டர் கேபி கேன் யூ டெல் மீ சம்திங் அபவுட் த லைஃப் சைக்கிள் ஆஃப் டீனியா சோலியம் அப்படின்னு ஸ்டைலாக வேறு கேட்போம் இங்கிலீஷில். திவ்யா இங்கிலீஷ் பற்றியா இம்ப்ரூவிங்? கம் ஆன் டாக்டர் கேபி சொல்லு. Can you tell me the life cycle of the bloody senior soli அப்படினு சொல்லு. இந்த சொல்லிடே உனக்கு இப்போ இந்த ஹாஸ்பிட்டலில் கொடுத்துரு, இந்த இது பில்டிங்கே கொடுத்துரு, ஐ டொனேட் யூ. ஹலோ கமாண்டா தெரியாதா? டீனியர் சோலியம் லைஃப் சைக்கிள் அனகா தெரியுமா தெரியாதா?
No sir.
No, MBBS but studied no?
Yes sir.
அப்போ MBBSல parasitology you studied no? See now exam is same slide given to you. You are telling now cysticercosis, tinea solium சொல்ற. Come on doctor, tell me the life cycle. Chapter close. On the same way you can't say no. I know you will tell what. Suppose I ask a question, what about the intralace? What about the femtosecond lasers? அதெல்லாம் பரபரன்னு you will tell. You will tell what? Sir, femtosecond lasers sir, 1050 nanometers infrared sir, you answer. Hello. புரியுதா இல்லையா? ஃபேக்கிக் ஐஓஎல் சார், ஃபார்முலா யூ நோ சார் அப்படின்னு வில் டெல். வி டோன்ட் பாதர் அபவுட் ஆல் தோஸ் திங்ஸ் இன் த எக்ஸாம்ஸ். பேசிக்ஸ் யூ ஆர் சப்போஸ் டு நோ. டீனியா சோலியம் சரி, போர்க்குடா, போர்க்கு மேன், யூ நோ த சைக்கிள். நவ் யூ டெல் மீ ஹூ இஸ் த டெஃபினட்டிவ் ஹோஸ்ட், ஹூ இஸ் த இன்டர்மீடியட் ஹோஸ்ட்? போர்க்கா, மேனா, இன்டர்மீடியட் ஹோஸ்டா, பர்மனன்ட் ஹோஸ்டா? சும்மா இதான் சொல்ல உனக்கு இந்த எக்ஸ்பெக்ட் பண்ணல. திஸ் டைப் ஆஃப் கொஸ்டின்ஸ் ஆர் நாட் எக்ஸ்பெக்டிங். ஐஸ்வர்யா இஸ் கோயிங் டு ஆன்சர் நவ். சி ஐஸ்வர்யா இஸ் வெயிட்டிங். ஐஷ் கம் ஆன்.
Definitive host is pig.
Pig, very good.
Intermediate host may be humans.
பத்தியா உன் கிளாஸ்மேட்டா? ஷீ இஸ் கிரேட்ரா ஐஸ்வர்யா. வெரி போல்டு கேர்ள். ஷீ இஸ் டெல்லிங் சம்திங் யூ நோ. அக்செப்டா? She's good, no?
Yes, sir.
Kinga? She's the king. King of ophthalmology. Microbiology. எல்லாத்தையும் king. ஐஸ்வர்யா அவ கொடுத்து அவகிட்ட பாவம் வாங்கிக்கோ என்ன? she wants to avoid. ஐஸ்வர்யா நான் சொல்கிறேன் பாரு, ஒரு கொஸ்டின் பாரு. இப்போ பாரு, இப்போ ஐஸ்வர்யா என்ன பாரு, இப்போ எனக்கு வந்து adult worm is there, my intestine. I pass the eggs in the stools. Pig இருக்குல்ல, pig comes and eats the stools. Eggs enter in the stomach of the pig. Pig enter the stomach and again it goes to larva. Larva is from the muscles of the pig. You eat the improperly cooked meat of the pig, the larva enters your stomach, adult will be coming in your intestine. Who is adult? You can have sexual cycle and all. Who is permanent now? I'm having adult worm. Who is permanent? Definitive. Hey, adult worm is not definitive. The poor pig larva, that fellow is intermediate. Never forget this. Hello? You have understood? Understood? Namadanda permanent. We are permanent for what? Hello? Definitely for your teenage solium. Pig is what? Poor pig is what for? KP. Poor pig is what for? Intermediate. Now this is what? Sisycercus is a larva. Sisycercus larva is supposed to be normally found in where? In pig. But how it is in your eye? Hey, Aishwarya, I'm asking you, how that bloody fellow Sisycercus, which is supposed to be in the pig muscle, has come to your eye? Hey, she's telling, you go and rub the pig with the eye. Hello. She's telling, sir, I'll go and rub the pig with the side, sir. It enters suddenly. Like that, no? And then now, very simple. Episode studied. I'm having adult worm. The eggs are containing segments called proglottids. When you vomit, reverse peristalsis, the segments having that eggs, they come to my stomach, getting digested. Eggs are liberated, go to my various areas, portal circulation, larva is formed. Hello? This is reverse peristalsis. Reverse peristalsis. You have not heard? Hey, எனக்கு இப்போ லார்வா இருக்கு. அனகா எனக்கு கொஸ்டின் கேளு. பிக் சாப்பிட்டேன்னு கேளு. Just ask me, did you take pig கேளு. சும்மா ask me da. I will give answer. I am having larva in my eye. Sisycercus. You ask me question, did you take pig? You ask me, I will give answer. சும்மா கேளு.
Did you take pig?
Pig? What is pig? I do not know. I have not seen. I am a pure vegetarian. I have not seen pig at all in my lifetime. I am getting how?
Vegetable salads. Raw vegetable salads.
Vegetable?
Salads.
From where? Vegetable salad. Now they will take the stool and give. Hello. Hey, it's a very simple thing. Eggs are in the stools, Ground foods. We are having carrot, beetroot, all nonsense. Hey, for example, imagine, hey, Pepe, you go to 5-star hotel. Get me salad. Salad. Salad, ground land, without washing, cut one. You give it to you. The eggs are entering your stomach. You are a vegetarian. Eggs are there. Larva can form. That means what? Pure vegetarian can have larva. But adult worm can only be seen in a person who has consumed pig. Adult worm in I would have consumed pig. Sisycercus is in larva. I would have consumed. No, I am a vegetarian. Take home message. Take home message. Never take salads from 5-star hotels. Hello. Never take salads from 5-star hotel. Take home message. If you want to eat salad, you purchase yourself clean. If you want, you can put in Dettol and keep it. Dettol about wash maximum you can have diarrhea. That's all. You will have diarrhea only. What do you follow? Sisycercus varadalalo, neurosisycercus and fish it's all nonsense will come to me, no? But diarrhea, nothing will happen to me. Anaga, whenever you get the carrot, Dettol about you. She's telling, hey, don't do that. Hello. You have understood?
Yes, sir.
No.
Yes, sir.
If a question in the vitreous cyst. Now come on, KP, exam goer. What drug I am supposed to prescribe to the patient? What's the dose? Hello? Dose, Sisycercus dose? What drug? I give a clue. Albendazole. Thiabendazole. Azoles. Let us know you got albendazole. What's the dose? Anaga?
400 milligram per kilo. 400 milligram.
என்ன சொன்ன?
Albendazole dose.
Albendazole?
Dose.
How many milligram? How many milligram per day for how many days you are supposed to give in a case of cyst in the vitreous? Kadasila, we have to go to Aishwarya only, no other go. Aish, come on. KP, my friend Andra, she has become very bad. Your answer is, your answer, sir, better to avoid drugs in vitreous cyst. I have to do vitrectomy and removal of cyst in toto. Because once you give drug, the worm dies, it will produce severe inflammations. The end of the story. So, end of 12 minutes will come on, hello. That's why better to avoid drugs. Best option is what? Surgical treatment. Understand now? Hello, KP. This was the reason I will ask you questions, whether you know or not. Leukocoria, so there is a leukocoria. Hello. Convergent squint is there. You can see proptosis like thing. You can see something, you have hyphema, hypopia, and all these things. These are all what? Never forget. Suppose a case is given to you in the exams. A case of ophthalmos is there. Glaucoma case. Suppose you are asking exams, what's your diagnosis? Sir, apart from primary glaucoma, I would like to rule out retinoblastoma. And you tell. In a retinoblastoma, in the child before 2 years of age, they can have IOP can increase. They can enlarge the globe. Ophthalmos can occur even in child. That's why the most important diagnosis to be ruled out in a child is for retinoblastoma in a case of ophthalmos. Hello, KP, is the exam question. We will ask you. Glaucoma, there is different. Please remember, retinoblastoma, they will take a vertical route. If you are not reading, you don't know. These are one of the masquerades. Have you heard about masquerades? Masquerade syndromes manifesting as something, but underlying pathology is different. In the hypopia and hyphema, okay? But actually, it's what now inside? Retinoblastoma. The proptosis is there. It's marks. Actual problem is what? Retinoblastomas. How to follow?
Yes, sir.
These are masquerades, masking the underlying pathology. You have understood now? Hello? Retinoblastoma gene in the chromosome. 13? 13 na? Short arm, long arm?
Short arm.
Short arm. You'll be happy. It's a long arm. Please remember. You have to tell wrong answer, I will be happy. Correct, Divya? Now I expected long arm, I would have got gastritis. Hello, KP. The correct answer, I will get gastritis if you tell. If you are giving wrong answer, you will be happy. As if I have given and today they gave us a payasam or something. And the payasam could chamay if you tell a wrong answer. You don't know. Hello? Purida liya? Najama? Sure. These are all masquerade syndromes. Okay? It's a 13q14. So 13q, na long arm, 14 location. It's a normal gene that is present in all of us. If you delete it or inactivate, the problem starts for the fellow. If you delete it or inactivate it. Now, if you tell this question, next we will ask you a question. Hello. Next. Can you tell me one more condition that is associated with this chromosome in a childhood area? One more condition in children that may also produce glaucoma in a patient. With this associated with the chromosome, this chromosome, which can be a bilateral problem. 13q14 location. Hello. Rieger syndrome. Rieger. Hey, you heard, no? Mesodermal dysgenesis. Or neural crest anomalies. Neural crest anomalies, have you heard or not? Neural crest, hello? KP? Neural crest anomalies, have you heard? Huh? Rieger, Peter, hello? Axenfeld? Well, you must suppose you know. Now what is this? Hello? Can you see now here? Can you see this rosette? Rosette? Rosettes, true rosettes.
True rosette.
What is that? Retinoblastoma tumor cells are primitive cells of rods and cones. Primitive. Normally they have to develop means become normal rod and cone. Instead, due to some genetic influence, they are getting converted to tumor cells. But then these are all primitive rods and cones photoreceptors. You have understood? Hey, these are all primitive cells of rods and cones. And they are going to arrange under empty lumens. Empty lumen. Or lumen. That's all generally it's lumen. L-U-M-E-N. Lumen. That is called true rosettes. Around a blood vessel, KP, around a blood vessel is called two pseudo rosettes. Everyone knows. Anaga, lumen is empty. It's called as true. Lumen nalle true rosette. Lumen is empty lumen. Something is there in the lumen. Now the reference. If the lumen is empty, it's called flexure intestina. Something is there in the lumen, it is all home or right. Just know this. Okay? Hey, true rosette, they will ask you in exams. Flexure intestina, home or right, they will ask you in exams. Then pseudo rosette, they will ask you. Hello? But this cell, when you see no tumor cells, you cannot say it's rods and cones. You cannot tell it's rods and cones. These are all primitive cells. Some slides you can see, hey, and the tumor cells you can see, hey, this might have been rods and cones. You can easily come to a conclusion because they are elongated cells. Normally, retinoplasma is small cell. It's an elongated cell. What is that called? Almost differentiated. That means you can tell, yes, this tumor cell belongs to rods and cones. That is called what? Not studied. Fluoret. Fluoret, hello. Hey, retinoblastoma, if you are not knowing, hello, KP, don't enter exam hall again. Hey, somewhere they will ask you, because that's the only tumor I got, mostly. We have to ask this question only, no other go. I don't follow. Purila.
Sir.
Now, I told in the fun guy, where a question, let me see. Of course, because you don't know, you have understood now, you have not studied about retinoblastoma. We will ask some more questions there only. Understand now? You know why? I told you lumen empty and all. Agreed. Rosettes. True rosettes. Can you tell me some other tumor inside the eye which will also show rosettes? Tumor. No. I'll tell you a simple thing to remember. Hey, retina development, outer layer of optic cup, inner layer of cup. You know that? Hey, inner layer produces sensory retina, man. Outer layer forms a pigment epithelium. You know that? You now come forward, trace it. It comes to me ciliary body epithelium. Hey, inner layer also forms pigment epithelium of ciliary body. Pigment epithelium also, outer layer of pigment epithelium. Ciliary body has got two epitheliums. One is pigmented, one is not pigmented. A tuber coming ciliary body epithelium can produce rosettes. I think parent, hello, KP, short notes. What's the name given for the tumor of the ciliary body? Dictyoma, tell me. D-I-K-T-Y-O-M-A, hello, T-Y-O-M-A, dictyoma. Not studied, hello. Anaga. Dictyoma, short notes. Otherwise called medulloepithelioma. Tell me, otherwise called as medulloepitheliomas. Hello, Anaga. These are short notes. They will ask you questions. If I set a paper, my first question will be this. Idea is what? Nobody should answer. Idea is what? Nobody should answer. KP. Dictyoma. Tell me, dictyoma can have rosettes. Hello. KP, now you tell me the conditions which have rosettes. So far I told what conditions they can have rosettes. Retinoblastoma. Medulloepithelioma. What else? Next question. I told you, Noor Darab, I have told you. You know Noor? Malayalam Noor means 100, no? 100, no? Noor. So 100 times I have told you. Now tell the answer. Don't know, it's a clue. Noori disease, hello. I heard about Noori's disease. Noori's. It's a DD for leukocoria, hello. Noori, N-O-O-R-A-E. Hey, Noori, it's a retinal dysplasia. Hello, Noori. Hey, conditions having row set, at least 1 or 2 conditions supposed in the exams. You want to say Arya Dana? You remember na? Anju. You are studying? What? MS? Which year? First year.
Nice.
Wow. Okay. Hello. Next question, funny exam questions. Doctor, you have seen lumen? You have seen lumen, no? Hello. Hey, I told lumen, no? Hello. See lumen, classical lumens? Hello. Terida, lumens.
Yes, sir. Yes, sir.
This lumen represents what in your eye? Which area is represented by this lumen? If you tell this, I will give my entire property for my. So far, I have earned so many things. I will donate you. This lumen represents what? You see now so many questions. Suppose by chance I come as examiner. Understand now? If the questions will come now, you get confused. What to follow? Anju, be careful. Hey, this lumen, rods and cones, what is the normal layer? Is there pigment epithelium? In between, what is that? Subretinal space. This lumen represents subretinal space. Hello, this lumen represents subretinal space. Hello. See, there are no funny exam questions. You may would have read so many things, but we will ask you only basics. Understand now? See now, here, tumor is there. Can you see a tumor? Right side, melanoma choroid. See now, Nietzsche, you can see now A scan. Can you see this A scan picture? Okay. Now you see the A scan picture here. Can you see this bottom arrow and all? See now, in scan, what happens now? Ultrasound, no? Ultrasonography. Melanoma choroid, the first hit gets reflected. Now inside, there is no hindrance. Only short, very small reflections. Then as you go to posterior wall, it goes up again reflected. That means what? You see now here, one top here, one high wave, and then here, one more high wave. That means what? In between small reflection, see this? That is why we can call it as melanoma choroid, acoustically hollow. Nothing is there inside as if. You have understood? Acoustically hollow structure. Hello? Understood? Acoustically hollow. That's why now, you see now 2 lines. See now, I have written the first wave in the horizontal line. The remaining waves are connected with another line. Can you see this? So an angle is created. This is angle kappa. It's called angle kappa. You have understood? Angle kappa in the first wave, you say A scan, you join a line. Remaining waves connect. An angle is created between them. That is what? You see retinoblastoma here. Retinoblastoma, you see now here. First wave goes here. The remaining waves are going on, coming down like this. Keeps on. There is no small reflections. So you can have higher reflections also in between. You know why? Calcifications. Retinoblastoma can have calcification inside. The wave comes on the calcification, they get reflected again. Necrotic area, they go inside easily. That's why going up and coming down, it keeps on moving. It's not coming to the bottom line easily. Yeah, one of the what retinoblastoma man, hello. KP exam question. This going up and coming down, You know this? This scan, what's the name? What is the name given for the scan report of retinoblastoma A scan? Come on. You tell now, nothing will be given to you. You don't know. Going up, coming down, going up, coming down. Hey, going up, coming down. Going up, coming down. It looks like what? Hey, this is V coming down. Are they? Why? VY pattern. It's called VY pattern. Hey, A scan, picture, ultrasonogram, retinoblastoma, VY pattern. Hello? If you know this, that means what? Angle kappa is small. You know, all the things are getting reflected. No, I told you, the first wave will only draw a line, remaining is connect. Naturally, everything is getting reflected. Naturally, angle will be less. Angle kappa less retinoblastoma. Angle kappa more melanoma choroid. That's all. You have understood? What is this? Full of soul. Evisceration. This is evisceration. What is this? Enucleation. Hello, have you done or not? You have not done enucleation. No, even dead body. You have not gone for high donations and all.
No.
Anjan, have you gone?
Yes, sir.
Hey, this girl has gone. Okay, I'll tell you. This is called on the groove, like groove. That is to hold the optic nerve. Then only you can go down and cut it. This is a enucleation spoon or optic nerve guide. Optic nerve guide. Understand now? What's the name? What's the name given for this instrument? You talk something, da? Hey, you are talking from the bottom of a well, my pesara. You are talking from the bottom of a well. Hey, Malayalam like a well again. Canary Kadilan, you are talking from below the bottom of the canary. Anju, tell the answer. Name of the instrument is wells. That's why I told you canary. I told you well. Anju, no sir, I am not well. I am sitting down here only. I am not well. Anju, you have to read a lot. Hey, this is an exam question. I do not know whether you know or not. We will ask you, doctor, this child, affected child, unilateral, tell me, solitary, other eye normal, third eye normal, tell me, third eye normal, fourth eye also normal, which is third eye? Right, left, which is third eye? Third eye you don't know. Anaga, pineal body is supposed to be third eye. Fourth eye is what? Parachiasma. Hello, that means what? I am having a right eye tumor, left eye tumor is there bilateral. I can have a pineal body also along with that is called trilateral. Hey, quadrilateral. Hey, right eye, left eye, pineal body plus parachiasma is called quadrilateral retinoblastomas. You are not heard. Hello, Anju, Purilia. Now, one eye, right eye only, single tumor. No other tumor, nothing anywhere. It's unilateral solitary is non-hereditary. Non-hereditary pattern. Hey, a particle is coming along. KP, non-hereditary. Suppose one eye has got 10 tumors. There are 10 tumors in one eye, but never forget it's not a spread, it's a multicentric. One eye only 10 tumors, they are all different tumors. So retinoblastoma classical sentence, multicentric origin. 10 tumors are individual tumors, it's not a spread. When you have a unilateral multiple, it is hereditary. Hereditary pattern. That's all. Bilateral always hereditary. Trilateral always hereditary like this. Just know this. Unilateral solitary only non-hereditary. Unilateral, multiple, hereditary, bilateral, hereditary, trilateral, everything is other things are all hereditary patterns. That means what? They can transmit. Hello? Amma? Hereditary means, bilateral, hereditary. That means what's the idea now? This fellow, affected fellow, bilateral fellow, they can give problem to his children. If treated and is alive, he can transfer to his children. Now the question is what? What is the type of inheritance? Is that dominant? Tell me. Autosomal dominant? Tell me. Repeat, right? What? Next sentence in a complete point. You have to complete a sentence. Retinoblastoma is autosomal dominant with incomplete penetrance. You know the meaning? Hey, but dominant normally 50% chance. 50% அப்படியே போகும். Understand now? Whereas incomplete now is not 50. It's only 40% like this. Hey, retinoblastoma, KP, autosomal dominant with incomplete penetrance. In the affected child, affected child, bilateral hereditary pattern. Our children never have 45% chance. Our children 45% chance is there. Imagine now unilateral solitary, non-hereditary pattern is there. The child is affected non-hereditary pattern. That means what? Our generations, our son and daughters are all only 6% chance. Already they have calculated 6 or 8% only. A non-hereditary affected child will transmit only 6 or 8%. Hereditary pattern child can transmit 45%. Genetic counseling, just know this. But now a question here. Hello. Father normal, tell me. Mother normal. Father normal, mother normal. Child affected unilateral solitary. Child affected solitary. About non-hereditary patterns. Understand now? Now the father is asking you, can I have one more child? What's the percentage? I'm not dealing with the child affected child now. Father normal, mother normal. First child is what? Unilateral solitary, non-hereditary pattern. But next child, you never know. Chances. You have not studied that. It's only 1%. 1% chance. Hello. KP, exam like genetic counseling, let me see whether you study or not. In this case, father normal, mother normal. Child bilateral. About hereditary pattern, no? About father is asking, can I have one more child? In a percentage, a chance. Don't tell 45 because father is normal, mother is normal. Here is again only 6% or 8%. You know one thing, KP? Exam like genetic counseling at a sir, unilateral solitary, sir. Examiner should not understand what's happening there. The way you are going to tell, no. The examiner should not understand, sir. Father normal, sir. Mother normal, sir. Child, sir. Affected unilateral, sir. Next child, chance of 1%, sir. That's what you tell. Father normal, mother normal, sir. Child, bilateral, sir. Hereditary pattern, next child is what? 6%, sir. Affected child, unilateral, non-hereditary pattern, only 6% chance. Affected child, hereditary pattern, that follow 45%. Understand now? Hey, this is all Jujubi Nana. What's the meaning? Hey, what's the meaning of Jujubi? You don't know? Hey, Divya, Jujubi Nana. Huh? Jujubi. You don't know Jujubi? Hey, have you ever seen Rajinikanth movie and all? It's a Jujubi here. You used to tell that. It was very simple. Like a Jujubi here. You tell what? Jujubi. You don't know. You know the exact meaning of Jujubi, Divya? The exact meaning of Jujubi? It's a fruit. Fruit, roadside they sell 1 rupee those days. And so Jujubi is a fruit. And you go and see your net J-U-B in put fruits picture or it come. Publish it. Purida. Are you able to follow genetic counseling? Hereditary pattern 45% chance. Next child. That follows affected fellow. Hereditary pattern child. Father mother normal. Next our brother sisters only 6%. Purida. Affected person transmit now it's 45%. Are you follow? Particular. This is genetic counseling. Guess what's the drug? Come on, tell me. I will give my property again. This is not drug. This is yara. மரடனாவா a pretty girl சொல்ல pretty girl புரியுதா which drug so now what god dead hey something killing goddess மாதிரி இருக்கான் பார்த்தா hello that fellow is killing fellow which drug comes to your mind
Atropabelladona.
வா
Atropabelladona.
யாப்பா கிங் பத்தியா hey பாரு அனகா Atropabelladona tell me can I call you belladonna can I call you belladonna or not அனகா நீ சொல்லு உன்னை கூப்பிடலாமா பெலோடனான்னு can I call you belladonna or அட்ரப்பா சொல்லு பார்க்கலாம் can I call you அட்ரப்பா பெலோடனா எது கூப்பிடணும் அட்ரப்பா கூப்பிடலாமா பெலோடனா you can call you கேபி சுபாஷ் ஸ்ட்ரெஸ் ஏதாவது ஒன்று வளர்றா அட்ரப்பா நீ என்ன சொல்ற can I call you அட்ரப்பா பெலோடனா come on அனகா come on என்னடா யோசிக்கிற அட்ரப்பா பெலோடனாவா சொல்லு ஏதாவது ஒன்று சொல்லு ஜஸ்ட் டைம் சம்திங் அட்ரப்பா பெலோடனா அஞ்சு அட்ரப்பாவா பெலோடனா வேணாமா அதுவும் வேணுமா போத் ஹவ் கேன் யூ கெட் ஒன்லி ஒன் திங் ஒன்லி யூ கேன் கெட் இப்போ ஐஸ்வர்யா தான் ஃபைனல் சான்ஸ் ஐஸ்வர்யா யூ ஹேவ் டு பி கால்ட் அஸ் பெலடானா ஆர் அட்ரப்பா என்ன சொல்கிற அட்ரப்பா உட்காந்துக்கோ நான் சொல்கிறேன் மீனிங் பாரு பெலடோனானா பிரிட்டி கேர்ள் அட்ரப்பானா goddess cutting the life killing goddess புரியுதா அப்போ ஒன்லி ஒன் பெலோடனா ஹியர் இந்த கண்ணாடி இருக்குல்ல திஸ் கனடியன் ஷீ இஸ் அ பெலோடனா பெலோடனா பிரிட்டி கேர்ள் ஆர் பிரிட்டி கேர்ள் ஆர் பெட்டி லேடி தெரியாதா you know why atropine is called atropa atropana you know atropine side effects you know or not atropine you know 1% means how many milligrams I told you 10 milligram that is sufficient to kill a child 10 milligram is sufficient to kill a child that's a killing goddess hello 10 milligram I told you atropine 1% eye drops apna 1 ml will how many milligrams 1% how many milligram per ml 10 milligram so 1 ml you take eye drops you stop putting in the eye 1 2 3 16 drops only 1 ml 20 drops only 16th drop take off 18th drop hello further take off 20th out that's why never prescribe atropine eye drops to a child and that too give it to the mother she may not know the significance she will put one drop right just to come out only she will think what now the drop has not gone inside she will put one more drop it will also come keep on putting 18th drop chapter close they will tell what this bloody doctor gave me he will tell these eye drops gave and then my child expelled they will blame you there's better options what don't give if you want to apply atropine in a child you yourself put one drop there that's off don't prescribe the drops if you want you can prescribe ointment that's the important point understand now with the exam viva question man it's a viva question hello atropa toxic or a lethal dose or for something dose for the child to get die no can die only 10 milligrams suppose adult I want to kill it may be more than 100 milligrams that's different adult 10 milligram you will not hello can you tell me the side effects of atropabelladona amma atropabelladona side effects poetry mai sollu poem song mari sollu hello anaga theriyada blind as a bat sollu blind as a bat red as a beet mad as a hen mad as a hen mad as a hen theriyada dry as a bone சொன்னாலியா அப்புறம் blind as a bat சொல்லியாச்சா red as a beet சொல்லு red as a beetroot don't know hot as a hair சொல்லு hot as a hair HARE hair தெரியும்ல hair என்ன hair என்னடா மலையாளத்தில் பாரு hair, H-A-R-E. Hair தெரியாதா? Rabbit, right? You take rabbit and have you ever seen the rabbit? You touch the rabbit and take it. It's very hot. Hot as hair means fever. Dry as a bone, dryness. Red as a beet, flush. Blind as a bat, because bat has got no eyes. You know that. They send no ultrasonic waves. Blind as a bat. You got people dilated, accommodation lost. You become blind, something like this. That's October side effects. We'll ask man exam la. Hello. Anaga. Be careful. So, and now let me see whether it's a question X-ray or CT, whatever thing is there. I can hear. It looks like what, man? In the appearance pair, what problem you can have it? Which chromosome problem? It's looking like a mask. Mask. Hello. TV you would have seen, no? Mask fellow, cartoon. Hello. Mask. The eye mask. Come on.
Batman.
Mask fellow.
Batman.
Hello. I know 100% will not tell. Harlequin,
Harley Quinn.
Harlequin is a person who makes others to laugh or smile without talking. Actions they will make you to laugh. Circus, we have got circus, jokers, Joker is a Harlequin mask. He's wearing a mask only. Jokers. Hey, Harlequin mask in Kerala, have you not heard? Harlequin like a joker in circus. That fellow looks like a mask. This X-ray looks like a mask. Understand now? You see now? X-ray looks like a mask. It's a classical feature of. Hello? You have not read, Appert's anomalies. Have you heard about atrophy? Appert's, Cruzons. Hey, craniofacial dissociation. Have you heard about it? Not KP. Craniofacial problems have you studied? Appert's and Cruzons. Hey, exam question.
Sensei.
Chromosome number? I'm going to para. 10th chromosome. Okay. Can you tell me what's the difference between Appert's and Cruzons? Appert anomaly, you're telling. Both will have oxycephaly, covered skull. Because of premature closure of almost all the cranial sutures. Hey, Appert's and Cruzons are because of premature closure of all the sutures in the skull. The skull can go upwards with the oxycephaly. Understand now? This can happen in Appert's and Cruzons. How do you know it's Appert's? How do you know it's the Cruzons? With a solid air, if you tell this another 5 minutes, I will donate you. No, donate panla, Divya. What to be doing? Hello, Divya, come on. Donate panla. What we can give? Teriyada. Ida clue. Ida path solilla. Can you see this? Fingers are united, no? That's the pair syndactyly. Syndactyly in Appert's. Hello, this is exam viva question. Amma, ophthalmology don't think it's only a cataract. Ophthalmology has got so many nonsense. We will ask you. Appert's, the Cruzons. You also don't tell like this. Sir, syndactyly. You have not seen. Anaga, you have to read a lot. Come on. What's the name of the view for optic foramen? Hello? Hey, orbital X-rays and all. Have you heard about it? Of course, nobody is doing nowadays X-rays. They have got CT scan, everything is there. Agreed. But for exam purpose, you are supposed to know. We will ask you questions in exams. You know one thing, all orbital views,
All orbital views.
RPA,
RPA.
except towns. Towns view. Except towns. Just know this. Hello. Suppose they ask you, what orbital view, man? Just straight away tell PA. Don't tell AP, don't all. Your answer is what? All views of orbit in X-ray are PA except towns. Hey, KP, if I want to see superior orbital fissure to be seen, what view we are supposed to have? In the order, in the view you take. You have to order now, tell the what view? How to remember? I'll tell you. SC, remember? SC. You write SC. Superior orbital fissure Caldwell, tell me. Caldwell view. Hey, SC, sollu. Hello. IT, sollu. IT. Inferior orbital fissure towns. Inferior orbital fissure to be seen, it is towns view. Hello. MOW, sollu. KP, MOW. Mo. Adanartha maxillary sinus, sollu. Orbital floor and roof. Waters. Hey, how to remember now? How to remember now? SC, it mo. Tell me. SC, it mo. Hello. Idhukku enna artham? Nose and chin touching the X-ray plate. PA view. Imagine with this nose chin. If I would take a water, maximum what water can touch the nose and chin only. So water view, X-ray plate will touch the nose and chin. Tell that's enough. Hey, water, tell me. Water view, nose and chin touching the X-ray plate. X-ray coming from posterior to anterior. Hey, Hama. Caldwell, hello. Idhar solvanga. Assalamu alaikum. Ibar, it's all right. Apna foreign nose touching the X-ray plate, that is Caldwell. KP, exam you are sitting in the outpatient. You will tell what? When I told show you, you will tell what, man? Water. What are the things to be seen? Yes, see it, more finished. Throw it out. You have understood? No. Now tell me what is the view for optic foramen? Your answer is Rees. Rees view. Rees, R-H-E-E-S-E. Rees view. Hello. Now with the question you can answer. Hello. Mama. Exam go here. Normal size optic foramen in X-ray. Out. When you call enlarge, out. Smooth enlargement can occur where? Out. Irregular can occur where? Out. Now out. But you will understand after 1 minute you will tell. Normal size, if only one side is shown. Only one side is shown. 4 to 6, tell me. 4 to 6. Millimeter. Don't tell centimeter. No. Millimeter. Next what now? When will you call it enlarged? When will you say it's enlarged orbit foramen of optic foramen area? Your answer is what? Suppose only one side is shown, normally it only 46. If it is 7, definitely enlarged. If it is difference, 7 is there, single side alone shown. If diameter is 7, it is enlarged. Or both sides are shown. Yeah, this is 4, this is 5. 1 millimeter difference is 5, enlarged. Right in the forearm, left is 5 millimeter size, diameter, it is enlarged. Even a difference of 1 is between 2 foramens, it is enlarged. Smooth enlargement, tell me. Regular smooth. Retinoblastomas and gliomas, tell me. Irregular enlargement can occur where? Meningiomas, tell me. Meningiomas, hyperostosis. Some of the answers you are supposed to in the exams. Hello, KP? Understand? Or you follow me?
She odds down on me.
Terrific. What's the weight?
5.5. 5.5.
How
5.5 gram.
5.5 and the plunger assembly system. I am asking you the entire instrument weight. 16.5 grams. Hello. If you want to tackle in the exams, if you suppose you want to trouble you, we will ask you inch by inch questions here. What's the entire weight? 16.5. Plunger system, see, without plunger system, 5.5. If I add 7.5, again it's not 7.5. It's written as 7.5. Actually, you are adding 2 only. Already 5.5 is there. You are adding 2. It becomes 7.5. Understand now? Now 10 importantly, it's written there. Actually, it's what? We are adding 4.5. Already 5.5 is there. 10.5, that the weight is not 10.5. You are showing it at 10.5, that's all. Already 5.5 is in a plunger. Everyone will answer. Now the question starts for you. Hello. You see now here, the scale, regular scale. Now KP enough, KP gone. KP, in the rendu scale reading irukala. In the needle goes from here to here. Goes from one reading to next reading. One division it goes. You tell me how many millimeter of cornea is indented inside. Right. You are placing the instrument on that. It's going to indent the cornea. That means it's going to indent. You tell me now how many millimeter of indentation has taken place for one scale reading. You tell now, Anaya will donate 1,000 rupees. This is what my questions. Hello, Anaga, don't get depressed. You do not. There are so many fellows will be there. One of the idiots, myself. Hello, you have understood? 1/20th millimeter, tell me. That means 0.05 millimeter indentation. One scale reading pochanaga is 1/20. That means 0.05 millimeter is indenting into the cornea. Hello, hey, what is Moses effect? Moses effect. Don't know. When I do 5.5 for scale reading is 1. Then 7.5 scale reading is 3. Then 10 for scale reading is 5. Out of these 3 things, I will take only third. 5 only I will take. The remaining 2 things, what the chance, that when you do that, the cornea may mold, bend, and enter the plunger system. Stop the movement. That is less than, they have already found out, less than 4 scale readings, the cornea can bend and enter into this plunger. Movement is stopped. That's why you always take the reading from 4 onwards. She has to understand now. You have to follow. That is called Moses, that bending of the cornea. Hello. You have understood? Any doubt? Hello. Any doubt? Are you okay?
Yes, sir.
Coffee sapala. No, I will close. 4 o'clock actually. Hello, are you okay?
Yes, sir.
We can have class 24 hours also if you want. You come to Coimbatore. Okay, thank you very much for this patience.
Thank you, sir.
Hope you have learned something.
Sir.
The entire ophthalmology, it needs at least 1 week, 10 hours teaching. The entire ophthalmology, minimum 10 days. What? Glaucoma, at least full 1 day. Neuro-ophthalmology, weeks. Okay? Anaga, are you okay? Definite? Sure? Definite? Thank you, Peter. Okay, thank you very much. Okay.
Thank you, sir.
Thank you, sir. I'm literally left speechless after that session, sir.
Yes.
Still, thank you so much for that energetic and informative session. I invite Dr. Shivan NV, sir, to present a memento to Vijay Raghavan, sir, as a token of our gratitude. It was a pleasure to listen to you, sir, and imbibe the pearls of wisdom. I'm sure it was an absolutely enriching experience for all the postgraduates as well as for the rest of us. Thank you so much, sir, for spending your valuable time for us. With that, we come to the end of our CME, Oculus Season 5, Rendezvous with the Stars. Many thanks to all the delegates, the invited faculty, and all the postgraduate students for coming in large numbers and making our CME a grand success. I request everyone to rise for the national anthem.